Good morning and assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to this conference from INTERYem with a public health theme. Can I just check everybody can hear me today?
Yes, please.
That's excellent. Back, it wasn't so long ago that we had a meeting, conference such as this one. Last weekend we had a very interesting conference with a sepsis and infection control theme. It was insightful. We learned about the challenges facing countries such as Yemen. We also learned about updates and models that work in Africa and elsewhere, where lessons can be learned and adapted. We also had an interesting idea of starting a campaign such as the sepsis awareness campaign, which will be a multifaceted campaign. This is an ongoing work. And today's conference on public health will add more onto that. And we're going to aim to utilize and implement some of what we hear about today to help in this campaign and maybe even more campaigns. So just a brief introduction about INTERYem for people who join time. INTERYem is a independent, non-profitable organization. Its aim is to promote the education, training, and research related healthcare in Yemen. We want, by doing so, improve the quality the Yemeni patient gets. If you have well-trained doctors, that's the benefit directly goes back to the patient. So that's what we are trying to aim. We try to leverage on the expertise and skills we have in the UK and elsewhere, and make it an easy reach for people in Yemen. We currently have projects ongoing. One of them is a mentoring project where we have selected a number of people from Yemen that have allocated mentors from the UK, where they mentor them through their career. This is at the moment on this trial stage, and of course we are waiting for feedback. We're also doing these conferences and also the campaign for the sepsis, which is coming soon. Today's is a very interesting day. We have world-leading experts on the field of public health. We will start the day very shortly. Professor Huda Basalim will be chairing the next session. And we'll have the various chairs going through various sessions. And then we break out. So each break, which is a coffee break or a lunch break, there is a function where you can actually stay in the conference and breakout rooms for networking. And that was very useful from last conference, because there's some of the ideas about how to utilize the skills we've learned today actually were discussed in those breakout rooms. So we very encourage you to move between the breakout rooms or stay in one and see how we get on. You can ask questions on the chat, and we will answer the questions after each session. So without causing any more delays, I will introduce Dr. Huda Basalim. So she's a professor in community medicine and family health. She achieved that PhD from Malaysia, and she has a specialization in international child and young care for development from Canada. She is a member of the Council of Academic Accreditation and Quality Assurance for Higher Education. She's also Council of the University of Aden, President in Yemen, and Vice President. And she is the Organization for Women in Science for the Developing World and Chair of the Arab region. She's a consultant to several international organizations, including the WHO organization, UNICEF, USAID, and IOM, and World Bank. She's a member of many important scientific national organizations, and editor-in-chief of the Journal of Medical and Health Journal, regional. She is very passionate about health and in getting the latest idea implemented. We will turn again in front of instrumental and previous conferences, and we have excellent collaboration to build on that. So if you would like to be with it, and the floor.
Assalamu alaikum wa rahmatullahi wa barakatuh. And good morning, everyone. Can you hear me? Good morning, everyone. Okay. Welcome you all, our distinguished speaker, our esteemed attendees to this the first session of this conference, actually, the INTERYem Public Health Conference 2025, lesson from the last pandemic to the next. And I mean, thankful for Dr. Wahib for introducing me. I am Professor Huda Basalim, as he said, as a professor of community medicine and public health at the University of Eden. I am very glad and honored to be the chair of this first session, and thanks for INTERYem for this invitation. This session will have only two important presentations that I think will be very relevant to the theme of the conference, as well as to the coming session of this conference. Each presentation will have 30 minutes, and I gently requesting our attendees to write their question in the chat box during the session if they have. We can start our session, and I am very glad and honored to introduce the first speaker, Professor Abdulwahid Al-Saruri, who is a well-known professor of community health at Sana'a University. Dr. Al-Saruri was an ex-technical advisor of Yemen Field Epidemiology Training Program for many years. This program is run by the Yemen Ministry of Health, Sana'a. He has distinguished career in both quantitative and qualitative research in the field of epidemiology and public health. He is the author of many books and journal articles that have been published in peer-reviewed journal. He was also worked as consultant, principal investigator with different international organizations such as UNICEF, WHO, GIZ, World Bank, Oxfam, and Rada. Please welcome Dr. Abdul Wahid, and we are eager to hear your presentation.
Thank you very much, Dr. Huda, and good morning, all colleagues. It is just to be sure you heard me well.
Yes.
Good. So, welcome all, and it is an honor and pleasure for me to be with you in this important conference and to meet very distinguished colleagues from different parts of the world and from Yemen. I must thank first INTERYem for allowing this chance to us to meet and to discuss such important topics in a very critical situation. So just to share my screen, I'm trying to, yes. Yeah. That you are seeing my screen?
Not yet for me.
And what about now?
No.
I already shared my screen. Does
You need to
everybody
click,
see?
I think, more. We see only the title of, of the file.
Already I press and it is clear for me. Does anybody see the, I will try, or should I try it again? Please write in the chat if you are seeing my, please, are you seeing my screen or not yet? Please, are you seeing my screen?
It seems that you didn't open it.
No, I already opened it, but I stop sharing and start again to do it again. Okay, no problem. Do you see anything now?
No.
Not yet.
No.
So I will do it another time. What about now?
No.
No? It is
No.
in my computer. It is showing that it is it appeared for me, but I don't know what's happening. Is this a common problem for all, or just I am moving my slide now? Do you see any movement or no?
No at all.
Not at all. So this is the second trial. We'll do it third trial, or ask the interim to share it from their side. I will do it another
Yes, you
thing.
can share with INTERYem to.
Yeah, just do it third trial. Computer sometimes do funny things.
Yeah.
Are you bearing with me? Do you see my screen? It is in front of me, my computer, but I don't know it. Does any of the colleagues are saying it? Or...
Do you have the WhatsApp of the INTERYem or my WhatsApp you can
It is
send?
the material with them. Already I sent it to
Okay.
Dr. Mubashir. So if you couldn't do it from my side, I will ask them to share it. So is it okay now from...
Yes.
Okay.
Now, yes.
Okay. Okay,
Yes,
thank
please.
you. Sorry for this. So my talk will be concentrated about importance of the Yemen field epidemiology training programs and lessons for the next epidemic. Just to please, you can move for me. Second, yeah. The outline of my presentations, I will just touch on country background and then speak about Yemen health system crisis. I will speak about some of the key achievements for Yemen FETB despite the challenging environment. And then I will concentrate the rest of the session on speaking about the role of Yemen FTB in leading response in crisis situations, and I will go to examples in cholera and COVID. And then we'll conclude and just speak about the lesson learned. Could you please move the screen for me? Okay. I will not go in depth on country background because I know most of you know the situation in Yemen. I just want to stress that the protracted conflict and SAG is entering its second decade with claiming nearly 400,000 lives through both direct and indirect impact, and with wide economic collapse for different social services, especially health services. Next screen, please. Next slide, please. Yeah, about Yemen health system crisis, I think you all know that the public health system has been devastated by more than 10 years of the conflicts. Many health facilities are partially or fully unfunctional. Health worker salaries have not been paid on regular basis since 2016. There are several large outbreaks over the last years, shows the health system fragility, and the health challenge existed before the conflict has aggravated with the current conflict and SAG. All this put health system under great pressure. Next slide, please. And it is not surprising to speak about them and the worst humanitarian crisis in modern history, and sure that you know about all the difficulties that the health system are facing in Yemen. Next slide, please. I will go now to speak about field epidemiology training programs in general. These programs are currently operational in more than 85 countries all over the world. Next slide, please. I was trying to do it from my side so they don't bother you, but sorry about that. So these programs have been one of the most successful intervention aiming at advancing the skills of the public health workforce in field epidemiology, focusing on promoting global health security. And it shows that it's invaluable in minimizing and preventing the spread of disease and outbreaks. WHO and other organizations like Center for Disease Control and others reinforce the central roles of the FETBs in general, especially for strengthening capacities of health workforces and help greater resilience and health care response capacity. Next slide, please. Now we go to the Yemen field epidemiology training programs. It launched in 2011 with the most important aims is to reduce the major public health problems through developing EBI workforce to conduct cross-cutting integrated surveillance, detect, investigate, and respond to public health threats and outbreaks, implement EBI studies and its application to control health problems in Yemen, with the important aim to provide these data to policy makers and decision makers to use it in their decision. Next slide, please. This is our training pyramids. We have 4 tiers. Currently, 3 are functional. The advanced one, the 2 years, which was launched in 2011, as I said. The intermediate was just launched in 2020. It is 9 months, and the basic was also launched since 2017. It's 3 months. We have a fourth tier, but we doesn't start yet, about community volunteers, and this will be very short, just 1 or 2 weeks. From the advance, we have already graduated 6 cohort with 62 epidemiologists, and there is on pipelines, there is the 7th cohort, which will be graduated in the next year. For the intermediate, we have graduated 2 cohort with 47 epidemiologists, and there is another cohort on the pipeline will be graduated by next February or before. The basic has graduated 450 or more, concentrated on the surveillance officers at the district and the governorate levels. Next slide, please. Okay, this is just to show you the map of our coverage. The green is covered. As you notice, the advanced nearly covered all the governorates and southern and northern parts, except Al Ghof and Al Bayla, due to they don't have peoples who are fulfill the requirement to join the. But we hope that in the next few years we will make them joining. For the intermediate, please move to the second map. For the intermediate tier, we are concentrating in the Yemen FETB in Sana'a on the northern part, but I'm sure that our colleagues in southern governorates and they are covering also the southern governorate and eastern governorates, such as Shabu and Hadramaut and Al-Mara. But for the 15 governorates in the northern and central part of Yemen, we already covered them. For the third tier, please move to the third to the map. Okay. As we said, we graduated 450, and it is the same. We covered nearly all governorate in the northern and central part, but I'm sure that also our colleagues in southern part are covering the southern and the northern, the central, the eastern governorates. This is about the coverage in general. Next slide, please. Okay, despite all challenging, I think we managed to make important and key achievements. We succeeded in generating a pool of epidemiologists at all health system levels as much as we can, and those are working to prevent early and detect and respond to outbreak and health problems, as I will show later on. They also working hard on collecting, analyzing, and interpreting surveillance data, and they are supporting health system to take prompt action and prompt actions and take action to save lives. Next slide, please. Of our achievements, since launching Yemen, FTB resident and graduates conducted more than 700 surveillance system analyses and evaluations. They investigated more than 800 outbreaks, and they conducted more than 100 planned studies to search for specific health problems. They manage also to communicate findings at national, regional, and international platforms. We have published more than 60 peer-reviewed journal articles in well-known journals, and we have 170 oral and poster presentations presented at national and regional and global conferences in Yemen, in the region, and even at international and global level. We won the best oral presentations at 2 regional conferences and won the best poster presentations at 3 regional and global conferences. We also glad to see that we are the first Arabic countries which won the CDC award for excellence in epidemiology in 2018, and this is, I think, a great achievement and recognition of our effort in Yemen FETB. Next slide, please. If you want to read more, we have published in Eastern Mediterranean health journals full articles about Yemen field epidemiology programs as a tool for strengthening the public health workforce, and I recommend that you just see that papers. Next slide, please. Now we go to the center of our talk, which is about the role of Yemen FETB in leading the response, especially at crisis situations. And I will just concentrate in 2 important examples, the cholera outbreak or epidemic experience in Yemen. As you all know that the Yemen has the world's worst cholera outbreaks during 2016 to 2022, who were more than 2,500 million suspected cases and more than 4,000 deaths, and that affect 20 governorates out of the 23 governorates in the Yemen. Next slide, please. Our contribution in the cholera outbreaks was concentrated in 8 pillars. The first pillar was to conduct timely outbreak investigation to help rapid containment. We also assess cholera epidemic response activities in hot districts and support these districts in micro-planning for epidemic response. We also, our graduate and residents coordinate cholera response in these hot districts, and we develop cholera guidelines and treatment protocols, especially in Arabic language, so it will become available for different health workers. We also strengthen the workforce capacity, especially in surveillance and outbreak investigation, through training of different health surveillance officers in different governorates and districts in these things. And we participate in the scientific committees, command committees, and operational research. and we post regular cholera updates in our website and newsletters and in the WhatsApp groups, which form as a forum for discussion. Next slide, please. This is just example of our journal that we published in 2017 at the times of the outbreak in Yemen. The newsletters was showing that mapping of cholera and recent cholera outbreaks and updates, which we provided to all readers about the situation in Yemen, and providing them with the new updates for the situation. Next slide, please. As time is short, I guess would like to recommend you to read our papers, which we published at that times about the role of the field epidemiology in disasters and taking Yemen cholera outbreak as examples. And you are welcome to show this in your Google and Google Scholar and read more about our role during the cholera outbreak. Next slide, please. Then I will move to the experience of the COVID, and this is, I think, maybe more interested for most of you. Our role was concentrated or centered around the WHO pillars for COVID-19 preparedness and response as it comes in the operational planning guidelines published by WHO at that time, at the beginning of the epidemics. Next slide, please. So I will touch in each one of these pillars and to show what we have did. For the first pillar, I think our contributions was important to show our rules as Yemen FETB in managing this conference. And we, I think, managed to do our best during that time so we participated at the National Technical Coordinating Committee and advice on preparedness and in technical and coordinating committees, and we use Imperial College model to identify the estimated total numbers maybe infected and deaths, hospitals at critical bed demands, so we can help our ministry to be well prepared from the start. We lead also the COVID-19 risk assessment using WHO capacities review tools to understand the existing capacities in area of detection and response. And participated in simulation exercise to assess the country readiness. For the, please, next slide, please. For the second pillars, which concentrated on the risk communication, our Yemen FETB directors was the spokesman for the COVID National Technical Coordinating Committee, and we supported development of local educational materials and run COVID telephone hotline supported by WHO to receive reports and to coordinate the rapid response teams for investigation, and also to address misconceptions and provide accurate and timely information. We posted COVID-19 updates, Arabic, English scientific materials in our websites regularly, and in the newsletter and the COVID groups, which was forming a forum for discussion. For the third, next slide, please. For the third pillars, which is surveillance and rapid response and case investigation, we started working, I think, and this is one of our strengths. We started before the epidemics, and since beginning of the programs, we tried to build a well-trained workforces. And when the COVID epidemic started, we already have 40 advanced tire and more than 200 frontline tires graduates are available in different governorates to lead the response. And we also trained before 100 of surveillance officers and rapid teams on outbreak investigation. This well-trained for workforces has led the COVID response at central and peripheral levels, and even at some organizations, because our graduates are employed by different organizations like WHOs, like MSF and others. And this was instrumental in resilience of the health system and supporting disease control and surveillance system. For the fourth pillars, which about surveillance, rapid response, and case investigations. This is a fourth pillar. The same. We, after the COVID-19 was declared as a public health of emergency of international concern, we organized 4 frontline FIP training for surveillance officers and refresher training for governorate and surveillance officers. And we run 2 special COVID rapid response training for governorate rapid response team with support of Infinite. This training provide trainees with the core competencies need to respond to COVID and support health resilience, and to lead we lead also the first COVID-19 outbreak investigation in Sana'a. Next slide, please. And we published our experience for the first COVID-19 cases with high secondary infection among health workers in Sana'a capitals in the International Journal of Infectious Disease. And we are welcome to go through that paper for more details. Next slide, please. For the fourth pillars, which is concentrated on points of entries, we started also before the epidemics, early in our program life. We trained in international health regulation more than 50 officers from different point of entries, and help train them how to prevent and prepare and respond to any public health risk. So when the outbreak, the COVID started, we already have people in the ground working on, have the knowledge to, after the COVID, next slide, please. After the COVID started, we organized another refresher training for these point of entry and surveillance officers, and perform risk assessment at some of these point of entries to identify gaps and necessary needs. We trained also surveillance officers and point of entry officers on screening Yemeni returnees from China and other countries, and how to follow up arrivals for appearance of early symptoms and referring suspected case. Next slide, please. For the fifth pillars, which about national laboratories, we are in Yemen FETB support the One Health approach, and we trained many of laboratory staff. Just in advanced tier, we trained more than 50 laboratory staff, and we also coordinate with the National Center Public Health Laboratory to train some laboratorians, which is the Center for a COVID Diagnosis Center. And we both also perform risk assessment at the National Center Public Health Laboratory and branch to identify gaps and additional supplies and equipment needs. Next slide, please. For the six pillars, which is about infection, prevention, and control, we also started early in the program life from the maybe 2015 to run regular workshops in biosafety and biosecurity training for health workers and IBCS staff to ensure proper implementations of major IPC measures and to prevent disease transmission to staff and patients and visitors. After COVID, we also did a refresher training for many of these and perform also risk assessments for IBC at some of the selected health facilities to identify gaps and needs. Next slide, please. For the seventh pillar, which is about case management, our role was concentrated to develop standard operating procedures and to also provide develop Arabic guidelines for case management and also for drug and supplies and needs. We train health workers on these guidelines to be ready to deal with the situations. Next slide, please. For the eight operational, the eight pillars about operational support and logistics, we also assess logistic and procurement supplies needs using WHO capacity review tools and prepare a list of equipment supplies needed for the response. So the ministry will be ready to face and donors also to be ready to provide these. The last pillars, which is the ninth pillar. Next, please. About maintaining essential health services. As we all know that there is a drawbacks during that, and we advocate for way to counteract COVID-19 negative impacts on immunization, chronic disease treatment, and other routine health services. And we participated in long discussions with the ministry and donors how to build resilience immunization programs and way to reduce vaccination equality and strategies to target hesitancy and provide lectures. So, as I said before, as time is short, I just advise you to, next slide please, to go to our papers, which we publish in Frontiers, which is about field epidemiology training program response to COVID-19 during conflict experience from Yemen, and you will find a lot of our intervention. Now we come to nearly to the end about the conclusion, and before that, I just want to stress our role in evidence-based and knowledge sharing. We publish many papers with Infinite and others about COVID, like the role of global health development and Eastern Mediterranean in COVID and awareness and preparedness of field program and mental health impact of COVID and also non-pharmacological interventions for COVID in different journals, and we are welcome to also to review these articles. As conclusion, next slide, please. I just want to stress that our response to epidemic has been instrumental via participating in country-level coordination, planning, and monitoring, developing guidelines, standard operating procedures, and strengthening surveillance capacities and leading outbreak investigation and contact tracing, and training on case management, infection and prevention and control, and guiding risk communication and evidence-based knowledge sharing. To sum up, I think the lesson learned for the next epidemic that the resilience system can only manage emerging and re-emerging crises if we have adequate, well-trained, willing epidemiology workforce, while the impact of FTP is substantial, not in Yemen, but all over the world for the health system resilience. Recent outbreaks show that more workforce is still needed to strengthen the country's epidemiological capacity and resilience. Unfortunately, this will not happen possible without continuing support to FETBs in general and to generate a pool of epidemiologists at all health system levels. Thank you for listening, and I just wanted to leave you with this quote, which said, "It doesn't matter how slowly you go, as long as you don't stop." Thank you very much for listening. Okay, Dr. Huda, it is now to you. Okay. Maybe I lost Dr. Huda, so I can go to chat to see if there is a questions or comments that I can answers from colleagues. Yeah, I think. Thank you, Prof. Khalid. His question about do you have any updated data on number of COVID-19 cases in Yemen? I think this is a very important question. I just scan last night the WHO dashboard for COVID, and they said that it's about 12, around 12,000 cases with 2,000 deaths. But I must say this is maybe doesn't reflect the reality, especially this is also maybe from southern part more than the northern. In northern part, I think the ministry under CA and under conflicts doesn't want to cause more panic to the community, and the numbers are not officially circulated and kept at the higher level just to use for decision makers. And I wish, I hope if there is somebody from the ministry which can take over on this issue and take more. Another question I see about the funding. Yes, the funding is very crucial and important for the program, and this is one of our difficulties. At the beginning, the program was funded by Center of Disease Control, then funded by TIFNET, with some technical support from Infinite. But with the current political situations, we are in very difficult situations. Still WHO supporting the programs, especially in the training of intermediate and advanced tier. But this is, I think, one of our major challenge facing in the program and keeping the program working as we wish. Okay. Another question is criteria about selection for intermediate levels. As I said, for the advance is like postgraduates, and we have very strict qualifications, English language requirement, and we found that many of our colleagues, especially surveillance officer, doesn't have this. So we launched this intermediate with less than a requirement, less strict requirement, especially, but still he should be graduated from a health institute. He has experience in surveillance and or public health in general, and have moderate English, not like the advanced. We have that very strong asking for a TOEFL or other things. But in the intermediate, we decrease our requirement to give the chance for our colleagues, especially working in the governorate and district level. There is another question about evaluation of AFTB graduates and any database map about the active graduates. I think I will refer you to the recent publication we published about evaluation of Yemen field epidemiology training programs. We conduct an evaluation of our programs where our graduates and what things. So please go to that papers. If you write evaluation for Yemen FATB, you will find that papers, and we'll think I'll answer your questions. Another questions about currently strategies in Yemen to combat cholera pandemic now. Yes, thank you very much for this question, Dr. Khalid, also Dr. Kamal. I think Now, cholera, maybe as you heard in the news, maybe it started again, especially in summer and all the difficulties in the countries. And I think the Ministry of Health, both in Southern and Governorate and in Southern and North, are well aware for the situations. And last week we have a meeting for a scientific committee for revising the situations, especially regarding the case definitions, as many people thinking that cholera in Yemen become endemic rather than it is an epidemic. So we are, I think the ministry are in good position to follow up on these issues and trying their best despite difficult situations. Any questions from others? Sorry, Dr. Faiza.
Yeah,
Dr. Fikri,
thank you,
yes.
Dr. Abdul Wahid. I am very sorry I lost you for a while for network,
Yes.
interruption. I saw here one, question about, do you think that having FATB in Arabic will be a good idea?
We already started this experience. As I said, we have 3 tiers, and for the first one, the advance, which started in Yemen in 2011 until 2020, we just concentrated in advance. And we found that we are targeting very highly professionals who are graduated from the university. Some of them have master and PhD degrees also. But if we think this is not maybe right things at this moment, we need to go to the grassroots, to the district, to the governorate, and these doesn't have all the requirement for the advance. So we started to implement first the basic one, and we didn't ask for the English requirement, and make all materials in Arabic and translate to Arabics, and they started in Arabic. Intermediate was the middle between the advanced and that. We are asking for some language, especially if they want to present at the conferences and the global conferences, but still we mixed the language. For advanced, still we concentrated on the English curriculum. Thank you, Dr. Hadi. I think this is very important.
Thank you.
Any
Thank
more
you.
question?
Is there, yes, for our esteemed audience, is there any question more? It seems no more. Actually, a
There
rich,
is a question, I think about HR incorporated in the FATB programs, which may enhance the preparedness effort against future. But thank you, Dr. Fikr, for this. I think it is very important. And as I talk, we trained in this becomes one of the core training materials in all our courses, especially for advanced and the middle intermediate work, about the HR. And I think it is very important to be incorporated on such training and providing the skills to manage the outbreaks and pandemics. Thank you.
Thank you. Actually, this is, very informative presentation. Maybe I have some contact with the FATB, and I know the great efforts they are, exerted in their work, and the respect they have, as teachers, as resident, all of them having a good respect and recognized in the community, and this increase day by day. This is a great opportunity, Dr. Abdul Wahid, to have you with us to illuminate in such a role. And we hope to see more success for, FATB in the future. Thank you.
Thank you. Thank you very much. Thank you all.
And next, I have the pleasure also to introduce Dr. Ahmed Al-Haidari. And for Dr. Ahmed, I am especially glad to introduce him, as he was one of my students. Actually, I was a member of the supervision committee of his PhD in Malaysia. He is a hard worker person. Dr. Al-Haidari served as the monitoring and evaluation officer at the WHO in Yemen, bringing over 18 years of experience in health system strengthening, project evaluation, and operational research. Dr. Ahmed holds PhD in Health Services Management from the University Putra, Malaysia, and he adopted a data-driven approach utilizing advanced statistical analysis to interpret and assess the effectiveness of WHO intervention. His expertise includes advanced data analysis, impact assessment, systematic reviews, and designing evaluation tools while systematically testing their validity and reliability. Welcome, Dr. Ahmed, with us in this conference. Please, you can start.
Assalamu alaikum and good morning, everyone. My name is Ahmed Al Haydari. First of all, many thanks for Dr. Huda to present me and to attend this presentation, to attend this conference. And many thanks for Dr. Wahib to invite me to this conference. And many thanks for all our colleges who attended this meeting. Really, I am happy today because it is the first participation in a conference to present one of my studies or my articles. Firstly, my articles and my studies, it is focused on the studies from the operational research zone. It is not from the epidemiological zone. Today, I will be presenting you with the impact of the COVID pandemic on the continuity of health services at public hospitals in Yemen. The study, it is a retrospective comparative study. I will show you the studies and the methodology and results and what lesson learned from this articles. Before we go into the presentation slides, I would like to briefly walk you through the outline contents. Firstly, I will go through the background that included the context and situation in Yemen, and also included the problem statement, justification, benefits, and next research questions, objectives, methodology that applied in these articles, and result and discussion, that finding, conclusion, limitation, and finally, according to the result and discussion and the situation during the first attack wave, I will show you some lesson learned from this event. Before I go to the studies, I will highlight on some challenges, and I will show you the situation of health system and the challenges of health systems during the first wave of COVID, during the first 3 months of attack of COVID, the health system in Yemen and Yemen. As you know, as Dr. Abdul Wahid Sururi, he said, the first cases detected in April. So the flow of the COVID started from the April in Yemen. Firstly, there was a weakness health system. This health system in Yemen weakness due to the prolonged conflict and economical collapse due to the conflict. So the health systems was in these times exhausted and unprepared. So the facilities lack and shortage to a lot of essential equipment and supplies to deliver even basic and essential health services. Second thing, it is noted during the COVID, some, not all the staff, but some of staff, they are refusing to work, and they are unwilling to go to the hospitals due to unpaid salaries. As you know, the salaries cut from the many years previous the COVID, and also they didn't feel with social protection. Particularly if they get the infection, and maybe they will become ill or died, and see they will fried of their families what will happen after the ill or died. There is because there is no social protection for the staff. The next one, public avoidance hospitals. It is noted a lot of people's avoidance the hospitals due to the fear of infection, widespread of rumors and misinformation, and also absence of public health awareness campaigns that increase the trust of the people and push the people to going to the hospitals for the routine care or for the non-COVID care. Also, limited local authority engagement. The local authority not taken in the. I spoke here about the first wave. The limited the authority, the local authority, not take seriously the measurements against the COVID. So there was noted failure to implement lockdowns. There is low awareness campaigns, and there is spread rumors and decline public trust. Finally, also there is noted fragmented response, fragmented in decision of in health decision, and there is was poor coordination, particularly in the first wave. In the first wave, it is noted the poor coordination and fragmented response. This overlapping responsibility weakened coordination, delay decision, and lead to inconsistent action because in this time the support of health systems it is sharing between the local authority and non organizations and donors who support the local authority to maintain the health services provision. So it is noted fragmented in health decision. I will go to the problem statement, justification, and benefit. The COVID pandemic triggered global crisis that severe distributed health systems. This limiting their ability to deliver both routine and emergency care. The pandemic response redirected and consumed and diverted resources, and it shifted priorities, often reducing access to essential services. In many settings, public perceptions and the people see the hospitals, it is a high risk area, high risk regions, leading to decline and decrease of non-COVID services. In Yemen, these challenges were cleared and intensified by a fragile health system already weakened due to the long conflict of the war, and also due to the economical collapse, and due to also the absence of global adopted measures such as lockdowns. However, health authorities in these times, the health authorities lacked comprehensive and evidence-based about the essential and the non-COVID health services. So we are in the WHO noted the decline and the decrease in the services that arised from the hospitals across all Yemen. Therefore, this knowledge gap, limit their ability to plan effective response and balance between pandemic control and continuity of the non-COVID services provision. So, addressing this gap is critically for ensuring continuity of other services provision and drawing lessons for further health crisis. Accordingly to the previous research questions arise, these questions: what is the impact? What is the COVID? What is the impact? And what is the effect of the COVID pandemic on the continuity of health services provision in public health hospitals in Yemen during the COVID crisis? Here we selected the public hospitals because the public hospitals, it is easily to reach out to the data, and they already sent to us the data. these questions, we developed a research objectives. The research objective was to evaluate the impact and the effect of the COVID pandemic on the continuity of health services provision in Yemen. To achieve this, objectives, we go through three paths. The first one describing, the second one comparing, the last one evaluating and assessing the statistically significant of its changes. Now I will go to the methodology that adopted for this study. Sorry. Go ahead, Dr. Aur.
Yes, please.
Okay. Research methodology. We adopted a rigor and strong research methodology to avoid a lot of bias that threat the external and internal validity that arises due to the some weakness in some research methodology items. For the external validity for the study population, our study population was all public hospitals that provide the secondary and tertiary health services. And the time frame was, I will show you here the time frame. We use the 3 months, April, May, and June, and compare. And also we selected the pre-endemic months, June and February and March. And we compare this month, the 6 months, with the previous year, 2019 year, to see what the changes that happens and that created by the COVID events. Study design, we applied a retrospective comparative quasi-experimental study that apply this design applied to assess change in services utilization. Really, this design, it is a non-randomization study, and non-randomization study, as you know, it has created a lot of bias. For example, that threat the internal validity, for example, selection bias and confounding bias that classified as high threat for the outcome and for the findings. But we adopted a rigorous strategy to minimize and to relieve the effect of this bias on the internal validity and also in the external validity. For the sample size, we selected 127 hospitals. These hospitals, it is represent 86% of the general and referral hospitals, and represent 20% of the maternal hospital, and represent 75% of psychological hospital, and represent also 40% of intra-district and district hospital. This hospital already that provide the services, the selected services under our study. Also, we applied and we adopted a selection criteria. We selected the hospital that are fully functioning. They are reporting through the DHIS system, and they have also complete data in the health and the DHIS system. Another hospitals, we excluding them because it is not meet the selection criteria of the study. Our variables in the study, it is for the independent variables was time periods. We depend on the time period, and dependent variables, we selected the consultations or patient visit to the hospitals, surgeries, deliveries, cesarean section, and Binta third dose. Why we selected this services? Because these services, it is the main services that we are in the WHO used them to assess and to evaluate the performance of the hospitals. The data sources, we use secondary data. This data was collected through manually through the hospital records by the M&A trained and qualified M&A officers, and also we executed electronically from the DHIS2. data analysis. In the data analysis, we use we use the SPSS version 23, and also we use the Excel 2016 that help us to draw the graphics, and the statistical significance was at probability value less than 0.05 with a confidence interval 95 percentage of confidence interval. We go in analysis through three levels. The first level was univariate analysis. This univariate analysis describe the number of services, and we use the means, standard deviation, number of health services to show us and to give us the and to show us the services provision during the 2 years. Also, the second level, it is bivariate analysis. And in this bivariate analysis, it is compare, and we use graphics to showing the trend lines, and also we use correlation coefficient to assess the association between the two condition time versus usage, and to assess the differences and discrepancies between the during COVID year and the previous year. Finally, the third level, we use the multivariate analysis. We use GE regression model to assess the significant of differences and discrepancies. It is statistically significant or not. We use this regression model. It is advanced model, and also it is not affected with the normality, and it is applicable with longitudinal studies. Really, due to the design, our design in this study, we face a lot of bias. But we adopted in this study strategies and guidelines to enhance study quality. We adopted a strategy to enhance the external validity by minimize the biases that affect the external validity in the study. For example, I will give you here some examples for this bias, population bias and temporal bias. And also we adopted a strategy to enhance the internal validity that minimize effect of the some biases. I will here can mention some biases, for example, the selection bias, confounding bias, and Hawthorne effect. Some of this bias, it is have low effect, and some of this bias have high effect. We really focus on the high effect bias. Also, we are going through the trend statement. This trend statement has 22 items. This trend statement, it is used to assess the quality of study, and we found 18. They found 18 items out of 22 items that meet the statement. This is mean it is 82% of compliance, indicated that it is strong and it is acceptable. This means the study demonstrates high level of methodology transparency and rigor consistent with the trend statement. For the ethical approval consideration, we obtained from the Health Ministry approval before we going to the study. And also the study, it is retrospective and it is secondary data. So we couldn't need to use the names of the patient, and no need to take consultant approval from the patient. Now we will go to the result and discussion. Firstly, I will go to the univariate analysis. As you see here, I put here in the tables for the 2 years, in the 2019 and 2020. This for the 2 years that we uses in our studies. The 2020, it is the year of the COVID, and the 2019, it is a previous year that we use this year to make comparison and to assess if there is any discrepancies and assess if there is any effect of the COVID. You can see here the number of the number of consultation or the number of patient visited to the selected hospitals. It is not affected during the January and February and also March, but in the April started decline. See, in the April there was 583,000 of patients who visited the hospital. Well, in 2020 there was 528,000 of patients. In May there is high decline. In May there was 459 health patient visit to the hospitals. Well, in the COVID year was 353. There is huge decline between the 2 years, and also the June similar. Also, if we see the surgeries, it is similar, the consultation, and also for the Binta third dose also it is similar. But if we go to the deliveries and cesarean section, we don't found any discrepancies, and we found that and during the COVID, the services, it is increases as a normal increases due to the increase in the population. If you see here in the April, this hospitals received 11,000 patients. Well, during the COVID, they received 11,400. It is more. And also in May, similar, more. And also in June, similar. It is more. It is less, but it is not significantly. Similar also for the cesarean section, we found that there is no effect in the number of the patient between the year of COVID and the previous year. I here draw for clarification some percentage to discrepancies between 2019 and 2020 and 2019. 2020 minus 2019. If you see here, all of the months, January, February, March, it is with the plus, with more patient in 2020. But during the COVID, we see it is with minus. This is the minus, and this is the discrepancies. This is for the consultation, also similar for the surgeries, and also similar for the Binta third dose or vaccinated children. But for the cesarean section and deliveries, we found it is there is no minus here. On all the values, it is no minus, even in April, May, June. Here, I will show you the graphs. This graphs, it is give us more clarification of the impact of COVID on the services utilization or the routine services utilization. For the number of the patient who visited the health facilities, the number of consultation, if you see, this is the year of during the COVID. See that during the January, February, March, there is no decline in the health services, and it is more than the previous year. But from the April started, it shifted the trends. Here you see this is one. It is in the April. It is more in 2019, and also in the during the May and during the June. Also, if you see, it is similar for the surgeries and also for the Binta third dose. But if you see the deliveries, it does not affect in the deliveries. This is the month of COVID period. And also it is the month of the COVID period. We see there is no discrepancies. Now we go to assess these discrepancies and these differences. It is significant, statistically significant. We use the GE regression model. we see for the April and May and June for the consultation, for the surgeries, and for the Benta third dose, there is significant. The statistically it is significant, and the p value it is less than 0.05, and also for the Benta dose similar. Now we can go to the other two surfaces. For the deliveries and cesarean section, we found there is no effect. You see here the April and May and June, the significant p value it is more than 0.05. So there is no statistically significant differences between the 2 years, and also similarly for the cesarean section. According to our findings and discussions, we found that 5 main key points. First point, the COVID pandemic led to substantially decline in health services utilization that we noted in particularly noted in for the consultation, surgery, immunization. But however, some services still stable, such as deliveries and cesarean section. There is no change, and likely because these services maybe it is urgent and non-deferrable naturally. The next points for the that we found or that we can highlight it here. This finding align with several other studies conducted to evaluate the impact of COVID in health services in regional and global countries. But we found in Nepal, one study in Nepal, this study reported that the decline, it is not significantly, the decline was significantly in all health services, including the maternal health services, including child health birth, and including the cesarean section. And this is different from our study. The next point for the key point, distribution and services utilization may have been influenced by fear of infection for both for the staff, for the health staff, and also for the patient, and shortage of health staff, and also allocation of available resources to face and to control the COVID. And the last key point, despite the challenges, the relative stability of some services reflect system resilience and highlight the need to protect essential health services delivery during health emergency. Our conclusion, the impact of COVID in continuity health services was clear and distinct, where the study revealed and discovered that the number of consultation and surgeries and the number of vaccinated children has been declined and affected with the COVID, and statistically was significant. However, some of health services still stable, such as deliveries and cesarean sections during the COVID, comparing previous year. A study limitation. Due to our study design and due to the due to the limitation of time, we have some study limitation. The first one, the study use successive time related. It is not use barrel control group, and this maybe create some bias. And we already created and adopted strategy to minimize and to minimize this bias and enhance the validity, external or internal validity. Also, for the study, we didn't also take in our study a staff shortage and escape supply disruptions and hospital type in our study. So maybe this it is limited for our study, and also the findings are limited The findings are limited to public hospitals and excluded private hospitals. As I said before, we haven't data for the private hospital, and it is not available with us. And the last limitation, the 3 months of study period, maybe it is relatively short, but it was necessary because in this time we urgently need evidence data and evidence base to see the impact of COVID on the services utilization and other services utilization. Lessons learned. We have 5 lessons learned. The first lessons learned, the COVID revealed and discovered the weak of the infrastructures of health systems, particularly in Yemen, and limited resources that hinder crisis response, highlighting the need of strength, system capacity, and readiness. Also, the unwillings and refusing of some staff to work during the COVID. It is very important that should be the local authority taken in consideration and solve these problems. And also avoidance the hospitals and the public see and the patient see the hospital, it is risk zone. This is also main problems, and this is need a clear health message and increase awareness and community engagement to reduce this fear and to face the misinformation and rumors. Also, the finding highlighted that we need pandemic preparedness and response strategy, strong preparedness and pandemic strategy. It is very important, particularly for during crisis, and need faster action to elevate the impact or the effect of any crisis. Also, the main lessons learned, also there is fear and many patients continue to seek, but many patients continue to seek some essential care. This highlighted the importance of maintaining access to critical and necessary health services during the health emergency. And thank you for you, and I am sorry for longed the presentation. It is up to you, Doctora. Over to you, Doctora. Doctora.
Thank you.
Yeah, Doctor. Okay, thank you.
Yes, many thanks, Dr. Ahmed, for this nice presentation. I saw many interaction here in the chat. We can start with the question from Dr. Abdul Wahid Al-Saruri, who wondering whether the difference seen between 2019 and 2020 is significant because measure the things in the Ramadan and Eid season, which usually Yemeni people not go to hospital except for emergency. Do you think this, how you can answer this,
Yes, many thanks, Dr. Abdul Wahid Saruri, Prof. Dr. Abdul Wahid Saruri. Yes, this is noted in our data in the WHO during from April to June. There is decline in the health services provision and the hospital, and decline seeking of patient to the services due to the Ramadan and after Ramadan. But we here use the similar months in the previous year in 2019 to compare between this month and see the discrepancies. It is due to the COVID or not due to other factors. Okay, Dr. Abdul Wahid, or thank you.
Okay. Another question from Amira. After thanking you, she said that based on your experience and position with WHO, what do you suggest to improve using evidence-based data in health policy?
Yes, this is we adopted a rigor strategy to maintain the data inequality. We take the data from the two sources, from the DHIS2, and our college's M&A officer collected from the health facilities manually from the records, and we made triangulation between the two sources. If we found any discrepancies, we contacted by phone to the hospitals to assess any correct from this numbering. So we adopted clear and rigorous data quality to ensure the data quality of our data. Thank you. It's okay. The next question.
Yes, from Dr. Muhammad, he said that in the beginning of your presentation, you mentioned that the public do avoid hospital for different reasons. What have the hospital did to portray that perception? I don't know, that perception, and have they started working on any solution to this issue? He's speaking about the the perception of people toward the hospitals.
Yeah, perception, it is noted during the COVID that a lot of patients, they were see the hospital, it is a risk zone, particularly when I said rumors about the Kuwait hospital, this rumors spread everywhere, and the patient started to avoid the hospitals, and the number that you see in our findings, this number reflect almost of them reflect the emergency cases that visit the hospital during this period. Really, during this period, there is fear, and a lot of patients avoid going to the hospitals due to fear of get the infection or get the disease. Thank you. I don't know it
Okay.
is okay or some okay.
Yeah. There is one comment and question from Dr. Julian. Actually, this is a feedback that the trend that you provided is almost similar elsewhere. And he asking about the publication of this data and what proportion of healthcare is provided by public versus private hospitals in Yemen. I think in general he is asking.
Yes, I think, as you know, Dr. Huda, and our colleges in Yemen, the private hospitals, they didn't send the data to the health ministry, and our mainly sources, it is health ministry, so we couldn't reach out this data, so we couldn't include the private hospitals in Yemen. The percentage or the proportion, really, we don't exactly the number. Maybe our colleges from the Yemen here in the conference, in this meeting, maybe he have or anyone from the health ministry have exactly proportion or a percentage between the public and the private. But for us, for the WHO, we didn't have. And also the WHO, as you know, we are working through the public hospitals only. And this study, it was very urgent, and it is very necessary to we do it in a faster way to see the impact of the COVID and the other health services. Thank you.
We have noticed that we are behind time. Okay, I agree with that. Just maybe the last question, that the what strategies can be implemented to maintain access to essential health services during future emergency if happen?
I think this is main questions, and it is very important questions. This should be going to the local authority to benefit from the lessons learned from this events, and to arrange and good preparedness for the future. Really, during the first wave of the COVID, there was this misarrangement. So there is a lot of patient COVID. There is no triage in front of the all hospitals, to filter the patient who is COVID and send them to the centers of the COVID, and to filter the non-COVID, to provide the care, and also the low awareness and seriously of the local authority. I think this all lessons learned. The local authority should be taken in consideration, and it is benefit for the next events. Thank you.
Thank you, Dr. Ahmed. I can conclude the session for both presentation. We learned a lot from these presentations about the response during any pandemic, if happened, of course. First, the experience of FATB in Yemen and the great work they are doing, and also the lesson learned from Dr. Ahmed in this presentation that I think will inform the ongoing preparedness and response for any pandemic. Thank you all for your presence, and see you after the break. So now we have a break. Thank you all. Bye-bye.
Hi everyone, I'm Dr. Mohammed Fadeh. I'll be chairing the next session. I'm sorry we had to cut down the break just because how we're running out of time at the moment. So I will just start. If somebody just joins in later, it should be okay. You can always catch up later with the questions. So essentially, the next session would mainly be again still focusing on the effects and different sort of problems that Yemen faced and how Yemen coped with all of that. And we'll briefly touch upon a topic other than the COVID as well, a bit of neglected tropical diseases and a bit about how the legal and political implications are during such pandemics. So I'll start by, first of all, introducing my next speaker. That would be Dr. INTERYem Babrik. I'm pleasure to introduce you guys to her. She is a lecturer in global and international public health at the University of Leeds, UK. She has over 2 decades of experience in teaching, research, and consultancy across low, middle income countries. She is a medical doctor with an MSc and PhD in global health from Leeds. She's also a fellow of Higher Education Academy. And she leads the international master's program as well. Her expertise are within the maternal and child health, non-communicable diseases, and health system research. um, and especially in the conflict setting. She has led different studies funded by UNICEF, CARE, and the Dutch Embassy as well. She is a published author and an award-winning educator, and she'll be talking to us today about challenges and opportunities for COVID-19 surveillance in the fragile health system, armed conflict, and humanitarian crisis, the case of Yemen. Dr. Mariam Babur.
Thank you, Dr. Muhammad, for the introduction, and thanks everybody for taking the time to attend the conference and exchange experience. First of all, do you hear me okay? Okay, great. So I think the order of the presentation aligns very well with the previous speaker, which I'm going to highlight most of the problems, why we do have a lot of problems in terms of access to health services, but also the rumor and the other things that it was mentioned in the previous two presentations. Do you see my screen? Dr. Mohammed, do you see the screen? Okay.
Yes, I can see the screen. It's not in the presentation mode, but I can see the screen.
Okay, thank you. In this presentation, I'm going to take the scenario of Yemen by maybe reminding everybody with those pictures that we have seen. It was scary, it was unclear, people were afraid because we used to listen to the news coming from the United States, from the UK, that people are dying in thousands. We had this picture earlier in the COVID. This is how many people being buried, and at the same time, we didn't have a clear
Dr. Mariam, just
Yes.
to pause you for a second, it's not in the presentation mode. It is still like a slide. It's not in the slideshow mode.
Oh, thank you. Thanks for. Is that better?
It probably is still not. I think you might have to share your screen, a full screen, rather than just the presentation.
Okay. Just 1 second. I haven't used Zoom for years. We get used
Imagine.
to. Yes. Entire screen.
Just because I think when you go to presentation mode, it doesn't show us the presentation. It just keeps on showing us the screen of your PowerPoint with all the slides.
Just 1 second. So Windows.
I feel someone from admin team can help us.
That's a shame. It's a shame. No, it's Windows. Okay. Do you see the screen now?
Yes, now it is.
Okay, thank you. That's better. Okay. So this is some of the picture that we had earlier during COVID. This is how many people were buried in one day in 2020. This is the people who were waiting outside the hospital, waiting for diagnosis or having a patient inside. This is the picture from one of the hospitals in Taiz, where patients of COVID were outside the building and people were wondering, are they gonna die? What's gonna happen for them? And this was the capacity inside the hospital. So definitely Yemen, like many other countries, including the high income countries, were not ready for COVID. But as was mentioned in the previous presentation, there was a lot of admission in cases into hospital. People were not sure, is that COVID, is that not COVID? We also had a large number of cases being reported among healthcare workers, and I would take this moment to remember one of the most important colleagues that we had in Sana'a who passed away. It was actually not one, two of them were specialized in a very rare specialty that passed away because of COVID, because of lack of preparedness, but also the unclarity of what is the protocol. So due to that, we ran a qualitative study, and this study, we actually wanted to meet the expert, people who are in charge of reporting and diagnosing and providing data about the number of cases of COVID. And you are clear that in any epidemic, we can't really identify the way forward if we don't know, if we don't have a good surveillance system. So the aim of this study was to investigate how already the surveillance system in Yemen to identify and report cases of COVID, and also report this to high level so we can get the right help on the right time. So we aim to identify what is the level of preparedness, what are the challenges, what are the possibility of intervention from the point of view of people who are in charge of that service. So what we did is we run an in-depth interviews with senior colleagues, either in the south and the north. All of them, they had to deal with COVID-19 surveillance during 2021. And our inclusion criteria included several people at the decision-making level, people who collect the data, people who identify the cases, people who diagnose cases in lab. And we did this study online to identify their perspective on how already the health system in Yemen and what's the best way forward. And here I'm going to use the WHO framework, which is a framework for colleagues who are not familiar with these. In case of surveillance, in order to have an effective surveillance, you would have to have 5 essential components of any surveillance system. So we were exploring how already the system in Yemen, or what's the current situation in Yemen during the COVID-19 pandemic against those 5 components. So the most important component is active case findings, when you go to the community and identify cases of COVID, and which is a key issue if you want to eradicate or control any infectious disease. Then community surveillance, when you get the help of the community for them to report to you, especially when the number of cases are increased. And by the way, community surveillance is one of the effective measures that's being used in countries that managed to control the COVID-19 within the peak of the pandemic. And then the third component is monitoring and suspecting cases that it might be a case, but it might not be a case, especially when the disease is new and you don't have like a clear 100% accurate diagnostic test. So these are the 3 essential components, but you can't do that without a lab testing data. So sometimes people don't report to the health centers, but they go and do the test themselves, and they pay for that service, or they do the test in pharmacy or at home. Do we have any data that will tell us how many people have been tested, how many are positive, how many are negative? And then the modeling and the zero prevalence data, which not necessarily that everybody will have COVID, who had COVID, would have a symptoms and go and report and do the testing. So sometimes it's very essential in case of epidemic that you go and take representative sample of the population and see how many of them have had the antibiotic or the antigen, which suspect they had the problem. So this is the World Health Organization framework, which we would recommend the surveillance health system to use the 5 components. So our findings, I'm going to talk about each of those 5 components in terms of preparedness. Was it there? Was it not there? What are the challenges and what are the opportunities based on the people in charge opinion? So in terms of preparedness, people didn't, none of the participants has referred to using modeling or mortality study at the time of the data collection. However, Dr. Huda Basalim have also later in the pandemic stage have done a mortality study, which she is going to explain to us following this presentation. There was also a study that has been done by the World Health Organization in one of the city, Aden, which Aden at that stage reported low number of cases, and it proved that yes, COVID was there, but maybe the symptoms was not clear, or maybe as the previous presenter also identified, people were afraid to go to the hospital or treated, or they say, Allah, it will be okay, we will manage. So the reporting of the cases was much lower than what the the seroprevalence study have identified. In terms of preparedness, the good thing that Yemen had rapid response team, which was established in 2017. And this rapid response team are people who are trained to identify cases in case of emergency, in case of epidemic. And this is, they were already in place since 2017. But imagine across the country, we had only 333 people, which definitely cannot cover the entire country. The role of the rapid response team is to do the active surveillance. You go and identify the cases in the community, or if a patient has been identified and discharged, you go and trace cases among contacts and so on. So one of the participants said the role of the rapid response team, they were very exhausted, working day and night, but definitely they cannot identify the cases across the country. In terms of the community surveillance, there was Yemen, among many other low middle income countries, were really excellent in using the hotline, community hotline. Some of the NGOs, not some, I mean, very good NGOs, very good initiative have started both in the south and the north, started to receive calls from people. If you are suspecting case of COVID or your relative might have COVID, you can call this hotline. A lot of data being identified within those NGOs and the initiative. The problem was this data was not reported somewhere. So at the country level, we know how many calls were received, what was the response, and also the people who are responding to the calls. They were actually volunteers. Many of them, they haven't received extensive training, but many NGOs took the initiative to use the World Health Organization training, which was available online, and train those people to be able to provide guidance on where to go and what you could do. But there was a lot of misinformation being given to the patient through this, which is, everybody can imagine that Yemen is not the only case. Also, we had a lot of misinformation being transferred to social media across all the regions, including high-income countries like UK and the United States. In terms of active case findings, both active and passive surveillance were used, but the contact tracing, beyond contact tracing, there was no further initiative for active surveillance, which I'm going to highlight later on some of the barriers that the Yemen faced, which hindered the proper surveillance. In terms of lab testing data, lab testing was really very problematic across the world, but poor income countries suffered the most, and Yemen also suffered the most, because many of the lab technicians, first, we didn't know what's the test. When we knew the test, it was expensive. When the test was provided for low middle income countries, it was not equally distributed across the country, but also we had limited number of labs where it had people who are trained to do virology testing. In many low middle income countries, including Yemen, we are good in testing bacterial infection, do culture, do parasitic investigation, those kind of things. But virology was not something that Yemen lab technicians were well prepared to do this. One good thing about Yemen also, it had the electronic early warning system, which was in place before, but there was no sufficient time during the pandemic, and I'm talking about the first and half year. It was not modified for COVID surveillance. So one important lesson is to adapt that system to be able to catch the surveillance of COVID-19 later on. And I can see that Dr. Fikri is here, and he maybe can explore more about the electronic integrated disease early warning system at any stage. In terms of the challenges, of course, Yemen had conflict, which was already affecting the health services in general. Then COVID came at the top of that. The whole world was struggling, and Yemen struggled the most. And most of the important things is due to the conflict and poor coordination between the south and the north, things were not equitably distributed across the country. So, for example, when the vaccine was provided or when the data was collected, the north had little number of cases being reported. The south was much better in reporting cases, but you can't really identify a data at the country level. The coordination between policymakers remain a problem, and I really wish this conflict is going to end soon so we can have at the country level a clear data, not only about COVID, about so many other problems. The other challenge, which was very important, is poor community engagement with the rapid response team. The rapid response team will go to the community and ask, have you got any person who had this? Or sometimes they are clear, this is a COVID case, but can we examine people who are relatives? But people were afraid. Many of them, they were not engaged because of course, there was some poor management of the cases when the police was sent in Taiz, for example, to catch a case of COVID. That was the early stage of the pandemic, and then people thought, oh, if you've got COVID, then you're gonna die, so it's better to die at your home rather than you die in the hospital. Also, pictures were coming from the hospitals where it's busy, people don't have enough spaces, so what is the point for us to be going to the hospital? So there was a lot of remorse and exaggerated or increased more because of the poor management at the beginning. And I'm not here criticizing the doctors and the nurses. It was everywhere, including the UK. So I think one important lesson we learn is, I think in the next pandemic is much better to restrict getting picture from inside hospitals to avoid such a problem later on. Of course, unsustainability, economic climate, weak community awareness was also a problem. People get their information from social media, they get their information from different countries. Copy and paste was everywhere on the social media, which create a lot of challenge for people to report the data, to treat the cases, or also to accept the admission of patient. In terms of the rapid response team, as I said earlier, there were few people, but also suddenly you might be asked to go and identify cases. Many of them, they felt they are not adequately trained. They didn't know what they are doing. They go and ask for COVID cases. They have a list of symptoms to identify. That sometimes they don't have the test. Sometimes they would ask people to pay for the test, which is all shared by other poor income countries. So Yemen is not an exception. As was mentioned in the previous presentation, there was already reduced health services accessibility when 50% of the health services were destroyed or not functioning. So that COVID added more to this, the problem. So people felt, well, we don't have a hospital here, let's die at home, and so on. But also insufficient healthcare workforce. Because as you know, because of the war, because of the no salaries provided to people, many colleagues have decided to go and do their services somewhere outside Yemen. So when COVID came, there was already a large proportion of doctors to patient ratio was already disproportionate. So when suddenly the large number of patients has increased, that also added to the problem. There was also shortage of the PCR machine, reagent, swab, rapid diagnostic test, as I mentioned earlier. The rapid response team and the surveillance system also have identified there was only few vehicles that they could use in order to go and do community surveillance. So some of them they had to use public transportation. They pay for the public transportation themselves, which when they don't have salary, it is very hard. It is very hard. The logistics also was a problem, the medical supply, and the last challenge I wanted to identify is actually the denial of COVID-19 cases. The misinformation result into underreporting of cases. So, for example, in the north, it was a policymaker's decision to not to report COVID-19 cases. As I said earlier, it was much better in the south than the north. But also, people they don't report cases even if they had because of poverty. For example, I had a lot of information from people saying, "Well, I can't feed my kids. So, do you want me to pay this amount of money to know whether I have COVID or not? I'm gonna die anyway, whether it's from during birth, childbirth, or COVID, or anything else." So that was a big challenge for the surveillance team. In terms of the opportunities, conflict resolution is being identified as it is very important if we have good management of this conflict, if we can strengthen the governance, if we can identify comprehensive community health education campaign using the radio is being used very well, especially in Hadramaut, in the south, and some areas also in Taiz. That seems to be very effective because people listen to the radio very well. Social media, so Ministry of Health and Health Initiative and NGOs should use the social media for raising community awareness. Building the capacity of rapid response team was clearly essential for the next pandemic. Of course, people they need their salary in order to be able to provide the service. We also identified that it was very effective by many NGOs that training community healthcare workers seems to be very effective. I'm sure everybody here knows that in case of conflict, providing healthcare services through community healthcare worker is a key issue, whether we talk about family planning method or maternal service or home delivery or whatever vaccination. And it is also important in case of COVID-19 or any pandemic. All participants also said the priority should be through primary healthcare service regeneration operating rather than the private sector. And as I mentioned earlier, the electronic system for keeping the data, it was important to be activated. People also suggested that mobile laboratory in rural area was very effective. So instead of the rapid response team to travel to the rural area, why don't we have a mobile lab that could stay in the underserved population and rural area and accept the cases there? It was essential. It was important to identify protocol for rapid diagnostic test and providing transportation for people who would go and do active surveillance. To summarize what I said earlier, this side of the diagram showing the challenges, and the challenges is the ongoing conflict, the poor community adherence. Rapid response team, their number was insufficient. They also needed proper training, inadequate health system, insufficient laboratory diagnostic test. The transportation was definitely a barrier. Denial of the existence of COVID cases, the misinformation, all those are the problems. What people suggested to overcome those problems, of course, conflict resolution, improve the governance, establish national community health education campaign, building the capacity of rapid response team, utilize primary health care. Everybody emphasized that. It should be close to the people, strengthening the laboratory capacity in term of examining or identifying viral infection, and of course provide good transportation, because as you know, Yemen has a very difficult geographical distribution. So 4x4 vehicles was mainly recommended for the next pandemic. I'm not going to repeat the recommendation again, but this was the study that we ran earlier. We try to use the information and the data to gather help and support for Yemen by identifying those gaps. However, I should say our study has limitations. First, we were not able to identify, to include people from different age, gender, geographical representation, because we were in the UK trying to give the information and feedback to people who are making decisions at the global health. So maybe if any of the participants or any of the colleagues wanted to take it forward, we would recommend that we include different age group, different gender, try to include more governorate, because not all the governorate has been included in our study. Some of them, especially in the north, they were afraid to talk about surveillance. It was very sensitive topic. We also would say, well, we would also recommend that people take the population perspective, because we didn't include the population perspective. We were just listening to people who are responsible for the surveillance. And we, of course, use snowballing sampling based on our network, which might have brought selective bias in these findings. So that's all what I wanted to say about this study. There is a lot that we can learn from the data there. And I wish I didn't exceed the time, Dr. Mohammed.
Thank you so much. No, you haven't. I think you've been spot on. And really, I could see the personal effect all of this COVID had on all of us, to be honest. I can all relate to all of this. Must have been very emotional. I'm just looking for any question in the chat. There's none so far. So maybe I just want to ask you myself, what did you think? I mean, there were so many factors, very frustrating, some of them. So which one most affected you the most? One of the challenges that you think was the most problematic?
I think if we want to make it COVID specific, I would say the misinformation. Um, and this is, as I said earlier, it's very similar to many low middle income countries. Egypt, for example, is much better than Yemen in terms of education, accessibility to health service. But you can see exactly the same pictures that people are, laying on the road. There was no capacity. But the difference is in Yemen, the Yemeni people would say, no, we are not going to the hospital. Allah, leave it to God. He is going to decide what we wanted to do. But in the Egyptian people, they will over analyzing and over testing. And this is exactly within the same region. So I think because people in Yemen were tired, exhausted, there was poverty, there was malnutrition, infection, so many problems, they said, okay, leave it to God. Whether I'm going to die from this reason or that reason, that is fine. But I can see the frustration from people who are responsible for gathering the data. When you, as a surveillance officer, are not able to provide data, that is a shame. But you can't do that when people deny they have a problem. And maybe I would remind, it's very emotional to remember this. One of our colleagues, I referred to him earlier, Dr. Ubaid, he is specialized in neurology, neurosurgery. It's very rare specialty. He was the deputy head of the Al Jamhuri Hospital. We studied together, and it was a shame that he knew he had COVID, but he was not sure if he goes to the hospital, he's going to go worse, and he ended by losing his life. So that as a typical example of an exhausted Yemeni person who is highly educated knows we all didn't know about the disease. I don't think anybody can claim that we were ready for the disease. We didn't know how serious it is. But then you hear the news, no, it is for mainly in cold countries like UK, United States. We have got the sun, we've got the environment that doesn't allow us. We never had this viral infection before. And it caused a delay and the delay and the delay. He was admitted to the hospital at late stage.
Thank you so much. Just one quick question from Dr. Tang, quite an important one. So, how did people respond to the vaccination, the offer? If you can just keep it brief a little, thank you.
Yes, sorry. I think that the talking about the vaccine, I would prefer to leave it to the panel discussion. It's a big problem. It is a big problem everywhere, but in Yemen in particular, people were saying, and that include highly educated people like healthcare workers, doctors. They would say they cooked the vaccine. The vaccine is being cooked in the United States, and they exported to experimented on us. That again, rumor, misinformation was a big barrier during COVID.
Absolutely.
But we're going to have a very interesting discussion later in the panel at 4, I think, on that.
Of course. Just one comment there that regarding the community engagement in COVID. Elham thinks that the community midwives played a critical role in the delivery, and MCH services at the community levels really helped with all of that. Thank you so much for the comment, Elham. There's no further question. Thank you so much, Dr. Babrik. So I'll move on to the next presentation. So I will introduce my next speaker now. That's Professor Huda Basalim. She has a PhD in community medicine and family health from Malaysia, and she specializes in international child and youth care for development in Canada. She is a member of the Council for the Academic Accreditation and Quality Assurance of Higher Education. She's also a counselor of University of Aden, President Yemen, and Vice President and the Organization for Women in Sciences for the Developing World. And she is also chair for the Arab region for that as well. She's a consultant for several international organizations, including WHO, UNICEF, USAID, IOM, World Bank, and she is also the editor-in-chief of the Yemeni Journal of the Medical and Health Research. She's associate editor for the Conflict and Health Journal and editorial board member several regional and international journals. She will be talking to us about adult mortality before and during the first wave of COVID-19 pandemic in 9 communities of Yemen. Thank you so much, Dr. Huda. I'll hand over to you.
Thank you, Dr. Ahmed. I will present my talk. Are you seeing the presentation?
It's just the screen saying that it has started sharing, but I can't see the screen yet.
Now it
I
is
can see
in
the screen. Yeah, it's not in the presentation mode.
Now it is in presentation mode?
Yes, it is.
Yes. Okay, thank you. Thank you all audience for staying with us until this session. My talk is about population mortality before and during the first wave of COVID-19 pandemic in 9 communities of Yemen. This is a key informant study done by a team of researchers from University of Aden, Taz University, and London School of Hygiene and Tropical Medicine. As an introduction, we all know that Yemen experienced armed conflict and insecurity since 2014. And at the same time, there are also Yemen experienced or affected by several waves of COVID-19 pandemic since early 2020. Globally, studies in countries affected by similar challenges also have shown that both armed conflict and COVID-19 have resulted in a substantial increase in mortality. At the time we are planning for the study and initiating it, there was, to our knowledge, no recent published information on mortality in Yemen based on, surveys or something like this. Thus, this study aimed to see how these events have affected the extent of mortality in Yemen. We have 2 main, aims to estimate the crude death rate in 9 purposefully selected communities in Aden and Taz cities, 2014-2021, and also because COVID happened during the time the war is ongoing. Also, we take in consideration such, death. And finally, to estimate the death toll attributed to COVID-19 in Yemen communities. This is the map of Yemen. Here, Taiz and Aden are nearby, more or less governorates in Yemen. The study design, we use qualitative approach with mortality estimation. There are 3 field researchers who collected, or contacted the key informants. They were 3 male doctors and 1 midwife. Their work was, supervised by doctor or professor from Aden and Taiz universities, and also supported remotely by London School of Hygiene and Tropical Medicine team. And our field researchers subjected to 2 days training session on 15 and 16 January 2021 using, Zoom platform. This was in Arabic language, of course, and including information about the methodology, the open data kit, as well as doing a role play, how to conduct the key informant interviews. The study location, as I said at the beginning, they were Aden and Taiz. In Aden, we selected 4 districts out of 8. We named here in the presentation as A1, A2, A3, and 4. All of them in Aden were urban. We selected purposely that 2 districts, that is A1 and A2, directly and heavily affected by the armed conflict and was controlled by Houthis for around 4 months. But residents fled the area due to lack of water, electricity, fuel, and shortage of food and health services. Another 2 districts slightly affected by the armed conflict and was the destination of many IDPs from those districts that I mentioned before. Were our key informant. They were mostly community leaders, imams, corpse washer, health workers. Sometimes we have the wives of the community leader, the senior citizen, and so on. Those who are well informed or well known about the mortalities in their communities. In Taiz, we have 5 communities from T1 to T5. They are different. The semi-urban were T1 and T3 were semi-urban. Rural were T2 and T5 were T4 area or sub-district were urban. Also, they have, much variability criteria in terms of the conflict. The semi-urban were on the contested border, while T2 and T5 having ongoing direct conflict since the beginning of the crisis. So they are still under, the conflict. It is divided, this area divided between the 2 control sites. And we have the T3, no active conflict in this area. However, it's become the destination for many IDPs. T4, which is the urban, have both direct conflict, but at the time of the study, no more conflict but it is affected by siege. The key informant, like the one before, but some, other added, like hospital manager, like teachers, like mortuary manager, and community shop owner, and so on. So not much. So the key informant in general, they are a variety of individuals who are likely to know about many of deaths that had occurred in their neighborhood. At the beginning of the study, we decided to have, and this is one of the limitations, to have such a study across Yemen. But we faced a lot of challenges regarding the insecurity situation, getting the authorization to do that. And initially, we got sometimes to plan the project with 70 Yemenis from around the country and also from the UK and others by snowballing approach. But finally, we reached the main typologies of key informant that are community leaders, healthcare providers, imam, and people involved with funerals and teachers. We have very simple standard questionnaire built using ODK platform, only 7 variables: name, age, gender, year of death, cause of death, place of death, origin of decedent since 2014. And it is like this sheet, it is appear now in the screen. So just to have, so every key informant provided a list like this. And then we have a method to see what about that. Data collection have been done between 18 January until 31st March 2021, covering a population of over 10,000, 100,000, inhabitants. Each typology of informant, as I said, generated a list of dissidents within each sub-district. And we have an almost daily meeting with our field researcher, and each one complete, we have a session with them to clarify what is happening in the list. This is the paper that have been published in the PMC journal. The statistical analysis is the one that is take a long time because we have many lists, we have many overlaps, we have some missing data, and so on. So we were manually cleaned and duplicate were removed, and we used linkage criteria. What are the differences, the missing information in reporting? So we make every sheet together and making such linkage analysis to across all, having three main variables, that is the name, the age, and the year of death mainly. We also use recapture analysis method. We all know that it is a statistical technique that analyzes the overlap. So we can see here, for example, this is list 2, this is list 1, so there is some overlap. And then again, there are people outside, not captured. So this technique allows to us, by using the overlap, to infer the number of deaths outside of any link outside of any list, for more validated finding and best estimate of mortality. We use or we stick to, most ethical consideration, that is ethical clearance was obtained from the University of Aden and London School of Hygiene and Tropical Medicine. We also got formal agreement from the Public Health and Population, and all respondents having, or have to provide their oral consent to participate. At the end, we reached 138 interviews. 56 were from Aden, and this is Aden in blue color, A1 until A4, and 82 from Taz. The highest number of interviews in any area was 23, either in Aden, in A2, or in T3 in Taz. Unfortunately, women only around quarter of, the participants. Many of them not like to, give information, but still 25% were women. We finally reached 3,022 records, that is of people who passed away. But after verification and doing our analysis, it was 2,445 deaths. We can see here the number of dissidents in records reported by key informants by year. It is clear here two peaks. The first peak was in 2015, which around 372, and the most or the measure was at the time of COVID, it is 2020. We can guess here that it is the year of intense, that is, 2015 fighting in Yemen, and this is the COVID associated with COVID mortality here in 2020. If coming by month, we can see here that the three most spike here happened for May, June, and July. And this is also, coincide with reporting of the death cases by COVID. We have a lot of data, but there is no time here. But for every, sub-district, A1, A2, for example, this is for A1, we can find a lot about male, female, what are the causes, and so on, where the key informant and other. This is from Aden, and this is another from Taz. And as I say, I have all this by the 9 communities. What about the death attributable to conflict? The percentage of death due to war injuries out of all death listed increases from as low as 8% increase as high as 51%. Even the lowest value of death, that is the 8% rate, is higher than the expected UN non-crisis demographic projection. non-crisis demographic projection, that is, if there is no more, that is for the years 2016 and 2020 of 4.1 per thousand person year. So we have much increase due to, conflict. In conclusion, the study provided evidence of a peak in mortality during the early phase of the pandemic. And also the death rate estimate suggested substantial mortality elevation from baseline during the crisis period, that is after 2015. The study highlighted challenges of data collection in this insecure, politically contested environment. That is why this is of the limitation that we cannot have many, authorization to go. And then finally, we decided to the areas of those Aden and Taz, that is the collaborating universities in Yemen. But future studies could be more specifically comparing sites affected directly by the conflict, which those that were not, affected. But what is interesting here that key informant interviews together with capture-recapture analysis could be applied in conflict-affected setting. We find it very useful, and this method has a potential to be applied prospectively as a substitute for non-functional vital event registration. We have problems sometimes with vital event registration, so using capture-recapture can help in this. And thank you very much for allowing me to give this presentation.
Thank you so much, Professor. Really insightful. I can see, first of all, the uses of the international collaboration. Especially London School of Tropical Medicine Hygiene coming in as well. I think I can see the comment there. We just do a bit of short Q&A. There's no question so far. Maybe I can just ask you something from my side. Because I could see there were trends, especially from after the conflict, there was a surge, and then there was in the earlier COVID, there was a surge in the mortality. In the COVID period, in your trends, because you have the data, what was the most common cause? Was it the COVID itself, the cause of mortality, or was it the conflict still in some places?
Yes, thank you for the question. Actually, the people living in Yemen know that is at the time of COVID, there is happening other also, pandemic. There are dengue fever, there are chikungunya and some other. So there is some overlap sometimes to decide, but at the end, it is the COVID. But there are other mortalities related to other infectious diseases.
I think there's a similar question from Dr. Tang. That how often was COVID used as a cause of death in the certification in the Yemen when you did the study?
Please, I didn't hear.
Sorry, it's just how often was COVID as a cause of death was used in your study? How often was that? How frequent was COVID popping up as a cause?
Yeah. Okay. According to my study, up to 80% can be attributable to COVID.
Fine. Thank you. There's no other questions. So yeah, thank you so much, Professor Bauda.
Thank you.
I would move on to the next presentation from now. Thank you.
Thank you.
We're not having any break because of the time constraints. So we'll just go straight to the next talk by Dr. Rahmat Dapari. So I'll just introduce my next speaker. Dr. Rahmat Dapari is an associate professor. He is a senior medical lecturer and public health medicine specialist in the Department of Community Health and Faculty of Medicine and Health Sciences at the University of Putra, Malaysia. He is an academician and researcher at the University of Putra. He serves as the chairman of the Integrated Dengue Research and Development, UPM, and he's a certified trainer in social and behavioral change, communication, and he's an active member of Dengue Prevention Advocacy Malaysia. His research focuses on dengue prevention and control, emphasizing risk assessment, predictive modeling, and community-based intervention. And his talk is pretty much touching upon what Professor Huda was talking about. Essentially, it is the neglected tropical diseases in Yemen, and especially in pandemics times. So, Dr. Rahmat Daparia, over to you.
Assalamualaikum warahmatullahi wabarakatuh. I hope you can hear my voice.
Yes, I can.
Okay, thank you. So first of all, I would like to thanks to Dr. Muhammad Fahad for the very kindful introduction, as well as the organizing committee for the invitation. I hope that you can see my slide now.
It's not going into the slide. Yeah, we can see it now.
Okay, you can see now. Okay, so first of all, I would like to little bit introduce myself again, Associate Professor Dr. Ahmad Dapari from University Putra Malaysia. By background, I am a public health medicine specialist, also a chairman of Integrated Dengue Research and Development from our university. So I would like to take opportunity to invite all of you who are interested to do some research and collaboration, especially community engagement to empower the community on dengue area. So my topic today is entitled Neglected Tropical Diseases in Yemen. I am from Malaysia, but we did some study on the systematic review on NTD, and then I think that the reason why I was invited to give the talk today. So without further ado, I start my presentation. So this is the content of my presentation. I will start with the introduction on the NTD, the global burden of the NTD, and then focus in the Yemen, what happened in Yemen in terms of the burden NTD, and then what other factor contribute to NTD. So at this point, I will try to separate the different between what happened because of the conflict and then what happened because of the pandemic of COVID-19. That's why I will have two slides. One talking about the factor contribute to the NTD in global pattern, happen in my country, happen in your country, and happen at global level. And then focus on what happened for COVID-19 during the pandemic COVID-19, and then what happened to the NTD. Okay, so NTD is a group of infectious disease. I need to slow down this one a little bit. I cannot see my screen. Okay, so NTD are a group of infectious diseases primarily affected underprivileged and marginalized population in tropical and subtropical region, including Yemen. These diseases are caused by various pathogens such as viruses, bacteria, protozoa, and helminth. Example, the famous is malaria, dengue fever, leishmaniasis, and lymphatic filariasis. Many more, but I will try to cover a little bit. The transmission of NTD is influenced by many factors such as environmental condition, including the climate change and poor sanitation. And these socio-economic factors such as poverty, underprivileged, marginalized, inadequate healthcare infrastructure, and low level of education also potentially as a factors that contribute to the increased risk or burden of the NTD in many countries. Despite their significant public health impact, we know that the number, the incident, the burden of NTD actually very high, but NTD often receive limited attention and resources in many countries, including Yemen. So in terms of the NTD, there are many factors. As I mentioned, the etiology from helminth, protozoa, fungal, viral, bacteria, and others NTDs. But this at a global level. So when we see at the global level, what happened? Basically, we can see many countries actually affected by this NTD, including what we can see here is including Yemen. Okay. So we did some systematic review entitled Neglected Tropical Diseases in Yemen, a systematic review of epidemiology and public health challenges. One of the main author actually from Yemen, Ibrahim Ahmed, and then me and UITM, UPM and UTM actually collaborate for this publication under BMC Public Health. So what actually we found? So we actually do some mapping. Oh, okay, before that, a little bit introduction on this study. So this systematic review actually looking into article published on the NTD in Yemen. So basically, we want to see how many actually article that fulfill the inclusion and exclusion criteria that focus on the NTD and Yemen. And then based on this study, actually, we found that there are 230 number of paper actually fulfill the criteria. So based on this paper, actually, we try to do some mapping to look how many paper actually from some region and what are the most common or what are the number of etiology has been published previously. Even though this one cannot answer what happened during the pandemic, but at least it tell you that this is the research interest in Yemen, meaning that the number of article actually tell you that there is potentially that's the highly meaning that the most burden of the NTD in your country. Okay, so based on the mapping, the figure A actually mapping location of the reported viral entity. So we can see that the darker the color, actually the higher the number of article being published based on the literature, based on this study systematic review. And then the figure B actually tell us about the bacteria NTD. Figure C tell about the helminth NTD, and figure D actually tell about the protozoa NTD. So the number of inside each region actually represent the number of paper actually we found during the systematic review. The next part actually, previous slide actually I show the etiology of the etiology of the NTD, but now based on the systematic review actually we are able to analyze in terms of the etiology of the NTD based on the paper, the 230 paper that we found. So based on this, actually we can see that the top paper, the most paper published for the virus actually is dengue, followed by hepatitis, and then for the protozoa, the most actually from the leishmaniasis, followed by the malaria. Helminth, the top is schistosomiasis and followed by the ascariasis, and for the bacteria, the highest E. coli, follow the E. coli and cholera. So this potentially tell us that the burden in Yemen actually among this etiology or among this kind of diseases under the NTD groups of disease. At the global level, NTD affect over 1.7 billion people. So now I go back to the global level. 1.7 billion people are affected annually. This disease contributes significantly to the morbidity and mortality, whereby we can see that malaria causing approximately more than 600,000 deaths in 2021, and dengue fever result in 390 million infection each year based on the WHO study. So what happened in Yemen? So as we know that since 2015, Yemen has faced a devastating conflict lead to one of the world's most severe humanitarian crisis, meaning there is a conflict. And this conflict actually resulting in extensive infrastructure damage and further weakening Yemen already fragile healthcare system. So we can understand that at this moment, before we are talking about the COVID-19 pandemic, the Yemen already have conflict in their country. So this actually contributes so much on the NTD burden in their country. So we can see that the burden in Yemen is actually alarming based on the study we found. Actually, this is from different study. So malaria remain endemic in part of the country, which an estimate 100,000 cases reported in 2022. So this is actually during the COVID pandemic. And then dengue fever outbreak have surged in recent years with thousands of cases reported annually. From 2016 to 2022, we can see largest ever reported cholera outbreak in recent history. Over 2.5 million suspected cases and 4,000 deaths happen. And for the schistosomiasis, a waterborne parasitic disease also continues to affect rural population, particularly in area with poor water and sanitation infrastructure. So we can see that because of the conflict, because of the infrastructure, because of the healthcare system, everything actually contribute to the NTD burden. On top of that, the displacement of over 2.4 million Yemenis due to the conflict has led to overcrowded unsanitary living condition in camps and host communities. So this condition significantly increase the risk of disease outbreak, particularly preventable disease such as NTD, including malaria, fever, dengue fever, cholera, and schistosomiasis. This disease actually disproportionately affect displaced population. So meaning that there are certain population actually at risk of having the disease because of the condition, and community with limited access to clean water, sanitation and healthcare, compounding the crisis, the conflict that happened in the Yemen. Okay, in addition to the impact, so we understand that this is the story from 2015 that I showed just now. So on top of that conflict, there are many other factors actually shown based on the systematic review that we found that there are many other factors actually contribute on top of that. It could be synergistic, it could be additive, or it could be multiplication. So what we can see actually, one, climate change. So climate change raising the temperature and changing rain pattern actually help the mosquito and snail spread, and this actually lead to the disease like dengue and schistosomiasis. Geographical changes. So what happened? Urban growth and people being forced to move have made it easier to the human to the contact with the disease carrying insect. So because of the displacement, the human need to force move outside or move to other place. So this actually increase the contact between the human and the insect. Economic impact, because of the economic collapse, the hunger and poverty have weakened health system and made it hard for the people to get the treatment and protection. Behavioral and educational factors. So low health knowledge and poor hygiene made it harder for the public health program to work well because of this condition. Living condition, because of the conflict, and then make it worse into the living condition. Crowded, dirty condition in a refugee camp and host area actually make it easier for the disease to spread. And wash system collapse. What is wash is the water, sanitation and hygiene. So the breakdown of this wash system lead to the increased chance of the disease outbreak in the population. So this is what happened during the conflict. So in terms of the impact, we can see that despite of the effort in the effort at the international organization, including the WHO, maybe the non-government organization, the intervention has been insufficient. Still insufficient to curb the risk and the NTD. And then the combination, the combined effect of this factor actually highlight the complexity of the addressing NTD in Yemen, and it require multifaceted approach that consider both direct and indirect contributor to the disease transmission. So next slide, I will talk about the COVID-19 impact on the neglected tropical disease. So what happened during that time? Unfortunately, I cannot provide the data because I tried to find, because I did not do any study on the data, but we try to understand based on the publication what actually happened during that during the pandemic in other country. Maybe it happened in your country, but there are certain things that we should discuss during my presentation. So the COVID-19 pandemic has severely disrupted health system, economies and society around the world, including Malaysia in my country. So how actually this NTD were affected by COVID-19? The main basically because of the multiple disruption and setback. Multiple disruption, interruption of the health system because of the COVID pandemic. So it affect the NTD program. So if you already have the NTD program in place, it actually affect that NTD program, and the progress toward the implementation could be interrupted also. So the impact based on this study, I think some of the speaker actually presented also, the impact on the health service delivery in Yemen has been distinct and profound. All the health services in the hospital has been declined during the COVID-19 pandemic. So what happened? We can see one by one. The diversion of the resources. So during the conflict, during the what happened in 2015 until before the COVID, maybe you already have some allocation for the NTD. But because of the COVID-19, what happened actually, there are diversion of the resources toward either because of the health personnel and resources were redirected from NTD program to manage the COVID-19, because COVID-19 at that time during the pandemic become the highlight, become the priority of the country because of the number of the cases and the number of deaths, and number one, and the focus of the public toward the COVID-19. So everything has been diverted, including all the resources. Access challenges because of the lockdown and travel restriction. What happened in my country, we do some movement control order, MCO. So nobody can leave the home. It's a quarantine in their host in their home, and then they cannot cross the border. So what happened? Lockdown and travel restriction actually hamper access to the remote and at risk population, and this actually delay the essential NTD services among who are having the disease. And then funding reduction at the national level or international level. So what happened? All the funding actually was reallocated from initially they want to do the NTD program, then now they focus on the COVID-19 response. So this actually causing financial constraint to the NTD program. Some of the NTD program become plateau, no movement because of the funding has been relocated. Supply chain disruption. Interruption at the global supply chain lead to the shortage of the NTD medication and diagnostic and risking treatment delay. And research, we can see that so many research actually focus during that time actually focus on the COVID-19. And then we are talking about the maybe is a COVID-19 vaccine or COVID-19 impact. So most of the research actually go to the COVID-19. So some actually happen also closure of the lab and hospital and cut in research funding disrupted this NTD surveillance and slow the development of new treatment for the NTD. Increased vulnerability. Already vulnerability group because of the conflict, because of the condition, but because of COVID-19, there are increasing number of vulnerable people. Poverty or limited healthcare access become even more susceptible for the NTD infection. Community engagement decline. So during the COVID-19, what happened? There is a restriction and fear of infection, reduced participation in community-based awareness and control effort because of the physical distancing. There are people afraid of the contracting the COVID-19 if they are engaged with the community program. So this is what happened during the COVID-19 pandemic. And then last but not least is healthcare system strain because overburden of the health system limiting the capacity to diagnose and treat NTD contribution to the care gap. So because of so many things that happened during COVID-19 pandemic, we need to understand when we want to do some analysis of the data. So in my country, we did some analysis looking into what actually happened. So example like dengue. In 2020, 2021, 22, we can see drastic reduction of number of dengue cases and reduction of the dengue deaths. So we can see that are we happy during that pandemic? Actually, we can cut or we can reduce the burden of dengue during that time. So my question at that time is it a true reduction? What we are talking about the true reduction? If patient actually having the dengue, but because at that time, COVID-19, they are afraid to go to hospital. So you already lost opportunity to get the number because they are afraid. If they did not go at that time because of the healthcare facilities actually too focused on the COVID-19, so maybe there are some of the cases actually undetected. So this could happen in Yemen. That's why if we want to see into the NTD, there are so many diseases under NTD. When we want to study, the question is it a true reduction? Is it a true graph or true data? What I can say. Number two, is there any possibility of masking? Again, the same issue that I raised, because if there are death because of the dengue, but at that time COVID-19 become co-infection or become the main treatment at that time, so maybe there are possibility that the dengue death is not catch but instead it become COVID-19 deaths. So there are some study or some investigation to detail out of this issue need to be done. Then only you can get the true data that can explain what happened during the COVID-19 pandemic. So this is some of the study published show that to show that there actually reduction of the R&D, research and development funding of the NTD before the COVID and after during the COVID-19 pandemic. You can see that there is a drastic reduction of the fund during 2022. Okay, and then this is the variation of the again the R&D funding. This is the data that are available, but in terms of the true number of the dengue or the malaria or NTD cases in Yemen, I could not provide for today presentation. So again, this COVID-19 impact on the neglected tropical disease increase the vulnerability due to the compounding crisis. You already have the conflict, you already have the poverty, marginalized, and then on top of that, you have the COVID-19 pandemic. So it's like a compounding crisis. About the on top of malnutrition, there are many more. They actually factors that contribute to the NTD burden. So in conclusion, COVID-19 pandemic has both direct and indirect effect on the NTD. This impact have contributed to a potential risk in the disease prevalence, disability, and the resurgence of the NTD in some region, including Yemen. To safeguard progress, future pandemic preparedness must prioritize the integration of the NTD program within resilient and adaptable health system. And this include innovative service delivery model, stronger stakeholder coordination, sustained investment, and flexible strategy that ensure continuity of the care during global and health emergency. But we do understand that my country is not in conflict, so we can have a better management. But in Yemen is totally different situation where you have conflict on top of so many other factors, and then you have the COVID-19 pandemic that make it worse for you to manage the COVID to manage the NTD. So thank you for listening. So now I open for any question. Thank you.
Thank you so much. I would say a really nice insight into the tropical disease, especially the insight that you had about the dengue cases going totally a bit of discrepancy when the pandemic happened. I have some questions in the chat. The first question is from Dr. Mohammed. It says, why was dengue fever higher than other diseases? I presume it's talking about pre-pandemic. Also, can you explain the difference between its severity in the Yemen and in Malaysia? How is it different, you would say?
The different severity of the
disease, I think that's what he means. Or the impact of the disease
the
itself.
impact. Okay, the impact. Okay. In terms of the impact of COVID-19 pandemic, what I can say based on, I have I think 3 to 4 PhD students from Yemen. So actually we discuss a lot on the dengue and malaria in Yemen. So actually what I can observe based on the discussion, so this is not paper. This is not the study that published. This is based on my expert and observation based on the discussion. So in my country, we are quite stable in terms of the political and no conflicts. So meaning that our resources as well as our manpower, including manpower, are at the optimum level, meaning that we are quite robust. When the pandemic happened, we still manage to move our resources from other. We inject into the health system, and then we try to mobilize our healthcare workers to focus. But again, that still not have bigger impact in terms of the NTD management. What I can say, because the hospital still going on, the healthcare system still going on, and then we still do at best for the surveillance and management of NTD for our country. But again, what happened in Yemen, what I can say, because you already have the conflicts, so the robustness of the healthcare system already at the risk, meaning that it's not too strong. And then when you have this pandemic, actually, you are have more challenge, and I cannot compare apple to apple. We are at different situation. So if short answer, yes, I can say there are too much different. The impact, I believe that in Yemen, in terms of the NTD impact, is so much bigger as compared to my country.
Thank you so much. I've got a question from Abdul Wahid. First of all, he's thanking you for your presentation. I think his question mainly is about rabies because he thinks that beside the dengue, he was expecting to see rabies to come up in your research, but he didn't see that come up. Do you see any explanation for that? Why didn't you see rabies in your um, talk at all, first of all?
Okay, I do not have any experience or any knowledge on the rabies in Yemen. I do not have, so I cannot answer. But what I can say in my country during the pandemic actually is a bit no. I mean that during the COVID pandemic, rabies is not one of the issue has been raised. I believe that because of the movement control order, where we are not exposed in contact with the dog at that time. So all the stray dog is outside still there, but because of the limited movement of the people during the pandemic, so we are not in contact with the stray dog. So I think the rabies is not an issue during pandemic. So, but I do not have any idea in what happened to in Yemen.
There are no further questions. So, yeah, thank you so much, Dr. Rahmat Dafari. We'll move on to the
Okay,
next.
thank you. Most welcome.
And I think we are catching up on the time, so I'll straight away move on to our next presentation. I'll first introduce our next speaker, Professor Alessandro De Motas. He is a PhD with distinction in international relations and European integration from University of Autonoma de Barcelona. He lectures on international relations and European security at UAB. His fields of expertise include terrorism, nuclear affairs, human security, and critical security studies. I'll hand over to Professor Alessandro De Motas.
Thank you very much, Dr. Fahad. First thing I would like to say, it's a pleasure, an immense pleasure and honor to be here and listen to so many doctors and people that are acting on the field. And I have to say that I come actually from international relations, so the purpose of my research that I'm going to present today is exactly to tell to the academia about the importance of what's going on in Yemen that sometimes is not receiving the correct attention by the international community and the academia. And we also wanted with Audrey Okansi-Agbeko, the other researcher, to prove that security can be analyzed also without the military on command. Security can be implemented as a coherent policy, and doctors and humanitarian personnel can be in charge and they can guarantee security. So this is our struggle. I study also traditional strategic affairs, but I also want to, let's say, give more voice to this new, this critical point of view of security that says that security is not only a military affair. There are so many other dimensions that in different contexts in the international society become the top priority. And Yemen is one of these contexts, because what do we intend without research is that security in Yemen must be guaranteed first by doctors and the humanitarian personnel. The army military personnel can only help to guarantee the correct context, but the priority goes to food security, nutrition, and these human security dimensions that are much, much wider. So what did we do? We decided to study food security and nutrition policy in Yemen before and after the pandemic. We started in 2018 and we ended in 2023. We compared to food security and nutrition policy implemented in the country. The first one is the Yemen Action Plan, from 2018 to 2020 called Strengthening Resilience and Agricultural Livelihoods. The second policy that we did analyze is a policy called Multisectoral Nutrition Action Plan for Yemen 2020-2023. So as you can see, the year of the pandemic is the end of the first and the beginning of the second policy. So we can see if the pandemic co-generated some of the most important problems that these policies are facing. So my first message is, apart from thank you, is also to congratulate all the humanitarian personnel present today here in this conference and in Yemen, because what you're doing is something unique, and we are trying from the academia to give you the enough attention that you don't have, we do think. So how did we, the first thing I'm going to do is just to summarize the two policies analyzed, also just to explain shortly the methodology and this human security approach that we decided to use. And at the end, I would like to make some multidimensional considerations about four different dimensions: the legal, the institutional, the political, and the material dimension. Related, that this last one is more related with problems on implementation of the policy that sometimes can affect its efficiency or efficacy, okay? So that was our objective. So let's start just summarizing the Yemen Action Plan 2018-2020 that is focused on the second sustainable development goal and hunger, and that acts on the ground in level 3 humanitarian emergency. It is focused on agriculture, climate change, and epidemic control. There are 3 pillars and 21 different areas of intervention that wanted to reach 1.17 million households for the elimination of locusts and other animal and plant epidemics, and also more than 135,000 households for the introduction of green technology, water conservation, and also there is always in this policy a dimension related with the institutional reinforcement. Why do we say that? Because this policy, and this is something we don't say unique but very positively strange, is led as a FAO project, the Food and Agriculture Organization project. So in this sense, we have a very complex context of a state, Yemen. We have a security policy, a food security policy that is implemented by the international personnel. This is something that international relations is strange. Why? Because usually states do want to keep their absolute sovereignty on every matter about security, not only the military one. So this is why this action plan was something very unique to us. It's sometimes because we have a perfect alignment of the government of the state that decides and accepts that international personnel can help a lot and can also be in command. So that was, we may say, why we did choose this policy. We have to say, I go very, very briefly to the results, and we have to say that due to the pandemic, the efficiency of the policy decreased from 95% in 2019 to 42% in 2020. So it's more than the double of decreasing in just 1 year. So only 6 out of 13.5 million people could be attended. And also, if we go to the long-term livelihoods objectives, like the introduction of green technology, etc., we see that the implementation of these long-term objectives were only at 8% in 2018 and 2019, but we do not have any data regarding the year of the pandemic. And this is a general problem that the pandemic had on all the policies, this lack of data, lack of information. So sometimes we cannot make the complete comparison. If we go to the second policy, the Multisectoral Nutrition Action Plan, we see that this plan is focused on the first three sustainable development goals. So it's reduce poverty and hunger, and also to guarantee healthy lives. This plan
is focused on reduce malnutrition through three axes. The first is to provide health and nutrition services for mothers and children. So focusing on those specific groups that we do know that in a conflict context deserve more attention. Also, we do register the need for a coordination of the action between different sectors. What do we mean? That in these policies, we have the participation of different Yemeni ministries, because this policy is led like a national policy. So we have the Ministry of Health and Population, like the Ministry of Water and Environment, the Ministry of Agriculture and Education, and also the Ministry of Education. So in this sense, we see a comprehensive, holistic approach that guarantee coordination and participation also of all national authorities. Another focus is put on malnutrition and forced marriages. Why also, and this is a common point also with the first policy, we do register a very positive point. There is a strong communication strategy. In this sense, focusing on hygiene, health, nutrition, and also women's rights. What do we have to say just in order to advance some results? The problem, in this sense, the second policy, of course, in the sense of efficiency and efficacy, is affected even more by COVID because it starts during the pandemic. So starting from the beginning, we have the deliveries reduced to 50%, not on a monthly, but on a bi-monthly basis. Also, information doesn't arrive as it has to do. So we do see that even if there is an almost perfect institutional normative design, legal design of the policy, there are some legal, institutional, and material problems that the pandemic starts, but sometimes other episodes or other processes do continue or sometimes make even worse, like the intense floods of 2022, like the end of truce of 2022, and of course also sometimes due to something that happens, no, there are no slides, that happens in the international context, like earthquakes, Syria, Turkey, or like the war that started in Palestine on the 7th of October on 2023 and that now is spreading on the region. All these factors contribute to reduce the international attention, as I said before, that Yemen deserves. The situation in Yemen is very bad, highly bad. Situation can be, according to numbers, even considered worse. The situation in Palestine, even if the gentrification, the concentration of people there may be different, but its objective is something that all the academia, we do agree, Yemen is not receiving enough attention. So how did we decide to approach these two policies? We make a qualitative methodology, we adopt a qualitative methodology analysis of more than 2,200, primary sources from actors from the grounds, general report from the Yemeni authorities, FAO, Food and Agriculture Organization, United Nations Development Program, the Organization for the Organization for the Coordination of the Humanitarian Affairs of the United Nations, like the World Bank, World Health Organization, and World Food Program. We also complement these primary sources with the international academic literature that is specialized in Yemen and food security and nutrition policy. Of course, we have to say that we lost a lot of time because information was fragmented, sometimes incomplete, and sometimes also out of date due to this pandemic, of course, situation that worsened even more the situation. But even so, even though we arrived to make a general, we may say, comparison with some results that as we said before, reinforce our thesis, that is that security is not only a military matter. So why human security? Well, human security is a new paradigm, we say. It was born in 1994, so it has only 30 years. It's a new paradigm. It's a post-Cold War view of security that, as I say, widens this and deepens the concept of security. We do define the human security approach as a security against chronic threats such as hunger or diseases, and also we do define human security as the protection against any violent disruption of daily life. So we distinguish 3 pillars and 7 dimensions. The first pillar is freedom from fear, that is focused in protecting bodies from violence. The second dimension is freedom from need, that is more related to any basic need of any human person. While the third, the new pillar that has only 15 years, if I'm not wrong, or 10, is the freedom to live in dignity. Because we add this moral dimension that we all agree is common to all humanity. There are some limits to dignity that no one can ever pass. And this is something that, thanks to the work of the United Nations since 1945, we may say that there is an international alignment. We do all agree about that, even if sometimes someone may say the contrary. The majority of the international community and academia, we do have an agreement of what is dignity. Dignity is human security. It's 7 dimensions of the people: economic, environmental, food, health security, political security, but also individual and community security. We do see there is no army, no military affair here. Why did we choose human security? Because we do think that in such a complicated context like Yemen is the only one that provides coordination and integration between different actors on the ground and also at other levels, because we must arrive to the international dimension. And we also see that human security policies do provide a correct, the perfect legal and institutional framework for the cooperation among these actors in a multi-level and multi-dimensional context. And also there is the principle of leaving no one behind. What does this mean? That local population must be an active and proactive actor in formulating and in improving security policies. An international policy, any security policy, can be designed in Geneva or in New York in a palace of the United Nations, must be designed also listening to people that used to live all their lives there and that may know all the local and sublocal problems or conditions related to the context that we see so much important nowadays. And also, of course, why human security? Because this is the biggest difference against military security. Usually the military security means that you must react to an attack, to an offense. We do not reason in this sense in human security. We do try to be proactive and to prevent. We go to the root causes of the problems, because otherwise it's always, as we say, trying to fix in a symptom, but you not go to eliminate the disease, the cause of the disease. And I imagine that you can understand me with this metaphor here. Okay, so what did we discover? First of all, what we do have to say is to congratulate all the people that work on the ground, because the results were, we may say, amazing before the pandemic and still are amazing due to all the impediments and problems that people are facing there. So with no any intent, I do repeat, our research is absolutely positive and to congratulate, but of course our idea is we do analyze, we do analyze and we do compare policies in order to improve the next one. So what can be improved? What can be fixed? Because it's something we are doing, we just must maintain it. So what are these legal, institutional, political, and material problems that food and security nutrition policies in Yemen face due to the pandemic, sometimes also to the pandemic and other factors? So we do identify 4 legal problems, impediments. The first, and we already mentioned here in the previous presentation, are the Houthis mobility restrictions that combined with the administrative travel bans during the COVID caused what we call the bunkerization of the humanitarian head. What does bunkerization mean? It's 3 things. It's the gap of presence, The second is the lack of information. And the third is the jeopardization of the action. So that means that, yes, it's something that is a weakness that can be, of course, fixed and improved if these travel bans and these mobility restrictions are reduced or eliminated. The third legal impediment that is reported by different sources in our research, that is open access if you want to consult, is the gender gap. Some reports report that female workers must go with men sometimes, and of course this generates inefficiency, absolutely, because it's a restriction to movement. And the third legal, not absolutely an impediment, but we may see as a problem, is the operational fact that the Emergency Operations Center is in Riyadh. Sorry, I do not read the chat. If there is something you want to tell me.
No, it's not for you. It's for the next speaker. You can carry on.
Okay. Thank you very much. So these are the four legal impediments, or yes, impediments and problems that we see. Going to the institutional dimension, as I said before, the institutional and the normative design, the legal design of the policies, absolutely, we may say, is almost perfect. So there is nothing to say on the design. Everything is very well written and designed. But of course, there are some institutional weaknesses that are related to the difficulties, to the problems that Yemeni authorities are, of course, facing on the ground, on the context. So sometimes there is this, some authors called it institutional incapacity. I do not like that much the term incapacity because I see it as absolutely negative. So I do prefer the term difficulties that an authority is facing. And of course, this situation, especially the fiscal situation, is worsened by the hyperinflation started after the Ukraine war at the beginning of 2022. And we also have to remember that Yemen imports the 27% of wheat from Ukraine. So, of course, this international, say, this war that comes from another regional context has a negative direct impact on the Yemen situation. But when we go to the political and the material dimension is where, taking the international relations perspective, we find more causes for problem for implementation. The first political problem is the biggest one. It is called structural violence. That is the violence that is not direct. It's the violence that you do not see. It's the violence eradicated in the structures of the society that makes difficult the complete human development and human security. Excuse me. The gender gap is a first example of structural violence, but the most important one, I would say, is the fact that Yemeni war is a food war. Like now in Gaza, food is used as weapon. Hunger is used to kill people. So food and security and nutrition policies in Yemen are essential because if you fight hunger, you're eliminating a weapon from war. So this is what we are trying to say to the academia, because I do repeat, this we are starting from 2014, we see the weaponization on food in Yemen. It's something proved by different researches that we quoted. Also, other reports talk about conflict, factions, and corruption that is very diffuse in the country, like in Italy, mine, and also in Spain, we have to say, we're all brothers in this. So, but what's the problem in this sense in Yemen? That there is no strong deterrence against human rights violation, not only against the population, but also against the international personnel. So this is sometimes that we may say related to structural violence. And the last element that I would like to mention that I will take also at the end, because I think it's very, very important, is the situation of the international press, actually the persecution of the international press made by Houthis in some cases that are reported. So the second political problem, as I said before, is the bunkerization of the humanitarian aid, gap of presence, lack of information, and jeopardization of the action. And also there are some new reports from 2024 that talk about the political conditionality imposed by neighboring oil Gulf countries to the Yemeni government. So this is something that is typical from the international relations perspective, because we see sometimes states have in national interests that are not exactly aligned. So this is something also that some experts report. Like another topic we do have different in this sense to also reference, talk sometimes about some tensions registered between NGOs staff and United Nations staff that can cause in some cases inefficiencies in the supply chain and in the resources allocation. Those sources that we quoted, they always have interviews, 20, 30, depending on the number. They are anonymous, but they are based on interviews on the ground. But of course, this is not saying that this is always like that. These are cases that are reported. Right, and I would like to go to the fifth one, the political, the most dangerous problem after the weaponization of food is the growing misinformation and anti-humanitarian social media campaigns that have been held in the last years. And also this has to be overlapped with the arbitrary detentions of journalists that is causing the fact that there is not enough information on what's going on in Yemen if compared to other conflicts. So just to finish my analysis, let's go to the material, to the efficiency dimension. So what are the concrete problems of the implementation on the grounds that these two food and security and nutrition policies in Yemen face? So the first were movement bans that started in 2020 due to the pandemic. Those bans made that 98% of people, 17.8 million, are in hard to reach areas, people that are the target of these policies. This situation is documented worsened by the intense floods that started in 2022. Let's go to the second problem, the COVID and the arbitrary detentions that I mentioned of journalists causes lack of data. For example, World Health Organization declares only 12,000 cases of COVID in 2023 and only 2,200 deaths in 2023. But we have reports and videos from the International Organization of Migration that is on the ground that talks about mass grave sites that do contradict evidently with what is reported in WHO. We also to say that there is an interesting report that talks about 570 households survived in Yemen after the pandemic. International Organization of Migration, together with Cash Consortium in Yemen, revealed that half of people lost their job, while 1/3 of them declare reduced incomes and remittances. So we do see a direct problematic economic effect on human security that COVID is also causing. So, of course, the fourth point goes to internally displaced person. The International Organization on Migration and all international humanitarian personnel report that they have high and acute food needs that are worsened by this situation. And also, just to conclude, the fifth problem is the pandemic, together with the end of the truce and the floods, the end of the lack of financial resources led to the fact that the 2/3 of programs in 2023 were reduced or closed. So the situation faced, according to the actors on the ground, is absolutely tragic if something is not going to change. So just to conclude, what can we say? We can say that these policies are really, I do repeat, perfectly aligned and designed with international public right, with human rights, and they can be analyzed using this critical and new paradigm that is the human security. There is a lot of things to do. Also, there are some institutional delays. There are some networks, for example, in academia, parliamentary groups, youth, media that are in progress because, as we do repeat, the pandemic overlapped with the floods, the end of truce, and also to the international complicated contest starting in 2022 in Ukraine that continued in the Middle East. What are the previsions, of course, regarding data, we try to be optimist, but we do see a very, very complete, difficult situation for all people that work on Yemen. Again, thank you very much, and thank you for everything you do. And we do promise that we continue struggling to give importance to human security in Yemen and in other contexts that are not receiving enough attention. Thank you very much.
Thank you so much, Professor. Really thought-provoking and really, I had never thought about these things from the political and from the international perspective, really. I think that I'll just touch upon the question that I have in the chat, very much related to what you've just said. So it is from Abdul Wahid. He says that why the malnutrition still continues to be a problem, despite there is huge sort of national and international input that has been put in to tackle this problem, but still this is a problem. So what explanation or insight you might have for this?
So you ask, sorry, why malnutrition is not, can you
It's
repeat?
still a problem. It's still a problem, despite all the international efforts for all those years. Why we don't see any improvement at all?
But I do think because there are so different factors and complex situation processes that are overlapping, meaning that in Yemen it looks like that everything, the situation is very bad, but there is always something new that is worsening the situation. As we said, until 2019, we had an efficiency of 95%, but after COVID comes, the COVID, we know that the effects continue during 2020 up to 2022 when we have the Ukraine war starting. And then in October 2022, the end of truce. That, according to data, is maybe the worst fact that happened. But I also do associate that to the fact that to the pandemic, we do not have data on 2020. We do have more data on 2022 and 23, so we can compare more. But I do think that this is the problem. Also, as I said, the second policy after the COVID, the first problem was fundraising. There is no money, so we do have to close half of the program that we do have there, and we just can limit to say everything is in progress. We were checking United Nations web pages to see if there was some update, and absolutely not. So it is impossible to have some recourse from those years. So the situation why malnutrition is still a problem, not because we do not have professionals, maybe because we do not have money. There is not enough attention on Yemen now. I'm Italian and I live in Spain. I can assure that everyone here is talking only about Gaza, Israel, and Iran. No one knows that in Yemen, 1,050,000 children dead between 2015 and 2019. People is talking only about the 50,000 people dead in Gaza. There is zero attention on Yemen. Imagine that 90% of my students do not have any idea of what's going on in the country because there is this. No, imagine, Israel, Middle East is always takes all the attention also on Western countries. This is what we want to change. Also, I always present also our research to students because I want them to focus on that. So I don't know if I answered to the question.
Thank you so much, Professor. There's just a comment from Dr. Tang that during the COVID-19 vaccination program, efforts were by COVAX to distribute vaccination to the resource-poor countries was not successful because wealthy and developed countries wanted to keep the vaccines for themselves. So essentially, it's a human nature, and it would always be difficult to overcome. But yeah, thank you so much, Professor.
Thank you.
I will be handing over the next session to Dr. Anne Hoskins, but I think we have 5 minutes short break. I can check with the admin team if we have a break or not. But Dr. Anne Hoskins from now on.
Thank you, Mohammed. I think we have a break now because the next speaker hasn't been able to join. I'm sure it's to do with Zoom and connection links in Yemen. So we have a break now until 1 o'clock and look forward to welcoming you all back. So time for you to have a little break and get your energy up for the next load of speakers. Thank you all very much. Welcome back, everyone, after your break. And I hope we're going to have an interesting afternoon session. My name's Dr. Anne Hoskins. I'm chair of the Yemen Special Interest Group of the Faculty of Public Health Medicine. Unfortunately, Dr. Abdullah bin Guth hasn't been able to join us, but we're going to move on now to hear from Dr. Ramadan Abdelmoez, who is going to talk about suicide prevention strategies in Yemen, bridging the gap in mental health. Dr. Ramadan is an interim doctor in Calfreiset University. He's experienced medical researcher specializing in statistical analysis, academic writing, and various research methodologies, including peer review and publishing. He has many publications to his name, and including 27 peer-reviewed prestigious journals. And his fields are public health, infectious disease, internal medicine, and surgery. Dr. Abdelmoez, I'm going to hand over to you, and I hope I've got the actual title of your presentation. Thank you very much.
Most welcome, Dr. Anne. I'm honored to be among you all, and thank you so much for the presentation.
Abdul, I think you might need to talk a little bit louder. It's a little bit faint, or closer to the microphone. Thank you.
Can you hear me now?
That's a bit better, but I think you need to maybe just, I'll see if anybody else have problems hearing. I'll just watch the chat message, but so far that sounds a bit better. Thank you very much.
Thank you so much, Dr. Anne. Can I start sharing?
Yes, please do.
Hello again, everyone. I'm honored to be among you all, and thank you for having me with you. My topic is about suicide prevention strategies in Yemen, addressing the recent humanitarian crisis and mental health issue and the ongoing conflict in Yemen. As we know, the ongoing humanitarian crisis in Yemen has been for 10 years, making which led to escalation of the mental health issues and suicide rate in Yemen. There is 4.5 million people being internally displaced and 18.2 million individuals who need urgent humanitarian assistance and urgent needs regarding food and medicine and mental health support. The current humanitarian crisis in this regard, over 18% of the population need help due to the economic and war collapse, which has been exacerbated by the COVID-19 pandemic, making the mental health issue and suicide rate an urgent issue which need action as soon as possible. Regarding the suicide rate in Yemen, the World Bank has issued a report in 2019, which was 5.8 per 1,000 people in Yemen, and there was 1,699 suicide rate deaths, making the suicide issue one of the leading causes across the country.
Dr. Ramadan, can you share your slides? I think some people are having difficulty seeing them.
Okay. I think I have shared it.
Yeah, let me see if
yeah,
that's fine. That's good now. Thank you very much for being shared. Thank you.
Most welcome. Also, there is a gender variation between males and females in Yemen. There is 7 per 100,000 for males compared to 4.6 for females. This variation in gender highlights the need to consider the gender-specific regulation and policies in the mental health initiatives and strategies. As you know, there is external factors contributing to the high suicide rate in Yemen, especially during the recent conflict and humanitarian crisis. Some of these factors include the poor living condition, high unemployment rate, the economic and political instability, the social stigma toward the seeking the mental health initiatives, especially among the many females. Also, there is psychological factors, limited mental health care and services, absence of mental health care services and support. There is also family disputes and domestic violence, cyberbullying, especially against females, and also more recently, weak religious beliefs. The conflicts and war leads to more psychological disorders among the population, especially psychosis, depression, post-traumatic stress disorder, which lead to high suicide behaviors and rate. There is, as we mentioned earlier, there is a social stigma in Yemen surrounding the mental health support and services, especially among females, which affect their seeking to the mental health support and psychiatrist negatively. The methods of suicide is different among males and females in Yemen. The most common suicide methods in males include firearm and hanging. However, in females, poisoning is the most common cause. Also, we should consider these methods in the future mental health strategy, national mental health strategy in Yemen, to put tight regulations, determine the background of these methods carefully to decrease or even prevent the suicide in Yemen. There is some challenges against the mental health support and strategies and policies. First item of this challenges is that there is a severe shortage of the mental health providers in Yemen. Yemen has only 0.2% of the specialized mental health providers per 1,000 individuals, which are about 40 specialists for over 30 million individuals. Also, there is limited access to the mental health services and psychiatrists, especially in the rural areas in Yemen and also in the females community. We mentioned the cultural stigma earlier in the presentation. We must call for action and for more initiatives and strategies in Yemen to decrease and or even prevent the high suicide rate. In this regard, the ministry, the Yemeni government and the Ministry of Health should seek the initiative called Hope Amidst Crisis, provided by the United Nations, especially in the conflict zones. This initiative provide psychosocial counseling, mental health support services, which can eventually decrease the high suicide behavior and rate, alleviating the current situation. Also, there is a national mental health strategy formulated by the Yemen Minister of Public Health in collaboration with WHO. This excellent strategy outline a 5-year plan to enhance the mental health services and implement preventive activities across the nation. It aims also to establish an evidence-based policies that can respond in a timely and effective manner to the mental health needs and the high suicide rates. Also, there should be a collaborative effort and background between the public and the private sectors, Yemeni government, Ministry of Public Health, and international organizations like the United Nations, the UNICEF, WHO. This organizations and structures should aim to prevent to decrease or even prevent the high suicide rate in Yemen through education, health care, increasing awareness, and increasing awareness through the social media, local communities, and also to reduce the social stigma surrounding the mental health issues. Also, Yemen can learn from other countries, especially Australia and Finland, who effectively implemented suicide prevention strategies in their nation, which can provide valuable insights for Yemen. For example, Australia has invested heavily in community mental health programs, which resulted in a significant reduction in the suicide rates across the last 3 decades. Finland also has a national suicide prevention strategy, which is one of the most recent strategies across the world, including comprehensive mental health services, promoting public health awareness, reducing the social stigma, determining and underlining the importance of integrated approach and evidence-based policies in regard to mental health issues and suicide. Yemen can adapt all these strategies and policies in one or more strategies self-based regarding the Yemeni population. These successful strategies can focus on the localized Yemeni community, especially females, mental health services, and support, and should seek the rural community across Yemen, as rural community in immense need for the mental health support, given the 68.2 rate of unemployment and illiteracy. So the future home message, implementing comprehensive strategies to address the mental health issues and suicide and high suicide rate is crucial for Yemeni recovery and resilience. Also, the Yemeni government should enhance and focus on educational programs regarding the mental health awareness through the Yemeni community, which can decrease the stigma, encourage individuals to seek the mental health support. We mentioned social media and confirm on it more again. Social media platforms is essential, plays an essential role to disseminate an accurate medical information regarding mental health and issues of suicide across Yemen, especially the youth and adolescent groups of Yemen population. Also, the Yemeni government should seek the international organization like the WHO, United Nations, to establish mental health clinics, provides get more mental health providers, psychiatrists, and resources. This can address the severe lack of mental health facilities, which is essential to decrease the high suicide rate. And this is everyone, all for today presentation. Thank you so much again for having me and for your attention and patience. If you have any questions, please don't hesitate to ask me. I'm available now for this.
Thank you very much. It's a really important topic that you've raised. There's a few questions now in the chat box that I'm going to read out for you. So Fikra says, thank you for highlighting this important topic. And she would appreciate if you could tell us more about the source of data and methodology of your research. She herself has found it difficult to get information from the National Health System. I personally was especially interested in the gender difference. Quite stark gender difference there. So anyway, so if any information on how your source of data would be really good.
Thank you, Dr. Anne, for bringing this important questions. Actually, there is a severe lack of data on suicide rates and mental health support across Yemen. However, I grabbed this. We published a letter to the editor in a journal with impact factor 13.4. Also, when we approached the medical data and published the data regarding the data published on Yemen, there is an important paper. I will share it through the chat. Published by Dr. I think Dr. Tawfiq al-Hashimi. I think this is his name. I will share anyway the paper discussing. He published a socio epidemiological analysis regarding the data, highlighting the severe lack of data of suicide. However, I get the numbers, the rates from international organization like the WHO, United Nations, UNICEF, and from his paper. We need. Thank you for reminding me of this point. We need an urgent action and need to conduct epidemiological studies, cross-sectional studies with real world experience across the nation in Yemen to determine the real rates of suicide, real rate of lack of mental health issues. And this is, by the way, highlighted by Dr. Tawfiq in his paper and also in our letter to the editor. This is regarding the data. I will get the link of the paper now.
Thank you. And just that following question about what do you think the difference between the suicide rates in males and females? That's quite high and quite an unusual difference. I don't think you see that in many other countries. Any ideas from your research as to what might be the reason? Is it conflict or?
Yes, Dr. Anne. Actually, I studied this and examined this point in details. The methods of suicide, the methods of beliefs. For example, there is a Yemeni female just published her face picture on social media, made her take suicide, just publishing her face image. The Yemen population is a very conservative and very religious population, especially regarding females. There is there is I even this proverb was mentioned by Dr. Tawfiq in his paper. Burn with honor. Yeah, means burn yourself, but to ensure your honor. Burn yourself alive, but ensure your honor. This is a very popular proverb in the Yemeni population. يعني commonly in the Arab countries, especially in Yemen, we have a very conservative honor regarding females. We see our females an honor for for our families. So any disrespect or any cyberbullying for females can make them get suicide, especially in Yemen. This is all in the paper published by Dr. Tawfiq. I will get the link for you now. Also, males, the ongoing conflict affect negatively the employment rate, education, getting jobs. So all of this increasing the suicide rates in males, especially they are the backstone of families regarding getting monies, food, etc. for the children and the family. There is a very different variation between the between the two genders.
I have a few more questions for you. So, Dr. Abdul Walid was wondering, how best do you think Yemen can shine the light on such an important problem, tackling the consideration of stigma and the lack of data on it? So it's really about how do we raise the profile of the challenges of mental health in Yemen?
I think there is an urgent need to disseminate accurate medical information regarding the Yemeni social medias through local communities, especially in the rural areas. Rural areas needs an urgent need for mental health awareness, especially with about 70% of the rural populations having unemployment and illiteracy.
Okay, thank you. And
Also,
one more question. What? Sorry.
never mind.
One more question. Do you think training of family medicine doctors on mental health and early detection could help in preventing suicide?
Yes, especially in the light of the severe shortage of psychiatrists in Yemen, this can even GPs, general practitioners in Yemen, can help in detecting these issues. I think it's easy to be tackled and addressed by the general practitioners, the family medicines, any doctors in the medical field.
Thank you. So I don't think I have any more questions coming up, but thank you very much, Dr. Ramos. It's a really important topic, and it's an area that we don't talk enough about. So I think it's really good that you've highlighted it and the work that you're doing. So thank you very much indeed for your presentation. And if you want to put the link in the chat, I'm sure everybody would really like to see it. So thank you very much.
Thank you so much, Dr. Anne, for the organization and the presentation. Most welcome in time. I'm honored and pleased to be among you.
Thank you. Thank you. So now we're going to have another break and we will start again 2 o'clock UK time, 4 o'clock Yemen time. And the next talk will be by Dr. Abdul Karim Said Al-Hamdi on digital health in the pandemic. So Thank you all very much and look forward to seeing you all in half an hour at 2 o'clock UK time, 4 o'clock Yemen time. Thank you very much. Good afternoon, everybody, and I hope you had a good break. So we're now going to resume our afternoon programme. We have Dr. Umar Abdulkarim Said Al-Hamadi, and he's going to talk about digital health in pandemics. Dr. Omar is a biomedical scientist and serological laboratory technician at Al Muthada Veterinary Unit, Barbara Port. He's co-founder and chief executive officer of Cobsi Company, sorry if I pronounced that wrong, and he's program coordinator within the Global Health Focus. So I'm sure this is going to be a very interesting talk and help us think about how we use digital to enhance our work for the future. So if I can hand over to Dr. Omar Al-Hamadi. Is Dr. Omar there?
Hello, can you hear me?
Yes, I can hear you.
Yes, I can hear you.
Have you got slides, or do you want to share your screen? Great. Welcome.
Hi, Dr.
Great. So over to you. Look forward to your presentation.
Yeah, I missed the introduction, so I got a problem with the Bluetooth device. So
I just read out all the important things that you've done, but I may have pronounced your company wrong.
Okay. Okay, thanks, Luani. And thanks for all attendees in this significant and remarkable event. And with all appreciation and gratitude to like all efforts collaboratively made for Public Health Conference 2025. It is an honor for me to be a part of this as a guest speaker, and also an honor to present before you today what digital health, also exploring the pivotal role of these tools relevant in mitigating and managing pandemic.
Dr. Omar, can you maybe go a little bit closer to the microphone? I think some people are having a bit of difficulty hearing, or maybe turn it up. It's a bit muffled, yeah.
Can you hear me now?
Yeah, that's much better. Thank you.
Yeah, okay, thanks. I used to say it's an honor to be, for me to be a part of this as a guest speaker, and a privilege for me to present before you today what digital health and exploring the pivotal roles of tools relevant in managing and mitigating pandemic in a world where health crisis can transcend borders. The integration of this technology into healthcare has never been more crucial. During this session, we will delve into digital health technologies, and we will explore how these technologies can transform our responses to public health emergencies, and also how to empower our communities in their health journey. As reflected before during the previous sessions on lesson learned from the previous pandemic, let us consider how to harness the power of digital health to build a resilient healthcare system, particularly in a region like Yemen, where challenges are compounded by conflict and limited resources. Of course, together we are going to shape the future.
Sorry, Dr. Omar, do you have slides?
Yeah, sure. Of course, we have slides.
Do you want to share your screen?
Yeah, I'm going to share it.
Thank you. And if people in the chat could just let me know if the sound is better now for you, that would be helpful.
Can you see the screen now?
It says it's coming. It says double click to enter full screen mode.
Okay.
I don't think it's quite in full screen mode yet. It's not in slide presentation. Yeah, it's still not in slide presentation. Maybe IT can help.
Is it shared now?
It's shared, but it's not in the slide presentation format. You might need to just put it into slide presentation.
We just give it a few minutes.
Yeah, it's just in speaker's notes as opposed to slide presentation.
Can you see it now?
Yes, that's great. That's
okay.
You pressed the right button. Well done. Thank you.
Okay. Like some the network, it's a little bit heavy, so some issues is raising. So the session this is talking about digital health. Digital health, it's an emerging term and promising field in the upcoming era. Is defined as the use of technology to enhance healthcare services, to improve the outcomes delivery, and increase access to care with capacity ranging from prevention to treatment. It's a systemic application of information and communication for data exchange, and also exploiting the computer science and digital discoveries to support the informed decision making by individuals, healthcare workers, and the healthcare system in general. It includes tools, devices, software platforms designed to diagnose diseases, to manage illness, to also identifying risk or identifying health crisis, and also to enhance the overall wellness of or the overall wellness and quality of life. To make it simply, it's digital health. It's an intersection of telecommunication or the ICT sector and also the health sector. The relevance of digital tools to pandemic is that these tools is represented by the capacity to support the prevention, management, and responses to pandemic. The digital health play crucial roles during pandemic by enhancing healthcare delivery and management in several ways. First of all, we have remote monitoring and care, also data collection and analysis, public health communication, resource management, patient engagement, early detection and surveillance, and also to combat misinformation and provide an accuracy with the information provided, especially with social media. And we will discover one by one how these technologies can combat the misinformation. The key component of digital health for pandemic include 8 tools. This is the first one is telemedicine and telehealth, also mobile health application, wearable devices and sensors, data analytics, electronic health records, artificial intelligence and machine learning, Internet of Things, and also blockchain technology. First of all, telemedicine and telehealth. Telemedicine, it's remote clinical services that allow healthcare provider to provide remote consultation and consult with patients via video or phone. It's a broader term encompassing telemedicine. Telehealth. It's a broader term encompassing telehealth, which include other remote health services such as education and health information. The key role of telemedicine and telehealth is crucial because it increases access to care, especially for those in remote area or patients in quarantine. This technology also can ensure the continuity of care and also an ongoing management of patients with chronic conditions, especially without a need to in-hospital visit. Also, it reduces exposure to to the virus because this technology can lead to no need for hospital visits. So it like minimize the potentiality of virus transmission. Also, it provides patients with information about symptoms and preventive measures. It engages communities through online health workshops and resources. The benefit of telemedicine is to enable remote consultation, diagnosis, treatment, overcoming geographical barriers, and reducing risk of infection transmission. The use case of this technology is crucial because patient can receive health services and timely intervention, which is crucial, given the security risks when traveling from one place to another, especially for a context like Yemen, and also due to the infrastructure damage. The impact of this technology is to improve access to healthcare, especially for vulnerable population like pregnant women and children. Indeed, the impact of this technology extend beyond merely increased access to care only, as this technology demonstrates its potentiality demonstrate its potentiality as a key solution to provide or to overcome barriers, and also addressing a specific condition, especially in Yemen. Like, for example, Dr. Amani Shaybani, an oncologist from a clinic in Daesh Governorate, has reported via direct relief. She indicated that shame and embarrassment is an additional factor. Considering that, she said this woman came to her clinic with a breast cancer at advanced stage. The reason behind that is women is always feeling shame and prefer to hide symptoms until they become untenable. Like, considering the context of telemedicine and its capacity in providing remote consultation, this technology can help women to receive consultation and ensure timely intervention without shame or embarrassment, which prevent breast cancer from advancement or exacerbating and reaching an advanced stage. The second technology of digital health is mobile health application, which is an app that provides health-related services and information directly to the user's smartphone. The mobile health application play a crucial role by allowing users to report symptoms and receive in turn guidance on the next step. Also track the infection rates and symptoms in real time to improve to improve the epidemiological understanding. The second role of this technology is to deliver educational content and reminder for preventive measures such as vaccine. Also to aggregate data from users for public health analysis and response planning. And also mobile app can disseminate information timely about the health guideline and vaccination efforts. Other benefits of this technology is to facilitate health education, appointment reminder, medication adherence, and disease surveillance. The use case of this technology is to disseminate information, as we said, and also to promote preventive measure and vaccine campaign. The impact of this technology is to empower individuals to take control of their health and make informed decision making, and also improving public health awareness and response. There are many cases reported for during the previous pandemic, especially in Yemen. And this technology demonstrates its potentiality to address all these challenges with a benefit. It's important to note that telemedicine and mobile health application is not just a technology that increase access to care, but also it reduces the cost of services. Like, for example, CSAIM Medical Care, which is a telemedicine platform based in UK with 36 specialty, can provide more than 383 services at the day of the visit. The key performance indicator of CSAIM indicate that the mobile health application was rated 4.9 on App Store, and also the services provided gained 95% of the patient satisfaction. The cost reduction of services provided by CSAIM compared to the national average cost is actually astonishing. Like, for example, the cost of prescription refill is $37 with CSAIM Plus, compared to $191 with of the estimated national average. In contrast, the cost of therapy session is $80 with CSAIM, compared to $275 compared to $275 of the estimated national average. Also, the cost of MRI without contrast, it is $278 with CSAIM, compared to $786 of the estimated national average. When we calculate the cost reduction rate of these services, CSAIM was successfully reduced the cost by 92, 78, and 78.14% respectively. Wearable devices. Wearable devices is devices that monitor health metrics such as heart rate, oxygen level, respiratory rate, temperatures, and more, and provide a real-time data. An example of this technology is like smartwatches, fitness tracker, body temperature monitor, asthma monitoring, Google Glass, Microsoft HoloLens, and more. This technology helps to track vital sign and alert users to or healthcare providers to potential health issues. Also, it gathers data from patients for research, especially when studying the disease pattern and patient responses. Also, it encourages proactive health management and lifestyle changes. The benefit of this technology is to monitor vital sign, activity level, physiological data, and enabling early detection of health issue and remote patient monitoring. The use case of this technology can be used to identify, as we said previously, early detection of diseases, especially for COVID-19. And allow timely intervention and reduce burdens on healthcare facilities. Technology number 4 is data analytics, which is tools responsible for processing and examining data set to draw insights, to make a conclusion, and to inform decision making. This technology plays a crucial role in analyzing trends to predict future outbreaks and resource needs, also monitor disease spread and healthcare system capacities in real time, also evaluating outcomes or assessing the effectiveness of interventions and inform future strategies. These technologies can be integrated together with other digital technologies, such as digital platform, and together with wearable devices can collect data for analysis and provide like an outcomes or findings from this analysis, which can be disseminated through these platforms, especially for public health authorities platform. The benefits of this technology is to analyze health data trends, predict outbreak, and optimize resources allocation. Data analytics can track the spread of infection diseases, identify high-risk areas, and inform public health intervention. The impact is to improve decision-making and enable targeted responses to health crises. Technology 5 is electronic health reports, which is a digital version of patient's paper chart containing like health information of these patients. This patient's medical chart can be shared across different healthcare settings, providing a comprehensive and up-to-date view of their medical history. And actually, this technology go beyond this because some functionalities can be included to enhance the patient care and streamline the healthcare process. The role of this technology is to enable quick access to patient history for informed decision making, facilitate information sharing among healthcare providers, improving coordination of care. Also, pandemic tracking, it support monitoring of disease and prevalence, and also healthcare utilization during outbreak. The landscape of healthcare system indicates a great disparity and variation in the reporting format, like facilities have different formats in reporting, which make difficulties for public health authorities to process this data and analyze it. However, electronic health records represent the key solution as it provides a unified format for reporting and streamline the dissemination of reported cases with infectious diseases to public health authorities. The key benefits of this technology is rapid access to patient data, improved coordination of care, enhanced public health reporting, support for telehealth, data analytics for decision making. The use case of this technology is for symptom tracking and diagnosis, vaccine management, chronic disease management, contact tracing, patient education and engagement. The impact of this technology is to improve patient outcome, increased efficiency in healthcare delivery, enhanced data sharing for public health, support for research and policy development, strengthen the healthcare infrastructure. I think there is a mistake with the pen on the screen. Technology number 6, artificial intelligence and machine learning. Artificial intelligence is a broad field encompassing techniques to enable machines to perform tasks that normally require human intelligence. It's a set of technologies that enable computers to perform a variety of advanced functions, such as the ability to see, to understand, to translate spoken and written language, to analyze data, and to make recommendation, and more than that. The machine learning is a specific subset of artificial intelligence focused on enabling machines to learn from data without explicit programming. The machine learns by itself. So artificial intelligence is a broader term and a wide field, while machine learning is a subset of this field. The key role of these technologies is disease prediction, diagnostic and screening, treatment optimization, drug discovery, resource allocation, public health communication and surveillance, contact tracing and monitoring, predictive modeling, and patient engagement. Like, for example, machine algorithm can accelerate the drug discovery and development because it predicts how compounds can function or behave in the body. The benefit of this technology is to assist in diagnosis, treatment recommendation, drug discovery, and improving diagnostic accuracy and speed. Also, it can be used to assist in interpreting like the X-rays and CT scans results and indicate the like the finding from these diagnoses in like a real time. The impact of this technology is to enhance efficiency and effectiveness of healthcare delivery, and also to enhance data analysis and decision making. Technology number 7, Internet of Things. It's a network of physical objects or things that are embedded with sensors, software, and other technologies to connect and exchange data with other devices and systems over the internet. This connectivity allows everyday objects to collect, to share, to analyze information in a real time. For me, I like this technology. It's like a motherboard, but it's like in a broader term. Like the meaning of this technology compared to the other technologies of digital health, Internet of Things is the motherboard for all these technologies, whether devices, software, sensors, systems, and like that. The role of this technology is to enable continuous health monitoring and to track vital signs, provide real-time data to healthcare providers, also to optimize the hospital operation, such as bed management and equipment tracking, and enhancing efficiency during a surge in patient. Internet of Things also facilitate the collection of a large data set for research and analysis, aiding in understanding the disease spread. The benefit of this technology is to connect medical devices and systems, enabling seamless data exchange and remote monitoring. The use case of this technology is to monitor patients with condition at home and transmit data to healthcare providers, which facilitate a timely intervention. Also, the impact of this technology is to improve patient outcomes and reduces the need for hospital visits. The last technology of digital health for pandemic is blockchain. Blockchain is a type of distributed database or a ledger shared over computer network nodes. It is different from the typical database in the way it stores information. Like it stores information inside the blocks, which connected together via cryptography. This technology are best known for their crucial role in cryptocurrency system, especially in maintaining security and decentralization of records of transactions. But the use of this technology extend beyond that. This technology can make data in any industry more immutable or more interchangeable. Means that data entered to the data entered to the database with with technology like blockchain cannot be changed like twice. The benefit of this technology, it is advancement in database mechanism, which allow transparent information sharing and also promote accountability within a facilities network. The role of this technology is to ensure secure storage and sharing of patient information and data, and protect these data from breach and ensuring privacy. Also, it enhances transparency and accountability in the supply chain, especially for medication and vaccination, by tracking their provenance and distribution. Also, this technology can create a more secure and more interoperable system for electronic health records, which allows seamless information sharing and exchange across borders. So the benefit of this technology is to enhance data security, privacy, and interoperability. The
Doctor,
impact,
is this the last screen?
still some points, but if time's finished, it's okay. We can summarize that.
Yeah, sorry. The next speaker's there, but I think that's really interesting. There's excellent presentation, and I leave people to read what you said, but I think there's a few questions that maybe we have time to take just before the next speaker. Thank you very much for a very comprehensive presentation. And then some of the questions I think are really important. Is there a conflict between traditional medicine and doctors with development of medicine and technology?
Can you repeat the question?
Oh, sorry. Is there a conflict between traditional medicine and doctors with the development of medicine and technology?
For a landscape, for a context and a landscape like Yemen, there is a conflict in that, especially in the concept of digital health in general. During the previous year, I tried many times with IT specialists and program developer to take some initiative to lead that. But actually, all I met with IT specialists like have no idea about digital health. So it was a big challenge in leading and developing this technology. So for me, I recommend two approaches to lead and ensure the adoption of this technology, especially in Yemen. First of all, is promoting a multidisciplinary approach, meaning that IT specialists can have knowledge and experience in the health sector. Also, at the same time, doctors, healthcare professionals should have skills and experience and knowledge as an IT specialist and program developer. The second approach is to update the educational curriculum in university. Thank you.
Thank you. So I've just one last question, just a quick response. I think there's some comments about the challenges of the internet in Yemen. And so if you had to choose which one of these digital health lists would be the most appropriate for Yemen, given the challenges of the internet and the lack of, the lack of internet in many cases, as
I think
some of our speakers not being able to make it. So which one, just give us one technology you think there's a chance of going with first?
one technology for
Yemen.
I think telemedicine.
You think, sorry?
Telemedicine.
Telemedicine.
Telemedicine is really crucial. Yeah.
Thank you. Thank you very much, Dr. Omar. Really interesting presentation, and I think lots of thoughts for the future. Challenges, I think, will be in implementation in Yemen, but I think, as you say, maybe start with telemedicine. That's a good start, and I think some people have already started on that side of things. So thank you very much. Really interesting presentation. So we're now going to move on to our next speaker, who's Dr. Fakhri Douab. Welcome. He's going to talk about neglected tropical diseases in Yemen and pandemics. Dr. Fakhri is a global expert with over 20 years of experience in managing health interventions, policy design, and leading teams in conflict-affected settings. Senior role in WHO in nutrition during emergencies, and now serves as program manager in DJAEV focusing on institutional development, healthcare reform for Yemen's vulnerable population through linking Yemeni doctors in Yemen with local health institutions to improve access and quality of care. And I guess you use telemedicine. So, so that's great. So thank you very much. I'm going to hand over to you. As an academic, he's based in Heidelberg University. Thank you very much, Dr. Bekri.
Thank you, Anne. Can you hear me very well?
Yeah, we can hear you well, thank you.
Yeah, I will share my slide now. Please confirm if it's well
It's there, but it's not in slide presentation.
now.
And not yet. Yes, no, it is. No, it's still in next slide. It's not quite in slide presentation. It's showing the next slide.
Oh, I don't know. Is it?
No.
No.
Yeah, it was there for a second and then it, no, not yet. We love technology when it works.
Now it's on the presentation now.
It's still showing the next slide, so it's not on the full presentation.
I don't know.
No, not yet.
Stop sharing and try again.
The presentation was coming up, it just wasn't quite in slide presentation mode, but we could see it.
And now also small.
Brilliant, thank you. We're set up, ready to go.
Yeah, sorry for that. Okay, actually, I work on many neglected tropic diseases, but today the plan to talk about the health system capability during the COVID-19 pandemic and the preparedness in Yemen. So I tried to extract some lessons for future pandemic. Using my publication, I tried to have some or 10 lessons actually. I'll start with the introduction, which I think everyone talk about the introduction, but to remind ourselves that Yemen was in a pre-existing vulnerability situation, conflict, and human crisis. Also, we have fragile health infrastructures. Um, and in addition to that, malnutrition, dengue, cholera, COVID, malaria. And for that reason, we are here now to talk about some lessons learned from all that and to extract some actionable lessons for future. If I come to the first lesson that we learned during the COVID-19, case management required systemic readiness. So what happened during the COVID pandemic? There was a shortage of essential medicine and trained staff. There was also fear among health workers, no approval national case management protocol in 2020. So from these issues or problems, we can extract the lesson that effective case management is not just clinical, It depends on logistic, workforce protection, and system-wide coordination, because we saw that there is some also weaknesses in the clinical management, but also the logistic was the big issues at that time. What's the future implication? We can talk about the preposition of emergency clinical protocol. We also talk about the personal protection equipment, stockpile, and surge staffing plans. So the support also modular treatment by maybe international organization that will help to have like mobile response team in conflict affecting areas, especially the rural area in Yemen. If we go to the lesson number 2 that we talked about during the COVID-19 is the surveillance system. And what happens at that time, we all know about the electronic disease early warning system was there since 2013, but the system was not cover whole Yemen or whole health facilities. So at the time of the COVID-19, it was only covering 37% of the health facilities. So what's the lesson that we learn from that? We need expansion of the surveillance is very important. We need to invest on the decentralized data system, and that's will help a lot, especially in fragile or in conflict situation. What's the implication? We or the government of Yemen and the national community in Yemen can prioritize the digital health monitoring, particularly in low in low resources or in rural area. And we say that here also we can mention the telemedicine can help also in that way in the rural area. Um, Lesson number 3, build a local laboratory and diagnostic capacity. So what happens, we saw scarcity of PCR machines and the reagents, and it was only in 1 or 2 government in governorate in Yemen. So having this PCR techniques should be actually more in all the governorates. We can say decentralization of this. And also to have emergency procurement protocol ready for any future pandemic. And that's maybe need support from the international community to invest more on the local diagnostic infrastructure in Yemen, not only on the case management or to be only responsible for the case management as we see since 2015. Lesson number 4, health security require functional borders. What we saw during the COVID-19, poor compliance with international health regulation and no isolation at the entry point. And we know that Yemen is an entry point for the refugee from the Horn of Africa. And unfortunately, all the borders without any health services or isolation points. That's why we always talk about that, not only during the COVID and but also cholera was spread in the same similar way. What the lesson? Fragmented governance undermine border health control. So need for future to have really plan, including the cross-border health strategy and partner coordination at the border in Yemen. If I come to lesson number 5, I'm talking here about international health regulation. The core capacities need to be localized. So we know that there is limited capacities in Yemen. The international health regulation capacity is really limited, and even if there is some capacities, it's centered in the capital cities. So we don't have and I mean s- strong capacities at this level. That's why I asked also this morning Dr. Sururi about international health regulation and if the FATP will be strengthened by international health regulation and implemented in all the governorates. The lessons, as I said, I mean, international health regulation should be adapted at the in all levels and should adapt the guidelines and build the capacities in this situation, especially also in the rural governorates in Yemen. Future implication, we said regional and international health regulation. As I said already, we should be context sensitive technical assistance. We have to encourage flexible compliance pathway and monitoring framework for conflict affected countries, countries in general. But I mean, in Yemen, to maintain momentum without penalization. So this is about international health regulation implementation in Yemen. I go here for community part, and we are talking here about lesson that we learn from the community. Community trust is not optional in Yemen. And we saw during the COVID-19 weak public communication, depending on individuals or NGOs initiatives, and it was not really institutionalized under the Ministry of Health or Ministry of Media or any other sector, governmental sector. So that's an issue which should focus on the risk communication during the pandemic, and it was only ad hoc, unfortunately. The lesson learned, risk communication and community engagement must be institutionalized and cultured, grounded, and that's really a very weak point and ignored area in Yemen. For future implication, we say that risk communication and community engagement, training, and invest are critical as a biomedical response. I mean, we should not focus on the hard programs and forget this communication and also community engagement during the outbreaks. Related also to the community and communication, I'm talking here about one of our research about infodemic management and as a core functional. And during the COVID, we all know that a lot of rumors spread during this pandemic, and misinformation, lack of transparency lead to public disbelief and social pressure against compliance. So the lesson that we learned, infodemic control must be embedded in emergency response framework, and any plan that developed in Yemen should put infodemic part of it, not ad hoc. And what's the future implication? The government and health agencies should institutionalize infodemic management unit that combine media literacy, behavioral science, strategic communication, and focus with the rural area as well. Investment in real-time rumors monitoring system and community engagement fact-checking network with critical during future health crisis. I know there is some efforts to tracking the rumors in Yemen right now, but still very limited. If I go to the lesson number 8, I've talked here about the health workforce. Workforce. So the protection of the health staff was really notable during the COVID-19. There was no PPE, and there was a lot of fear, as I mentioned, that affected the case management. The lesson learned, as I said, protecting staff is fundamental to sustain care delivery. The future, we have to put this in the stockpile and frontline support during outbreaks and pandemic. I will go to the lesson number 9, which is coordination. Coordination can compensate for weak system, and that's what actually WHO trying to lead in health cluster, support the coordination, but also we have different clusters led by UNICEF and other UN agencies like WASH, Nutrition, and that's all trying to support the national efforts to combat the pandemic. What's the lesson learned is leverage humanitarian cluster and multi-sectorial task force can sustain response in Yemen. And yes, this is we want to say multi-sectorial action is really needed because fighting or combating the pandemic or any health issues is not purely health issues, but should have different sectors collaborating and coordinating to get better result outcome. Future implication formalize this collaboration in national emergency framework. Last not least, the fragmentation undermine system, undermine the systematic resilience. And this is really one of the biggest issues in Yemen, as we saw that we have. This is a result of one of our study about Yemen. We have here 6 interlinked forms of fragmentation: political, structural, intersectoral, financial, governance, and agendas related. And all this weekend, Yemen capacity to mount the unified pandemic response. So also the lesson that we learn from that pandemic rebellion and response are not just technical issues. They require really systems level coherence across stakeholders and sectors. So we need to work on strengthening the health system. What's the implication? National health strategy must develop through collaborative governance platform that bridge gap between humanitarian and development and include or involve local authorities. And here we are, I'm talking about the, having this shifting from humanitarian to development as it's really important, and also to strengthen the national support or national domestic financial support to the health system will be really great to try to not be fully dependent on the international organization. Support health system integration and policies to be harmonized within the all international or national technical support. So that's what I want to share today with you in this presentation. And yeah, we are looking for better future for Yemen and all the world. Thank you very much for listening.
Thank you very much, Dr. Fricker. Really important lessons there. And I know those are lessons for Yemen, but when I was involved in the COVID outbreak in the UK, I think many of those lessons could also be learnt within the UK setting. So we've got a few questions for you. Many thanks for your great lessons. And I think 2 questions are focusing on, so you've given us 10 recommendations and 10 lessons. Which would you prioritize of the 0 to 10? Which one would be your priority to start thinking about?
With the last one, the health system strengthening.
Okay, so health system strengthening. And another question from Khalid. Which area do you think there is more need for more local research evidence?
Yeah, actually, all the areas that I mentioned, yeah, we have really scarcity evidence in that. However, focusing on the health policies, analyzing the strategies and the policies, the previous and the current one is really very important and crucial at this point, because we want to learn from our lessons and mistakes in the previous, and that's unfortunately all the time we repeat the same plans, same policies, and in my opinion it's not really effective, and need to more be have, I mean, analytic or critical analysis for these policies and strategies. And I wish most of the new research coming from the Yemeni students and researchers focus on that area. Yeah.
Thank you. So another question is from Kokab, and it's probably quite a hard question in many ways. You might have answered it. Do you think in our situation in Yemen, with political instability, war and hunger, we could implement these recommendations?
Yeah, if there is we can implement, but yeah, it need a lot of I mean, we have to put the recommendation, and then we see how to adapt this according the place. And in Yemen, unfortunately, we cannot copy paste the same method for all regions. And for anything, this is a, like, general recommendation, but each area need to adapt. And that's why I focus in most of my recommendation on decentralization, because I don't see the things that will be implemented in Aden can be implemented in Shabwa or in Al Jawf or in Marib. So yeah, also to have to implement this, we need also financial resources. We need human resource. We need strong health authorities or local authorities in general. So there are many factors that may affect the implementation of this recommendation. Yeah, yeah.
Great. Thank you very much, Dr. Fricker. You've highlighted, I think, a really important strategic approach to answering these problems. But as you say, it's a challenge, but I think it's really important, the focus on local as well. And I think sometimes that's forgotten, local solutions for local areas. So thank you very much indeed. We'll be moving on to the next speaker, and there may still be a few questions for you in the chat, so you might just want to see if you've any words of wisdom that you can add into the chat as well. Thank you. Thank you very much, Dr. Fikri.
Thank you very much.
Okay, we're now going to move on to a talk by Dr. Hassan Batis. I hope he's there.
Thank you. I'm here.
Brilliant. Welcome. Welcome.
You hear me?
Yes, we can hear you. Thank you.
Thank you.
So, Dr. Hassan Batter is going to reflect on a Hadramaut initiative against corona efforts during COVID-19 pandemic. Dr. Battis is a pediatric hematologist, oncologist at the Oncology Centre of King Saud University Medical City. He's a special interest in neuro-oncology, HLH, myelofibrosis, an active member in development of clinical practice guidelines in the centre. He's a founder of the Yemeni Pediatric Hematology Oncology Alliance Group and founder of Health Education Club at King Saud University Medical City and founder of the Hadramaut Telemed Organisation and Yemen Telemed Project. Thank you very much, Dr. Hassan.
Thank you very much for your introduction. And I'm proud to be with you in this prestigious conference. Thank you for all the committees and the organizer for this conference. So it's just a brief about what has been done during COVID by this initiative. Actually, I'm a member and it was a big team that time. It was led by Dr. Omar Al-Khambashi and many of other specialists in the field. And it was actually thousands of hours, thousands of dollars have been spent and a lot of efforts from the people in the field. So we'll just talk maybe a few minutes about what, and briefly what has been done. There was a clinical activities, scientific conferences and webinars, as well as educational awareness for the public, and many equipments has been supplied to Hadramaut. Either Hadramaut, we have, it's as you know, the biggest governorate in Yemen, almost 1/3 of Yemen size. So regarding the educational activities and or the clinical, we started doing like workshops for the physicians on Sayoun and Mukalla, and it was about to discuss the protocols, the diagnosis, the management of patients, and actually it was connected together with the centers treating COVID, and it was weekly every Saturday. So this was the first scientific committee, which was started on June 2020. Then the subsequent workshops has been done, and it was discussed COVID-19 guidelines update every time, discussed challenging clinical cases from both Mukalla and Sayoun, the big areas of the big two centers in Hadramaut, and importance of data registration. And we have a good two registries, one in the Wadi, one in Mukalla. And we discuss as well as that a registration for the specialist, in a way to give a direct consultation to the physicians and to the patients in Hadramaut at that time. So there was a subsequent on every Saturday, and this was maybe the fifth week, and we have actually a heavy conference that day. It was more than 4 hours. We discuss a lot of things and a lot of difficult cases, as well as surveillance issue and how we can apply the COVID-19 guidelines. And we conclude with our specific guidelines for COVID-19. And so on, we have these all scientific talk still there on either website of YouTube and Facebook and X of the Hayak Hadramaut Initiative against COVID-19, and you can go through it one by one. So these are the subsequent weeks, week 17, week 18, and then we have after the on 2021 we discussed that the difficult cases and the complication of COVID after almost at end of the pandemic. And then we discussed about the health researches in Yemen, and what's about the prioritization of health topics, and setting of health research objectives with experts like Dr. Hamdi, Dr. Amin, Prof. Amin Bawazir, and we have Dr. Mubashir Chaudhary with us on one talk about health training priorities in Yemen, and what's safety of patients and health professional in time of COVID-19 and beyond, Dr. Khalid Sremi. And this was as one of the talk that's people from Seoul with us, the physicians on their on direct contact. So again, we have a scientist of virology, Dr. Talal, about COVID-19 virus in the vision of virology, and Dr. Hamdi again regarding medical research in Yemen. So all this is our YouTube, as I mentioned, based all of the almost 30 weeks of discussion are still recorded there, and anyone can return to it. We conclude all this discussion by making a COVID-19 clinical practice guidelines. This is a local or how to modify the COVID-19 practice guidelines to Hadramaut and Yemen in general. And actually, it was a good effort, and it was disseminated to Hadramaut and everywhere, and people can get it from this is a preprint organization. About from the clinical and scientific efforts, we have educational efforts like this about face mask and infection precautions. And actually, we did many of like innovative infographics and short videos to deliver the message about infection precautions for COVID-19. And these are some examples, and even through the media, we got contacted with them, and we started working through like our local media. One of the big, or one of the best for me effort which has been done is we trained women there to make a professional face mask. So this was actually we or the team have give them everything, support them while all initially like workshop how to make a good face mask, and then we give them all the support to make it, and almost around thousands of face masks have been done. And it was also like a financial support for those families to make, rather than to get a face mask from outside Yemen. So we make our face mask in local face mask. So, and then we started distributing this face mask everywhere in Hadramaut. And these are examples of together working with the people in the field for a high quality face mask, which has been done that time. So regarding the equipment issue, we have been we were lucky to have almost provide the Hadramaut Governorate with mechanical ventilators, as well as regarding the diagnosis, the COVID-19 swabs, and we make many combines, and they go to the every health center with oxygen cylinders, and providing even oxygen cylinders to whom for those patients cannot come to the centers. And actually, it was a lot of equipments have been supplied, and we will not forget that we have actually a support from international initiatives outside Yemen, and many of the infection precautions have been supplied to Hadramaut at that time. So this was almost around 8 months of work, and it has been done and we think that it has impact on Hadramaut, especially with the situation of Yemen at that time. I make it in brief, and the time is open for your questions.
Thank you very much, Dr. Hassan. Very impressive, the amount of work that's gone on and the support that you gave to the Hadramaut. So I'm just looking to see if there are any questions. I have one just while the audience thinks of some. Is there an ongoing work? Has it stopped, or is there sort of ongoing initiatives, maybe not related to COVID anymore, but related to other aspects of medical care that your group is continuing with?
Yeah, initially COVID has connected us together. We were before COVID, each one working alone, and with COVID, so we get like a team. And after that, we continued to work, and we started initiative, and now it's organization of Hadramaut Telemedicine Organization, and we hope to make it like a project for Yemen. So actually, this was started after COVID and still ongoing project.
Thank you. A query was about how you worked well between the sort of, how was the work between the sort of local and national government? How did that work? And what are your reflections on what could be improved? Well, somebody said the next pandemic. Hopefully, it's not too soon coming. But what do you think would be, what areas that you think could be really improved, but also that sort of local national liaison? How was that?
Actually, we learned a lot from this initiative locally and nationally, and I think we have many initiatives has been done in Yemen, and we have INTERYem Yemen also regarding the training. I think we should continue training and the training and education and training. This is the key to make things better for any next pandemic. And we have to set up a system. It's difficult to set a system, our healthcare system in Yemen currently, but we have to work with the Ministry of Health and the local authorities there to build a system and somewhere or that make things more better to work. And initiative are still initiative, but doesn't mean or doesn't mean that it will success without the government work.
Thank you. So I have a question here. A note that Taiwan did the similar making of the mask, so well done. And a question from Khalid, how to bring the quick NGO initiative thinking to government and private sector way of thinking?
Sorry, I could not get the question.
So it's about how you're, as an NGO, they were saying, how do you bring that quick NGO initiative thinking into the government and the private sector? So it's about how you can influence for that quick response that often NGOs can do, whereas the government is a bit.
Regarding the Hadramaut initiative against Corona.
Well, I think probably in general, but maybe for the next pandemic that we hope won't happen too soon.
Yeah, actually, it was difficult, and but we are fighting against unknown victims. So everyone work like really a team, and even we get facilities from the government because almost we think that our people will die there without any support. So they opened the doors for us to work, and even Prof. Khalid was with us on that time, and many of Yemeni specialists have been working regarding either Yemeni or Hadramaut initiative. It was initially we thought it will be difficult, but with big efforts, with help of all the team and with the facilities from the government, it was gone smooth. It's not that smooth, but it was have some effect on reflections.
Oh, thank you very much. Perseverance is always very important, isn't it? And just keeping the channels of communication over. open. And then just looking in the chat, they talked about a similar initiative in Kerala, where there was a community program for COVID-19, and there's an article there which is Rethinking State, Society and Democracy, which is very interesting. So I think, is there anything else that you think it would be really good to highlight, Dr. Hassan?
I make it just a brief, just because I'm just one of the team, but I told them we have now a seminar about COVID-19 and pandemic, and we have to raise the flag that we did something during that effort, and we have to continue working together. It's a brief talk.
But a brief but very important, and it shows how individuals coming together can really make a difference. So thank you very much indeed. So we're going to have a short break now, and our next speaker will be coming back to us at 3:30. So a quick comfort break, and we'll start again at 3:30. And thank you again to Dr. Hassan Battis, which was a really interesting and inspiring talk. Thank you very much.
Thank you very much. Thank you all.
Welcome, everybody. I think we've now found our speaker, which is great. So the next talk is by Dr. Mohammed Al Sabri, and he's going to talk about conflict and COVID in Yemen and lessons to avoid another humanitarian crisis, which is really important. Dr. Mohammed, he works in the pediatrics department at Brookdale Hospital in USA. He's also an emergency medicine and critical care consultant at a DTH in Sana'a, Yemen. He's co-founder and past president of the Yemeni Association of Emergency Medicine and Disasters. So thank you very much. If I can hand over to Dr. Mohammed.
Thanks so much for the introduction. It is a pleasure to have me. Appreciate it. As I am not good with the IT, let's see if you guys have my can see my screen or you have the slide with you.
I think it's just about to be. There we go. Its slides are your slides are up now, Dr. Mohammed. So the first title slide is showing. So I think you're ready to go.
Okay, so you guys will control the slide, yeah?
Yes, I think Mubashir will do that. So if you just want to say next slide, please, then I'm sure he'll move it on.
Sure, amazing. Again, thanks so much. I know now it's the last minute. I can imagine maybe everybody's tired, but I promise I will be brief and as I can. Please, next slide. This is my beautiful country. Hopefully one day everybody will visit it and will be peaceful as before, as it's always in the history. Okay, next slide. So the objective is just to reinforce what I am sure you guys talk about, the conflict, the effect, the COVID, and unfortunately the gap that we are facing and in Yemen, and what should we do as healthcare provider, policymaker. Next slide, please. First of all, I have to admit I have no financial or other conflict of interest. Next slide. Why Yemen is matter? I think before the what's happening in Palestine, just in the recent history, Yemen facing the worst humanitarian crisis, maybe in the globally or in the recent history, unfortunately, for many reasons. The situation in Yemen, as we know, one of the worst, as I said, over 1 million people, which is represent about 80% of our population, were in need for humanitarian assistance by the end of 2022. You can imagine how many, or what happened now since 4.5 million are internally displaced. I am sure maybe the number is increasing since then. Chronic underfunding, conflict, all this has been going on for almost a decade. Next slide, please. This is our healthcare system status based on our research. We published, me and my group, maybe more than 6 or 7 articles being reviewed. If anyone interested, just talking about the same conflict in Yemen and COVID and the status of our healthcare system from emergency standpoint. And so before even the war, Yemen ranked among the worst and the lowest on global health indices. Like for instance, physician density, just zero point 0.3 per thousand people versus the global average was 1.6, was a huge difference. For instance, also the infant mortality here about 43.4, which is extremely high. In terms of the immunization status, it's just less than 60% were like covered. Uh, Unfortunately, we don't have full insurance system or it's not fully covered by the government when it comes to the healthcare. You can imagine people living in poverty with multifactorial, and in addition to have some or facing another further disaster like healthcare related issues. So next slide, please. In terms of the infrastructure, unfortunately, As if 2021, only 51 of the healthcare facilities were fully functional, and approximately more than 1,000 health facilities were damaged or destroyed due to direct airstrikes or active fighting. Chronic shortage of all medical supplies and personnel further degraded care deliveries. Next slide, please. When it comes to the like sanitation, water supply, cholera, pandemic, others, as we know, multiple pandemic or epidemics happen because of the cholera, not just in one city, in multiple city and at different waves. Yemen has faced literally the largest modern cholera epidemic with over than maybe 2.5 million suspected cases between 2016 and 2022. Over 17 million people lack access to safe water and sanitation since 2022. Next slide, please. As the ER physician and pediatrician, I can imagine to have someone with all the above like difficulties and challenges in addition to food insecurity like malnutrition is by itself a huge problem. In Yemen, about 2.2 million children under 5 are actually or acutely malnourished, with more than 500,000 suffer from severe acute malnutrition with medical complications, unfortunately, like rickets and others. COVID just disturbed food import and humanitarian accesses. It increased at least 16% in food insecurity just during the first year of the pandemic. So malnutrition, of course, it will increase the susceptibility for infection, complications, morbidity, mortality, extra. Next slide. Now, when COVID hit Yemen, it was unique, like for multi things, because we were under a lot multi wars at different occasion, like different stage, in addition to all the above challenges. So it's not surprising anybody. It was underreported. Like we don't know about the confirmed cases. So on Yemen, that time, I think back in 2022, only worth 15,000 were confirmed and 3,000 deaths. I am sure it was underreported, and in my opinion, maybe more than 95% of the time because of multifactorial things. You can imagine also regarding the actual death, they said here the case fatality ratio was about more than 25. Again, I am sure it should be more than that based on my like communication and touch base during the time of the pandemic with my folks in Yemen regarding treating of were we were lucky to take care of so many unfortunate patients in ICU from the time of diagnosis till time of either discharge or death, unfortunately. And I think we did a good job in terms of utilizing or utilizing the social media, WhatsApp. We'll come to that, like in terms of ICU management and ER extra. But it was a huge problem, more than what we can imagine even. Next slide, please. Now, giving just to enforce what I was talking about, you can imagine in the entire Yemen at that time, only 4 PCR lab were operational nationwide. In terms of the average test rate was only about less than 150 tests per 100,000 population compared to, for instance, I'm not compared to US or Canada or I don't know or UK. I'm just comparing to Egypt and Jordan, like 25,000 in Egypt, 40,000 in Jordan, while in Yemen was maybe less than 150 tests per 100,000. There was no any way to improve it during that time. no supply. There's also the data was really well controlled by other agency, like let's see in Houthi control north. It was very hard to get any information. Even in the other part of the Yemen, which was controlled by the government, it was also for many reasons hard to catch any valid data and to rely on. Next slide. Now, this is, I think I can speak about it clearly because I was following with a lot of ICU physician from all the entire Yemen, north, east, west. We did a great job. I think we did a great job with by building up. We have we had like large WhatsApp group we created just for ICU, attending from all the entire Yemen, also physicians who were interested to in helping patients like from UK, from Germany, from different parts of the world. So unfortunately, again, it was a huge problem. Like we had about less than 500 ICU beds. Can you imagine? Less than 500 ICU bed for about 25 million or 22, or I don't know what was the number at that time, and literally less than 200 ventilators for population of 30 million at least at the beginning of the pandemic. It was a huge problem. Oxygen shortage, frequent power outage, mechanical ventilation unreliable, lack of resource. It was catastrophic, literally. Like some patient, we just decided ourselves to like the best interest to do nothing, like because there was no any even basic thing like oxygen or treating them at home with simple oxygen supply or doing yes, it was basically like palliative care. Or unfortunately, I'm sad to see that. Next slide. Uh, Furthermore, in spite of the keep alarming, we did a lot of lecture online and in person, advocating for vaccination, for the isolation, for other staff. In spite of that, unfortunately, many challenges also were there, including shortages of the vaccines, in addition to resistant, even if the vaccines were available in certain location, a lot of people surprisingly they were totally against to be against vaccination at all, like as an idea, especially in the area which was controlled by the Houthis. uh, Next slide. When it comes to the impact on women and children, you can imagine, I think they were more affected than any other, in addition to elderlies. Like maternal mortality rose from 164 to 248 with death per 100. Like it's a huge increase. In addition, as I mentioned it earlier, about 60% decline in routine childhood immunization for many factors. Interestingly and sadly, we also note that the violence just increased by about 63 during the pandemic. Next slide, please. Now, regarding the healthcare services, I have no idea. Maybe it was working synergistically. COVID just perfectly was working in against our fear with other pandemic. So during COVID era, we did face many pandemic, not just the COVID, the measles, the diphtheria, in addition to the cholera, even see some cases of TB up to my best knowledge. Diabetic hypertensive chronic become lost they lost their access to for medicine for at least couple of months, which just make it worse for everyone. Next slide. uh, we did a study ourselves. It was published, interesting study about the the impact of the COVID in terms of psychological among healthcare provider in Yemen. Uh, and another study, they showed that about 70% of Yemeni population, unfortunately, will suffer from either anxiety or depression or post-traumatic stress disorder during the pandemic. Even the frontline worker. Unfortunately, also the suicide rates just increased significantly during and after the pandemic. Next slide. Now, regarding the healthcare system itself, frontline, can you imagine, according to the WHO, I think at that time we have only 10 doctor per 10,000 people, and it just since then, based on my best knowledge, it's just getting worse. A lot of my college immigrated, unfortunately, to Gulf countries, to other countries, because of the war and because of other condition. And two-thirds of the healthcare worker in North has received no salary since 2016, which is again, it's a major problem. So when I ask other healthcare system, me but personally, I left before the pandemic and before the war for studying and for further like for research and other reason, not necessarily because of the war. But when I spoke to a lot of my friends, most of the time it is not just because of the salary, interestingly. It's just because they feel insecure, they feel unsafe because of the fighting, because of the, sometimes they get threatened by patients, and many times they were attacked, especially as ER. It happened multiple times, especially recently after COVID era. Next. Now, I don't think it is worth it to mention everything without paying attention to the education, especially the health literacy that we've been facing in Yemen since even before COVID. Unfortunately, over 2 million children were out of school even before the pandemic. COVID just led to closure over 5,000 of school, affecting about 7 million students. So loss of school-based health program, including like hygiene promotion, other also spreading of misinformation about the hypocrisy, don't use the myth about the vaccine, the hesitancy. Next slide. Finally, regarding also the fragmentation in our healthcare system. Depending on funding is always a bad idea. It's when your country dependent on more than 70% of our healthcare system in Yemen, just dependent on the donor funded, and you can imagine during the COVID what happened. As like any other country, it's just getting worse. Lack of funds, and it was a major impact in addition to what we had already. Next slide, please. Um, I cannot underestimate the role of the different agencies. They did a great job, I believe, but without having a solid healthcare system in place and having secure like funding, others, backup systems, it will not be efficient regardless. Next slide. In spite of the darkness, in spite of the sad stories that we hear, the number, there were a lot of good example. I can see, at least I know two or three of them here. For instance, in Taiz, they initiated telehealth for training, and they trained over 200 nurses using WhatsApp and Zoom, and it was very effective. Also in Hadramaut, I think Imam were trained to disseminate accurate COVID prevention message through the Friday khutbah, which is amazing, I would say. Next slide, please. Also from in Aden, I think they open very nice like infant hospital during the pandemic, up to my best knowledge, and they did handle more than 500 patients in 3 months. in spite of all the previous, challenges. They said those 80% of those admitted require oxygen. The mortality was about 50%. And they demonstrated some kind of rapid improvement. And I had a friend who are an emergency physician. He was intubated. He was in mechanical ventilator for 2 weeks, but thankfully he survived after with just very very minimum support like this hospital. Next slide, please. Now, if you compare to another country who they were involved or they have some similar condition like war, it's not surprising me or anyone. It's almost the same. Unfortunately, there is no respect for healthcare system, and most of the time they were involved anywhere, wherever in South Sudan, in Yemen, somewhere in Somalia, anywhere. It is the same problem worldwide, not just in Yemen. Next slide, please. Now come to the hardest part of this presentation, which is easy to say, hard to apply. What should we learn? What we could do after this pandemic? I can tell before moving forward, I don't think globally even we did something better, even globally. The evidence is my expectation after the bad experience with COVID, we will become more united, focusing more improving healthcare system, globalization of healthcare, become better in terms of treating such as pandemic worldwide. But what happened is really different. See, immediately after COVID, start to have war, multiple war in Ukraine, Russia, somewhere else. We did not learn the lesson, unfortunately. So I guess it's the same in Yemen, similar. There's nothing really has been changed. I've been asking also here, interestingly, many leader from in the US, like in the emergency department, hey guys, what did you learn from COVID? You was during COVID managing this crisis. Have you ever changed anything? Do you think your hospital implement any policy different than before COVID? Shockingly and sadly, the answer is no. It is unfortunately still the same. I don't know if you guys have different opinion, but this is based on my personal observation and limited research. Next slide, please. Any obstacle bring with it some opportunity. We should learn from, for one of the biggest lesson I think we should improve, I hope it will change. Healthcare system must be respected and must be neutral. We don't care about politics. We are not a politician. We are a physician. We are a nurses. We are here to save life. We don't care about this or that. Keep us alone. This is at least. It should be neutral, and there should be, I know there were so many international humanitarian law, but unfortunately nobody using or following this rule. And this is the problem. Can we build up health safe zones? That's the question. I don't think it could be possible, at least during the coming years. We will need time until changing the mentality of those, politicians. Can you, okay, next slide, please. Uh, in my opinion, depending on funding and on another agency is one of the most fatal mistake any healthcare system can accomplish. So we should strengthen our local capacity. We should not rely on any foreigner agency, because this is non-secure and this is not the right thing. By training, by equipping our local nurses, our hospital, preparing for any pandemic, even with simple things like let's see an example, midwifery, let's safe delivery program in eb reduce maternal death by 20%. I can give you another example. When I was in Yemen, we were facing a very huge shortage in number of the ER physician internationally in Yemen. This is before COVID, before the war, before anything. What we did instead of waiting for someone to be trained for 4 academic years, which is a lot, we build up our diploma like very short, like intense program, about 99 months, was approved by the Ministry of Health in Yemen, by the WHO, and by other agencies in Yemen. It was amazing. The outcome was so credible. Like we sent them to work in rural area throughout Yemen, and it was amazing. This is just as an example. Next slide, please. Supply chain resilience. It was interesting to understand that in Yemen they were relying in terms of the supply on one, I think, company or country. Most of the supply were from India. And because of the pandemic, India also by themselves, Indian, they faced also the same challenges, shortage of supply. So it was a huge problem. It is worth it to mention that, but I don't think it is the main problem here. Next slide, please. Also, I think because we cannot apply the guidelines or the protocols from UK, from US, from other country in Yemen. Each country should have its own, guidelines or protocol policy based on the infrastructure and what do we have, and we should utilize something logic and something applicable. Like let's see for WhatsApp, Telegram, others. I can tell you like it was yes, we were busy maybe 24/7 with building up guidelines, creating guidelines, working together with the our friend in Yemen, but it was very cheap and very effective. Like I unfortunately we don't have any published study to show the impact that we made or what we did, but I can imagine and I can assure you it was incredible. Like giving the outcome, how many patients we were able to discharge from ICU, how many audience we had. We were giving lecture like weekly about education, about like COVID, about isolation, vaccination, healthcare, about home treatment, many things. I have another, as I mentioned earlier, the example from Hadramaut, from Aden, from Eb were incredible, giving the the limited resource. Next slide, please. Community engagement is crucial. I think it was like it was very important from the beginning. We know that without involving community we will fail, and we will able to do to some extent by doing a lot of lecture for non-health care involving those who they taking care of refugees, asking imam during your Jum'ah khutbah to advocate for vaccination, isolation, and others. And I think we should focus on this more and more. Next slide. Now, this is a huge problem worldwide, not just in Yemen. The concept of decentralization, uh, you can imagine Yemen like any other third world countries. Everything is under control and everything is mainly central. Like you cannot do literally anything without referring first to the main government, which was a huge problem here. Next slide. I think if we want to do something better, we should plan from now for further for any coming a pandemic. We know that there is no way that we will not have further pandemic. We will, and it will be even maybe way worse because this is the nature of the disease, the infection, the human, the war. We should be ready for at any time. We need to have like one health approach to anticipate zoonotic trade and climate or effect. We have to integrate very good emergency response, including food, including vaccine, including everything. Next slide, please. If we want also we should understand and start break down doing root cause analysis to understand what was the major weakness of our healthcare system in Yemen, and start breaking down each weak point and try as we can to fix and prioritize our effort. Next slide, please. Now, despite the ongoing conflict, as I said, there were some kind of shine light somewhere from here and there, and most of the time it was like kind of self effort, not necessarily represent the effort from the government or other agency. Next slide. This is just to, I think it is like kind worth it to mention that even though we were under war, we were under, shortage, under all the challenges, still there were some unethical prioritizing of, spreading supply, unequal vaccine across between North and South, prioritizing supply for VIB, for those who they are not, have, versus those who they have no support, which is sad and unethical at the same time. Next slide, please. I have some recommendation for policymaker. I don't think it is different than what everybody said. Just to codify protection of healthcare worker infrastructure, as I said, prioritizing local system, establish decentralized emergency fund, embed pandemic preparedness, and fund operational research in conflict affected zones. Next slide, please. We can also redesign aid model to prioritize sustainability over visibility, fund local agency, bypassing unnecessary intermediate, integrate health programming, push for vaccine equity, ensure data transparency, and allow civil society oversight. Next slide. Next slide. Our goal as healthcare leader to advocate for Yemen in policy, media, academia, support grassroots and dysphoria initiatives, partner ethically with local actors, use our voice to not just to quantify the crisis, to humanize it, to make it like more than just to quantify it. Next slide, please. We should call for action for the next crisis. Yemen's COVID experience is not unique. I believe on that. It is predictable and preventable. Conflict zones must be central, not peripheral, in global health strategy. Humanitarian health should be prepared, not reactive, as everybody knows, inclusive, not selective, resilient, not fragile. And I believe on that if we fail Yemen, we risk failing all future fragile states. Next slide. Next slide. I should end with this. Health is not just the absence of disease. It is the presence of peace, and I believe on that. Thank you so much. Next slide. This is my city, Sana'a. Hopefully, I am looking forward for everybody to visit it once we have peace in Yemen. Thank you for your attention. I am here to answer if there is any questions.
Thank you. Thank you very, very much, Dr. Mohammed. It's very comprehensive, and you managed to depress us, but also I think you managed to raise our hopes by some of the local work that you highlighted, and the how people respond, which is come up in, as you say, in many of the other presentations. So thank you very much indeed. I think there's just one question that that we could maybe pick up before we close the session, which is from Khalid. Is very informative presentation. From your perspective, what should be done first? Improve the capacity and disaster management in Yemen, or what else should we do considering what else is going on?
Thank you so much. Thank you so much.
Hello, sorry, we just can't quite hear you.
I am an emergency physician at the same time. So I will leave it up to those who they are in the ground. Like I think they are better than me to answer to this question. Otherwise, my answer will be focused on emergency standpoint.
Okay, thank you very much indeed. And another comment from Kokab was, I think thinks without the involvement of decision makers and the community, we could not reach a practical solution. So I think that adds to your presentation. So
Absolutely. And in general, I think we cannot move farther forward without first having base. This is, I think, maybe the first thing, to have base, to utilize the resource instead of buying food for those who they are improving the immunity and working together at multinational level at different stage. But the very first thing is base. This is my opinion.
Thank you. Yeah, indeed. I think something that we would all agree with. Peace is so important for all these areas where there's conflict. Okay, I think that brings us to the end of this session. There will be a panel discussion which will start at 4:15 or 6:15 Yemeni time. And I think it's just a little bit of comfort break for people, and then we'll start again in about 6 minutes time. So it'll be interesting to hear what the panel has to say. There's been a lot of common themes throughout the presentations, a lot of sadness, but also a lot of hope for the future. And thank you all very much for your presentations, and thank you for the audience for continuing your participation. And now we'll just have a quick comfort break. Thank you all very much indeed.
Thank you.
Good afternoon, everyone, and thank you for joining us for the final session for today. This is a panel discussion now, and we have 4 distinguished speakers available to us. My name is Nicholas Wong, and I'm an infectious diseases consultant based at the Royal Liverpool Hospital. And with me today, we're welcoming back 2 speakers from earlier. Many thanks to Professor Alessandro De Mertas and Dr. Fakhri Duriab for their excellent talks earlier on. I would also like to introduce Dr. Julian Tang, consultant clinical virologist at the University of Leicester. His area of interest is in the diagnosis, treatment, infection control, and prevention of all viruses that affect human health, including emerging zoonotic and potentially pandemic viruses. These include respiratory viruses, childhood and vaccine-preventable viral infections, bloodborne viruses, transplant virology, and infections of the immunocompromised. His research interest is mainly focused on epidemiology, transmission, infection control, prevention of respiratory viruses like influenza, RSV, paraflu, adenoviruses, and rhinoviruses, and of course, COVID-19. I would also like to welcome Ms. Ofra Al-Muflahi, professional lead and nursing support workers of the Royal College of Nursing in the UK and founding director of the British Arab Nursing and Midwifery Association. Ms. Muflahi has more than 2 decades clinical and nursing experience in various roles in and outside the NHS, in pediatrics, community nursing, quality governance, project management, and quality improvement. She won the 2008 Mary Seacole Leadership Award, which supports nursing staff to improve the care of patients from BME communities, and she champions equality and is the director of the BANMA. She has held board roles in multiple charities and is the non-executive director in the NHS and strives to support innovation and clinical leadership. So at this point, I would also like to thank the audience for sticking with us for the course of a very educational day. So if you have questions you would like to pose the panel or topics for discussion you would like to raise, please feel free to put them in the chat or raise a hand, and I can call on you and read your question out, and the panel can share their views on the matter. Just make sure that our other 2 panelists are here, and then we can get started. All right, then. It looks like we have a question already from Abdul Wahid Al-Siruri. So, yeah, feel free to unmute yourself and please go ahead and ask your question. Thank you.
Thank you very much. I think it is, we all tired after a long day, but it is good to conclude with some recommendation for the future and to see how to best utilize all the minds and all the presentations during this day. I guess to raise an important point that still in Yemen lacking evidence-based data, and we need to work more on ensuring to fill this gap. Since INTERYem is interested in research, and I think it is time to think about the deficiencies we have and how to support Yemeni researcher to conduct and analyze and publish also evidence from Yemen, and just not a gut feeling or things about a lot of topics. Another things, as we discussed in the last conference last week about campaigns for sepsis, I think we need to have another campaign for society. I think these problems in Yemen did not take full knowledge, and needs to raise this topic as a priority for the future, and encourage research, raise awareness, and think how to have shed some lights on this very dark area, which we know little about. These two things are coming up now to my mind, but I think with other colleagues we can have more and more. Thank you.
Thank you for sharing your thoughts. Would any of our panel like to offer a response or your thoughts? Julian, please go ahead.
Hi, Nick. Thanks for inviting me to this. I'm a bit of an outsider because I don't really know Yemen very well, but I've been quite impressed and rather depressed listening to all the talks today. I think there are two things that they need in Yemen. They need the peace, and they need to fund all these different ideas that people have had. Now, I'm thinking in particular there's the surveillance, there's the mental health clinics, there's the telemedicine, and then there's all the infrastructure that goes with that. And you need people, so you have to pay their salaries, and you need the funding to do everything else. And for that to even start, you need peace. So that is not a problem we can solve today. So let me give you a different angle. I'm a respiratory virologist, and I can pretty much predict that the next pandemic will be a respiratory virus. The last 6 or so, if you like, the 1918, 1957, 1968, the Russian leak, 1977, 2009 pandemic, and the COVID 2019 pandemic have all been RNA respiratory viruses. So I think if you prepare for an RNA respiratory virus, not necessarily influenza, which was the mistake that the US and UK made, then this will focus your minds on preparedness. The other issue is the severity, the clinical severity of the next pandemic. So we've been lucky so far. 2009 was very mild. 1968 was relatively mild. 1957 was very mild. 1918 was severe. The current COVID-19 virus is now becoming seasonal, and the mortality has dropped from about 5% at the beginning to like 1% or less now. Of course, in the elderly care homes, which in Africa you don't have so many of, the elderly care homes were the Achilles heel of the developed countries, where massive numbers of the elderly died in those concentrated elderly care homes. So that could be one thing that you want to continue avoiding in an African environment, where the culture is that you tend to go back home where your family will look after you in rural settings, and avoid that concentration of highly vulnerable people. In terms of preparedness, I think the mask making is great. It's been done in Asia as well. I put the example of Taiwan in the chat. Other things that you might consider is that where you do have to impose a lockdown, the community support teams that Kerala had were also very successful in controlling the leak, if you like, of people breaking self-isolation, quarantine, and spreading the virus further. And the other things that you want to avoid, and again, this has been alluded to by some speakers, is to, when you give a message about compliance of lockdown, self-isolation, quarantine, you don't have political leaders who break the rules. And that's what we saw in the UK. And when people start breaking the rules in high positions, everybody else thinks, well, why should we bother following the rules if they don't? And then chaos and anarchy ensue. Now, of course, Yemen has other problems, lots of other problems. And if you have a pandemic where the mortality is less than 5%, to be honest, I've seen a documentary about another African country. I can't remember. It may have been Ghana or Gambia. In the market town, they were interviewing people. This is like early 2020, like July, I think it was. And people saying, what is COVID? Why do we care? We've got TB, malaria, HIV. We have famine. We have starvation. What is this? And is it going to really bother us? So I think the severity of the next pandemic will also affect the response, the public health response. If it's 30%, you will be much more focused than if it's 3%. So that's my kind of 2 cents as a virologist, as a respiratory virologist, in this situation for the next pandemic.
Hi, Nicholas. Can I come in around the comments?
Please do. Yes.
Around
Please.
sepsis. So the previous speaker, articulated the need for that community cohesion and some of the excellent practice that was happening in terms of COVID. And I think, as a nurse myself, I think we mustn't underestimate the power that can be given to nursing staff in the Yemen as well. I think there's probably more that needs to be done for nursing staff and I guess their intervention and how they can create community cohesion and also teach the wider population. And the comment around sepsis is very much around, early detection, spotting the signs very early on. By the time they've presented to or hospital, they're probably very, very sick. What we want to do is empower the population, empower the communities through potentially nursing staff or community staff to teach them about spotting the signs and empowering those communities, which the speaker spoke about in the last presentation. And that way you get sustainability. You don't get that over reliance on medical teams or presenting in already stretched hospitals where the sickest should be going, but I think that requires some global support. So it does require some of our nursing partners to kind of come into the fold and have that dialogue with the wider with the Yemenis and with the movers and shakers within the Yemen to make that happen.
You think it would be fair to say capacity building and investing in people to take the lead themselves, even in war-torn situations like Yemen, would be a good way forward here?
Absolutely, absolutely. And I think, the previous speaker spoke about the use of technology, like a train the trainer approach. And there's no reason why we can't empower nursing staff to do that, to then engage with the communities. They know the language, they understand the culture, they understand the barriers, the potential barriers, and it would be a fantastic way of certainly adopting that empowerment in those communities.
Thank you. We've just had a very sensible comment from Kaukab Al-Haddad. Raise awareness of decision makers, community as a first step towards all these issues is highly needed. Therefore, inviting them for this type of conferences will be very helpful. I couldn't agree more in that regard. I see Khalid Al-Surumi has his hand up again. Please, if you would like to ask a question, go ahead.
Dr. Khalid?
Okay. So here's a question from my end. A lot of our speakers have touched on misinformation and how that was as much of a problem with dealing with the pandemic as, and this was a global thing. Whether you're talking about in the West and relatively resource-rich settings or in places that don't have that benefit in low and middle income countries, misinformation about vaccines, about the virus and everything else seemed to be running rampant. Would anyone like to offer their thoughts about how we counter that in the future?
Maybe I will come to that, but I see Dr. Khalid, he wants to talk. Maybe if we give him a chance.
Thank you. Yeah, I was muted actually. If you allow me, I have to have comments. First of all, I think thank you very much. Actually, it was a long day. Even for me, I was attending parallelly another meetings, but I tried to be connected with you the whole day. Very, very informative, actually, a scientific day. Actually, to take home messages from this kind of important meeting, from public health perspective, even and I agree with Dr. Sururi saying that we need more evidence, but I think to be pragmatic, it's not about lack of evidence. We have enough evidence about everything. It's about moving from evidence to policy and action. And I like what Kaukab said, we need to create awareness among all stakeholders. Who are the stakeholders in this kind of public health endemics or public crisis? everybody is really responsible. But the question is, we are not in a situation that we can mobilize the community in all different levels, from policy perspective, from non-policy perspective, from media, etc. So what I really suggest is based on a person who live outside Yemen, but I am from Yemen, and I'm a professor of health policy and public health. I think what's missing is we look at things in a silos. We need to move from silo thinking to a comprehensive thinking, and I think when Dr. Sabri present things, the issues, he 100% correct. But we need to move in a way that do we have a comprehensive approach that each one can understand, even the policymakers, the clinician, the nurses, the lay people. This one thing. We need to think about how we, as academician and non-academician, we have the language that we can improve public health. And public health is beyond only clinical setting. We don't want actually to wait until patient gets sick or patient are in the ICU. Can we do something outside of it? What pushed me to this? For example, nowadays I can tell you from Yemen, we start seeing many cancer patients. It's not because Yemen is special, but we know what's going on there. People are eating the wrong food. There are a pesticide. There is uncontrolled things are given to the foods. We don't know what's going on, and there is a new cancer patients because of the not only because of lack of healthcare, because of lack of awareness and lack of regulations to prevent using such kind of carcinogenous material. So unless we close this, nothing will happen. One thing. Second thing is we should not actually, and I work with the international donors sometimes, we have to change our mindsets in the developing countries. We should not be driven by donors initiative. We should direct donors initiative to our priorities, not other way around. We have to be innovative nowadays. Innovative in a way we look at the problems from our perspective locally and then tell the donors this is our priority, rather than ask them help us, we need your help. No, this is for me is not a good approach. I would like to close one thing as we should not forget what they are saying, determinant of health in terms of social determinant of health. In Yemen, it's not about only lack of healthcare. It's a multifaceted issues. We have a problem now regarding poverty. Unless we improve the health, economic status of people, improve access to the job, improve access to get something. Otherwise, girls will not go to school. Kids will not be able to complete their education, and then it's kind of think big, not only from her perspective. And that brings me to the concept advocated by WHO. We need health in all policy. Health should be in education policy, it should be in agriculture policy, in everything. With this kind of generation, and I rely on ourselves as a generation of Yemen, so whether we live outside, inside them, to think outside the box. If you keep repeating the same solution for the same problems, we will not go anywhere. We need to think in a different way, how the problem could be addressed differently. Otherwise, no, nothing will improve. So I think we can start somewhere, rely on awareness, yes, but we need to connect the dots. That means there are more than stakeholder who can work. So when you are addressing any problem, for example, talking about infection, so who is really care about infection? It's not only patients and doctors and nurses who are really source of the infection outside the community. How we can do this and that. So I'm thinking, in summary, as we need to think big, comprehensively, and start small. Thank you again, and I think it's about how we be innovative in our solution, and that's the whole idea. Thank you.
Thank you for your insightful comments. Dr. Duryab, would you like to offer any thoughts?
Yeah, bring you myself and audience to your question about infodemic and misinformation. Actually, during any new pandemic or new disease like or disease X, as the WHO mentioned that, always it comes with less information, and that's give this gap brings the thought about it, and the misinformation started from this gap. So the second thing that also we can think about is the distrust of community in the official institutions, and that's what we face actually in Yemen. And the distrust was a big issue. At the beginning, we saw community was committed and compliant to the advices, but further, I mean, with time, they lost the trust and they start this disobedience or break the lockage. So that's the one important things that the information gap, and should be covered with trusted information, trusted messages from the government or from trusted organization like WHO or others in the country with the respected language. So the other thing that I want to talk is the social media, which really amplified the problem of spreading this misinformation and rumors. And in case of Yemen, the high illiteracy rate also among the people play roles, because people, they just read what they received or they heard what through the social media, but they don't go and search for the source and the correct information. Yeah. This is some factors that we really we found it during our research during the pandemic. But there are many factors also behind that, and at the end, I also support the voice talking about the community engagement. That would be the best, and yeah, trying to give the chance for community to manage their issues. And this is in summary. Yeah, thanks.
Thank you. Ofra, did you have something you would like to add to that?
Yes, please, if I may.
Please do.
So we saw some of this misinformation in Yemeni communities outside of the Yemen. So the Yemeni communities that live in the UK, because obviously they have families in the Yemen, and the WhatsApp was generally the way people communicated during the pandemic. So, and then I think your previous speaker talked about microchipping. There was this idea that if you were going to have the vaccination, it was actually a microchip, and you shouldn't have it. So there is something about definitely mistrust, but learning from it is really thinking about how do we regain that trust. And the only way we can regain that trust is through evidence-based, and that's what we need to kind of convince the communities to say, X, Y, and Z. But I think what we mustn't forget is the stark inequalities we saw around ethnic minority groups, and this was across the globe, not just the Yemen, but even in the UK, we saw our colleagues who looked like us who were the first to die. Healthcare professionals, nursing staff, doctors who were the first to die. So there was that increased hesitancy amongst professionals, healthcare professionals around vaccinations, and if you recall, for those of us who reside in the UK, the expectation was that it was going to be mandated, and the NHS did a full U-turn, didn't they? After certainly the ethnic minority groups, really pushed back and said, well, hold on a minute, we don't have the evidence for you to give us the assurance that actually it's safe and we're going to be okay. So we need to learn. We need to learn from that. And the last thing I would add is around poverty. So I think the last speaker talked about having access to mobile applications to be able to get the right information. If you've only got TikTok and WhatsApp, then that's not enough, is it, to kind of educate and stabilize the right information for people to make the right decisions about their care. So those were the things that I wanted to pick up on, which weren't covered. Thank you.
Thank you for sharing your thoughts. I think a recurring theme we're getting here is openness, evidence, transparency, and setting a good example from the higher ups, be it the medical profession, nursing, politicians, and the like. I see we have a hand up from Dr. Mohammed. Please go ahead. Thank you for joining. You're on mute at the moment, Dr. Mohammed.
Hello.
Hi, yes, we can hear you now. Please go ahead.
Yes. I want to thank each one of you for allowing us to be part of this impressive and insightful meeting. We gather some of the important information, and thank you to each one of you. Also, I want to thank Prof. Abdul Wahid for sharing with us that about your work, about your impressive lectures and everything you do. It's remarkable, actually. What I want to talk about, you can say it's more of an opinion than a question. It's about the evidence-based medicine, especially when we talk now with the emergence of new technology and the combinations and we need like the connection and the overlap with technology and medicine. Also, Dr. Omar talked before about it and mentioned telemedicine. It's important to use the evidence-based medicine to avoid the errors, to avoid the medical's faults in terms for providing the optimal care and optimal treatment. When we want to diagnose or we want to use the appropriate and the cost-effective also in terms for intervention to the patient. In terms for the prognosis, in terms of the BICO method for the patient intervention with the comparator and the outcome. Yes, so the outcome. It's not about the evidence. We can gather more evidence. We have the members who will do the evidence, will do the research, but I think it's more of a conflict between the old medical staff and the upcomings, the youngster. They tend to look at us that we belittle their clinical experience, that we use some kind of epidemiological garden and statistical sleight of hand, when in fact we try to use the up-to-date evidence to deliver the most effective medical intervention. That it goes from the diagnosis, investigation, treatment, the cost effectiveness, and the outcome should be beneficial for both of us, as the doctor and as the patient also, so that we don't fall to another medical errors and to another like disabilities or death. We try to minimize the risk, and I want to shed light. I wanted to shed lights about how we can use it without causing problems with the old medical staff, and use it effectively. that we encourage students from other specialties that they be using IT, information technology, or health informatics. Also, how we can form a bridge that with technology and medicine that cannot be faced with opinions and the problems and conflict, and to use it for the good, for all people, especially for the workers and for the patients, for everyone. Also, how to implement these despite the difficulties for in terms of the ongoing war, the dire circumstances we live in Yemen or any other underdeveloped countries. So we can use it effectively, start work without any delay, help other people who want to like open a door for other people who want to help us use this kind of thoughts. And that was my you can as I said, it's more of opinion than a question, but at the end I want to thank every one of you, and I hope I delivered some understandable statements. Thank you all. Thank you all.
Thank you for sharing that, Dr. Mohammed. Julian, if you've got some viewpoints to share, please go ahead.
So I'm just curious, just going back to the presenter who talked about digital health. I don't know if he's still online, but I asked this question kind of in the chat. If you go online and you discuss with a patient some distance away about a diagnosis, and you find a diagnosis and you want to prescribe something for that patient, at the moment in Yemen, how would you actually practically do that? So you can make a diagnosis online remotely. You can't send the drug down the line. You have to get the drug from somewhere. Where would you actually get the drug from if you needed it in that kind of situation on the ground in Yemen? And this is to all the people who are based in Yemen who have worked in this environment.
Yeah, maybe someone from Yemen. I'm in Yemen and I work for sometimes in Yemen, but unfortunately, the patient record is not really kept for long, and it's not really electronic actually in the hospitals and primary healthcare centers. So it's hard to recall some recall some information for your patient even. So you have to go back to the file and paper in the archive if he was admitted in the hospital, but it's not also registered or during the follow-up visits or to monitor the progress of the case afterwards. So need to have such information system is weak regards the patient's registry. I think Dr. Khalid Remy wants to add to that.
Yes, please. Go ahead.
Yeah, if you allow me, just this is really very scary things, and because digital health is a good things to talk about. But when you talk about Yemen, we need to look at it in a context specific. We are not ready to go far away that we can diagnose the patients remotely, but we can advise. Then I would suggest if you're gonna consult patients remotely, especially in Yemen, about 70% of the population in rural area, and assume there is a good connection with the internet, and you can speak with the patients, I think I will not go further to diagnose and prescribe treatment, because here, as Dr. Fakri said, we're going to document this history. There is no electronic medical record. But what can we do? We can give advice that say, okay, you are in an early stage, you need to see your doctor. So we can use this digital health as one step to improve patients, to move from being suffering in silence, or being hesitant to go because lack of access or lack something, and we create a momentum awareness that it's your responsibility or your family to try their best to take you to the doctor to be diagnosed, maybe to prescribe further test. But to diagnose 100% online in Yemen context, I think it's not applicable, and we should avoid what's called medical errors and safety issues. There is a lot of things. This is why digital health, it's not one size fits all. Yeah, it is a solution, but each solution should be context specific. Take in consideration illiteracy, access to many things, misinformation, etc. So to answer the question, where they can get the prescription, I think we are not yet in the level that we can describe medication or anything. And personally, I will not recommend to prescribe any medication required prescribed from doctors without advise patient to see their doctor physically. I think this is my perspective on this, and I hope it answered partially the question.
And another issues also related to the pharmacy in Yemen. The patient can go to any pharmacy and get medicine without prescription, and even the pharmacist can change the drug the medicine for the patient if it's not available if you prescribed it. So there are many issues regard that, and also the ethical things.
Yeah.
So can I just ask a follow-up question, Nick? I was in Africa many years ago, Kenya, Tanzania, and I walked into some pharmacists there, and they had boxes of drugs with familiar names on them. But I know from some of my microbiology colleagues that some of those drugs are not real. So I'm assuming that that's a similar kind of problem you might get in Yemen, where the drugs that you pick up from the pharmacy or the hospital, are they how real are the drugs? How reliable are those drugs? And how do you know they're actually not fake drugs in a way? Is that very widespread in Yemen, as it is in some other countries?
Yes, especially this time during the conflict, there is no strong monitoring from the central authorities.
Not only this, just because you are in a scientific day, about 1 year ago, there was a huge, big mistakes patient given in a hospital and wrong medications, and kids their first 5-6 years they died because of wrong vaccine. So even those medications that are in the government, sometimes they end up are the wrong medication because of many factors. Some of them are smuggled. We don't know actually who is the importing this medication. We find the medication as maybe see it in Africa and the shelf of pharmacy, but if you go to the supply chain, you find a lot of big questions in the supply chain managements until it end up in the shelf. So there is no rigorous system in place to secure quality and safety of medication or in general medical device as well. So I can agree with you that Yemen is not exceptions. You find some fake drugs or something expired drugs, etc. Because this is the reality.
Thank you. Ofra, you've got your hand up.
Yeah, thanks, Nicholas. So I mean, it's an observation that I made. So last week I was in Finland, and I was probably the only Yemeni nurse in an auditorium of 7,000 nurses. And I think there is something about a shift in the policy within the Yemen, specifically for nursing and midwifery staff, and I liken it to potentially what nursing used to be in the UK many years ago. In the UK we have advanced practitioners, we have enhanced practitioners, we have consultant level nurses, and at the moment my understanding is that doesn't exist in the Yemen. So there is something about creating that space for nursing and midwifery staff to release potentially capacity for the depleted numbers of doctors within or medics within the Yemen. And I just want to pick up on one point around intervention. So I think, you know, I have family in the Yemen, and we talk often, and one of the things that I think fundamentally needs to be done in a way that really does empower the communities is the basics around public health.
Right.
And spotting signs. You know, people tend to present when it's too late. You know, so if a woman presents, you know, she's very late stage breast cancer. You know, there's no screening programs, but actually there is public health that can be done around, you know, what to look out for, and that goes for other things as well. So there is something about, and I think somebody mentioned it earlier, around, you know, public health initiatives and a real focus on that, which can be really driven. I do believe that it can be driven by nursing and midwifery staff within the Yemen, and then that empowers the communities, you know, really gets the elders on board, really gets the children within the communities thinking differently about their own health and well-being. And just to finish, and I'm not sure whether this was discussed throughout the day, because I came in a bit later into the Zoom, but mental health is very rarely talked about in the Yemen. You know, we know that the pandemic really affected people's health and well-being and mental health, but I rarely hear that in my own community, and them talking about the anxiety that they face and the mental health that they've subsequently faced. I think your previous speaker, or your last speaker, touched on it briefly. But yeah, that's all I wanted to say. Thank you.
Thank you. All very valid points. There was a session earlier on in the day regarding mental health in Yemen, but the point bears repeating. It shouldn't be underestimated, even as we're dealing with all these physical health problems. I suppose a perspective we can share, no matter what resources are available to us, or it's harder for the general public to think about prevention when there is a clear and active problem staring them in the face right now. Prof. Surimi, you had your hand up first, and then we'll move on to you, Julian.
Just to respond to the sister Afra, I totally agree with her in Yemen in terms of what's called the human resource crisis, which is really a number of doctors and nurses to the population is under crisis, is less than 0.3 or 0.5. We need what you call a policy task shift. We need to shift task performed by doctors to nurses, and from nurses to midwives, and midwives to community. This is really a business model be used somewhere, and it's very effective. The question is, the critical issue is going to be how to have a close supervision about these people and to see where is the limit. Because the problems, if you don't know your limits and the community will put pressure in you to exceed your limits, then you start causing harms rather than giving care. I'll give you example. If you are a doctor and you work in your clinic and the community pressure in you on antibiotics, and the symptom is viral, we don't need to give them antibiotics, but they put pressure in you until they get it. Right? Imagine a community worker, she works in the community and she has a diploma or something, and then she did something good, and then they start dealing with her as a doctor. And they amplify her with the name Doctors X, Doctor Y, which is not a doctors. And by psychology, she start crossing the boundaries. In terms of the task shifting is good, but should be a policy developed and linked with close supervision and close guidance and advice to make sure that everyone is doing the right things right and we are not cross our boundaries. This is very critical in healthcare because there are some mistakes we might make and we end up with a disaster. This one thing. Another thing is the community itself. Unfortunately, in Yemen, and this my belief in, we are adopting Western approach in a way population concentrated in urban area. We need to invent our other way. It should be rural-based healthcare system. Our health system in Yemen, majority are in the rural areas. Unless we direct resources, even limited resources, to start from the rural areas, move up, things will really remain untouchable, because you cannot make any change in infant mortality or maternal mortality without targeting public health, as you said, or population health in the grounds. So people are waiting until they get sick. But if they have been promoted, educated about the risk factor, how to behave, what to eat, starting from the school, from the community, I am sure things will be different. So my suggestion and really recommendation in such kind of this meeting, you should advocate for rural-based healthcare for any population, majority of them in rural areas. Also, we can work about shifting tasks among health workers, but with close supervision and close guidelines. Thank you.
Yeah, just to add to you, Dr. Khalid, there is, I mean, job description for the nurses and community workers. However, the compliance and to that guidance from the Ministry of Health is weak, and each one doing whatever they want, and no accountability to that. So yeah, there is, but it's not followed.
No. I mean, we have discussions about scope of practice and limits on what various practitioners can do in the UK as well, but if it can't be enforced in any way, then it doesn't get you very far, unfortunately. Julian, you had your hand up next, and then we'll move on to Ofra.
Yeah, so just on the same theme, I just want to ask Ofra, actually, what is the minimum training period for nurses to work in Yemen? Because the first presentation actually was on the field epidemiology training program, where they had just 3 months for a junior field epidemiologist, going up to 2 years for advanced trained field epidemiologists. So if you need nurses quickly in Yemen, what's the minimum training period you would recommend or exists for them at the moment there?
So, so globally, we have a real shortage of nursing and midwifery staff. So it's not unique to the Yemen. We do have a real problem around recruitment, but also retention. And we've got an aging workforce in the nursing and midwifery world. So it's not just the Yemen, although the Yemen has got its problems. So in the UK, it's a 4-year degree program, and that changed a number of years ago. And we are regulated by the Nursing and Midwifery Council. So I'm not sure whether the Yemen has the equivalent. I don't think you do, which is, the professional nursing body, which basically ensures that, or should ensure that, you're sticking to your scope of practice, and that you adhere to the number of practice hours, and that you are a safe practitioner, because you have to revalidate every 3 years, as doctors do. I think annually is my understanding. So, professionally, I think that 3 to 4 years is the standard practice. I know in other Arab countries, it's 4 years. So if I think about my Palestinian colleagues, it's sometimes it's 5 years, because they go to postgrad level. And it shouldn't be shorter than that, is my view. But if you haven't got the lecturers, if you haven't got the education establishments, if you haven't got the trainers to do that, then that's going to be really difficult, not only to deliver, but also to, I think the previous speaker said, around supervision and regulation, professional regulation. And that's where you start to get the gaps, and potentially it becoming more of a risk than certainly something which is a positive step. Yeah.
So just to give you some contrast in that, actually the revalidation in the UK is 5 years, every 5 years for doctors, but we get annual appraisal. When I was working in Hong Kong, we went to China, to a rural area in a place called Santao, and they were getting 3rd-year medical students in as house officers in some of the rural country hospitals, because they had no doctors. So that's basically like the 1st-year clinical training year in the UK, going onto the wards as house officers, because they just had no manpower. So that's not ideal, but in an emergency situation, I guess as long as they're well supervised by their seniors at that point, I'm wondering whether nurses in Yemen might do the same thing. Now, I actually work very closely with the midwives in my current job. I do a lot of viral infections and pregnancy. Probably about 70% of my work is that. So I know the midwives very well, and I know that the training is extensive. You don't need the midwife level of training to do some of the basic stuff you see that's required in Yemen at the hospital level, even just admissions and triage, for example. So that could be one way to, if you like, shorten the training to apply the manpower that you need with training, to follow on the job. So it's really just my experience. It's not a virology question, but it's just something that I thought about once you were talking.
And I think, sorry, may I come in, Nicholas? I think it's about the model of delivery. So you've got different tiers doing different interventions. But we've seen some of that in Gaza, where we've got third-year students, I know for a fact, having to work in ED departments and actually be faced with things that they would probably never have seen at all, and actually having to do things that are completely out of their scope of practice, but they don't actually have a choice. So the model of nursing delivery probably needs to be explored further, where exactly what you said, Julian, around the tiers, where you've got support staff or community staff doing their bit, and then more advanced, enhanced and consultant level nurses doing the more higher, certainly higher interventions, clinical interventions.
Sorry, Julian and Offer, just to give you a background about the nurses credentialing in Yemen. We have the different tiers in a way. As far as I know, when I was in Yemen about a couple of years ago, we have a diploma nurses, which is 2 years after middle school or primary school or high school. And we have a bachelor of nurses as part of the College of Medicine. It's called College of Medicine and Health Sciences. We have that levels, and we have every couple of universities in Yemen, they have this kind of degree, and every year they take intakes and the graduate nurses. The question is, the problem with us in Yemen is most of the graduates, they end up working in the cities, which is in the capital cities like Sana'a, Aden, and this, what I said, it's not the majority of population. So we didn't see this kind of impact of nurses. But the good thing is those who are graduate diploma are in the what you call it health institutes, and each governorate in Yemen, 23, have at least one higher institute, and the graduates, diploma nurses and diploma nurses, diploma in midwifery, diploma in medical assistance, all these paramedics or lower than bachelor are there. But the question is, the value of this graduate are not there. Either they end up not working, or when they graduate, they do something different, because there is no such kind of opportunity for them to be employed. And the health system is not structured around empowering primary care center in the rural areas. All the health workers, whether even diploma, they go to capital and work at there, even though they should not work in the tertiary hospital, but because of the opportunity, high income or high salary. So the question is not only about we have the degrees, we have the curriculum, but it's about how the production side, which is the university and health institutes, align with absorbing this from the Ministry of Health and Ministry of Finance and Ministry of Labor. So we need more than stakeholders who can work around these issues. It's not all about producing health workers. The question is, who can observe them in the health sector in the reality? How the Ministry of Finance will create supporting to employ them, how the Ministry of Labor will create what's called a civil position or post for them. So there are a lot of layers need to complete each other. Otherwise, we end up in the vicious circle. Just to give you a background about how the program look like, we have these degrees, but unfortunately, it's not functioning.
Thank you. What about Salim? You had your hand up. Would you like to give your opinion?
I can here intervene. Yes, thank you for the fruitful discussion. Just I want to add something about the training of the nurses and midwives in Yemen. Now there is faculties for, bachelor degree. Belong to the universities. At least to my knowledge, we have faculty of nursing in the University of Aden, as well as faculty of nursing in the Hadramaut universities. The problem is some of them mentioned by Dr. Khalid. The student mostly of nursing that we at least having in Aden, mostly the students are from the rural areas, and then they come to Aden and stay here in Aden. Another thing that it is surprising to us in the University of Aden, that the majority of students are males, not females at all. For example, at the first and second and third batch, they are only 5 student women, females. Suppose that the others are around 40 males. This is another thing. It should be sometimes the opposite, that females more than males, but we have, and many girls are reluctant to, enter in this situation. Another thing regarding the training of them, we have very few, teachers or teaching staff, as we said in the universities, that having PhD. So we have only 3, 4, 5 only having PhD. As you know, this is academic level, and we should have such, degrees in the university. So some teaching staff coming from Hadramaut, because 3 of them are in Hadramaut, come to Aden, and this in unsuitable situation, salaries and teaching, and the things are, barely going well. Another thing that I know about the midwifery. Now the Faculty of Medicine, Faculty of Nursing in Aden is also thinking, and we have some plan to have a midwifery bachelor degree, but still at the beginning. So now I am leading a project for the, upgrading the midwifery, what we say, the technical midwifery, degree at the Institutes of Health, Nasher, in Aden. But we have difficulties. There are a lot of things happening, but as Dr. Fikri said, many things are in papers. For example, the strategy of midwifery. It is a nice strategy. We updated. We are, working according to the International Confederation of Midwifery. But at the end, the reality is something else. About task shifting, we know that midwives doing a lot, especially in rural area, that is out of their, scope of or the job description. But we want to have this in the curriculum, but we have many things limiting us. So we are now working heavily in the area of improving the midwifery training and the nursing training at the level of bachelor, and hope in the future also we will have the midwifery also bachelor degree in Yemen. Thank you.
Thank you for sharing your on-the-ground experience. We're nearly out of time now, so Ofra, we'll give the last word to you. Closing comments, please go ahead.
Thank you, Nicholas. It's actually quite refreshing to know that more males are going into nursing in the Yemen, because in the UK it's a female-dominated profession, and it's actually an observation that I've made in some of the Arab countries. So places like Lebanon, Palestine, I've been doing a lot of work in Palestine. The majority of nurses actually are men, and Egypt. So I think that's a positive thing, but we need to kind of ask the question as to why the women aren't seeking it as a profession of choice. But it was just that comment around male nursing staff. I think that is actually a positive step. Thank you.
All right. I think we'll have to move on and allow the next talk to progress now. My thanks to all members of the panel for sharing your insights and asking some very intelligent questions, as well as to everyone in the audience who shared their experiences and prompted further discussion. It's been a really excellent session. So we will hand over to the next speaker now imminently. And I'll thank the organizer for this conference, Dr. Mubashir Chaudhry, for his efforts as well.
Hello. Assalamu alaikum. Hello, everybody. It's a pleasure to be meeting you all today and to present about the INTERYem RIMS project. So I'm Sara Al-Saqaf. I'm a Yemeni doctor and I have the Masters of Public Health, and I'm a candidate in the Masters of Family Medicine at the University of Edinburgh. And with the INTERYem, I'm a project support assistant. I will start with the agenda of the INTERYem RIMS story, which was a concept and then became a reality. So I will start with the background and then move on to the aim, then the outcomes, the project methodology, my role as a project support assistant, tentative and actual timelines, and challenges and solutions of the project, contributions and future plans. So there is significance of healthcare professional remote mentoring. So Yemen, as you all may know, has been trapped in a conflict that fragmented the fragile health system. And one of the things that frustrate Yemeni healthcare professionals might be the lack of mentorship opportunities. Mentoring has always been shown to provide support for mentees and their well-being, and to create opportunities for networking and career development. One study indeed revealed that remote mentoring was promising in providing resident doctors in inaccessible settings with accessible and fast mentoring that helped them improve the patient outcomes. So the aim of this project, first of all, RIMS is an acronym that stands for the Remote International Mentorship Partnership Scheme. And the INTERYem RIMS project aim was to provide remote mentoring to healthcare professionals in Yemen via UK and worldwide based healthcare professionals and university professors in fields related to health, for example, psychology. The outcomes were to recruit at least 5 mentors and at least 5 mentees with respect to priority health areas in Yemen that are primary care, women's health, mental health, infectious diseases, and public health. These mentors and mentees would meet at least 5 times between the December 2024, which marked the launch of the project, and May 2025, to discuss the challenges and the possible proposed solutions during their mentoring journey. They would meet through synchronous and asynchronous means, and I will come to that in a minute. And then the INTERYem would provide training sessions, record these meetings, and share them with the Global Health Partnerships, which is the funding organization. And the mentoring relationship will continue for at least a year. So the methodology was, the stakeholders were, of course, INTERYem, which considers the RIMS as a pilot study for a long-term INTERYem mentoring scheme, whether or not it will be viable in Yemen. We have the official partners in Yemen, Dar al-Shifa Hospital. Then we have the Global Health Partnerships, formerly called THET, or Tropical Health and Education Trust, which is the funding organization. We have Dr. Helen Crowley, who is a PhD candidate in Oxford Brookes University, and she hosts sessions on remote mentoring and its related challenges. We also have the mentors. We had 6 mentors, 5 males and 1 female, 5 UK-based and 1 Kenya-based. We had 5 medical doctors, 3 general practitioners, 1 psychiatrist, 1 infection disease specialist, and 1 psychology professor. The mentees were 6 too, and they were mainly 3 males and 3 females. All were Yemeni, but 5 were Yemen-based and 1 was Egypt-based, doing his training in neurology. We had 2 general practitioners and 3 nurses. So the process, in brief, went like the recruitment of potential mentors and mentees through the INTERYem email list and through extensive network of INTERYem. I sent emails to participants to explain the process of mentoring project and the methods of mentoring, which is synchronous, the Zoom or other video conferencing platforms, and asynchronous, the email and WhatsApp for more immediate responses or simple chats. And then I did the matching by sending the forms to the mentors and the mentees. And then we had 2 types of meetings, the meetings between the mentors and the mentees, at least 5, and then the training sessions, which lasted 2 hours each. So we had 3 training sessions with the trainers who were mentors themselves, Dr. Nancy Redfern and Dr. Tay Shiraton. Kindly came forward to do these training sessions. This session were generally an introduction where everybody introduces themselves to everybody. And then we had a general introduction to the concept of mentoring. Case scenarios were presented and a demo was done by the trainers. And then the participants practice, if you were a mentor in that scenario, what would you do? We had breakout rooms, mentors and mentees would discuss their perspectives on mentoring. And we had 3 training sessions. And of course, there is planning and organizing the training sessions and sending the reminders 4 to 6 weeks prior to the anticipated day of the session, and then sending reminders 1 week, 1 day, and 1 hour to the mentors and the mentees and the trainers. After the training, there was a post-training survey, which were 2 questions: what went well during the session, and what are you going to change for improving the next time. These were used to taper the training sessions to the needs of the participants. So my role was actually divided into 3 main phases: the pre-matching phase, which is actually the preparatory phase, the matching phase, and the post-matching phase. The pre-matching phase, I got to know the stakeholders and other partnerships working in remote mentoring in Yemen, and I did the recruitment of the mentors and the mentees. In the matching, I had to read extensively into the literature because we had a very small pool of mentors and mentees. So successful mentoring relationships require a compatible matching that incorporates the mentor-mentee involvement, personal qualities, and developmental needs, and not only the clinical specialty. Well-matched pairs will contribute to positive outcomes of the relationship, satisfaction, and lower dropout rates. And the INTERYem actually did this, which is mentor guidance through training sessions to become a more fruitful relationship. So the matching process was based on these criteria: personal qualities, main career challenges of the mentees, and expectations of mentors and mentees from this remote mentoring project, and these were incorporated into the matching forms. In the post-matching phase, I did the organization and attended, recorded, and sometimes facilitated introductory and subsequent training sessions. I followed up with the mentors and mentees, replied to project-related queries, distributed a handbook after the introductory session. You can see here the cover of the handbook. It included roles, responsibilities, and expectations of the mentors and mentees. I gathered minutes of mentor and mentee meetings to know about the challenges that they are facing and how they were able to overcome these challenges. And this is my current task now, writing up and analyzing the data to prepare the final project's report for the Global Health Partnership. And then came the post-project evaluation, which I did the first part. I shared a questionnaire with 20 questions via email, where the mentors and mentees in May 2025, and I gathered the responses. The main aim was to improve subsequent similar projects by knowing the experiences of the participants. So we had a dropout rate.
Sorry to interrupt, Sarah. If you click on the slides, because we can only see the first slide.
Oh.
Yes, yeah. If you go to presenter mode, yeah, that's okay. That's okay. If you go to presenter mode, then We only saw the first slide, but that's fine. Just carry on where you are. From there, yes, start slideshow and start from where you are. That'll be okay.
So can you see it now? Can you see the slide?
We can see this. This is slide number 22.
Yeah, you can see the slide now. And this one?
Yeah, but it's not a slideshow. If you click on slideshow,
it is the slideshow. Yeah.
Click there if you can.
Start from the first slide. You can see them now.
Okay, if that's in that case, just
what about now?
That's the first slide. What you could do, you could just click as you go along. Every slide, just click on the left-hand side of the screen on the thumbnail.
Oh, okay, I'll do it the traditional way. Fine.
Yeah.
So can you see it now?
That's now slide 21.
21. Yes. So is it clear now? Can you see
Yes,
it
we
clearly?
can see that.
Yeah.
Yes.
Thank you. You could have told me earlier. I would have done that. Sorry for the mishap. I'm here in the post-project evaluation. The second part of the post-project evaluation is the post-project qualitative evaluation. So we are intending to interview mentors and mentees who are willing to get more in-depth insights about the mentors and the mentees' experiences throughout the project to further improve the similar projects in the future. So I had a timeline, which was a tentative one. I started recruiting the mentors and mentees in July. And I shared this with the INTERYem team. Dr. Mubashir Chaudhry was involved too. And I set up the timeline to, according to the first submission deadline was late March 2025, and I also aimed that we will have 5 training sessions. However, the actual timeline here, I started in July. However, the recruitment ended in late October 2024. I'll come to that in a minute. And I did the matching in late October 2024 to late November 2024, and then we only had 3 training sessions due to the overwhelming duties of the healthcare professionals who were the mentors and the mentees and the trainers too. As I mentioned before, in May 2025, I sent the post-project survey, and now I'm doing the write-up and analysis to be shared with the GHP on the 30th of June. So we had our challenges. One of the main challenges was the shortage of mentors and mentees during the recruitment phase. The first reason was that when I started sending out the emails I sent out more than 500 email addresses from the INTERYem list. However, I only got 7 responses. So I reached out to the INTERYem team, and they provided me with the extensive network of the INTERYem colleagues, and I also suggested that we use the LinkedIn account connections. And it worked. We had everybody on board. The second challenge was partially related to the first challenge, and that delayed the launch and submission. So the second reason for the delayed launch and submission was that communications take time, especially with healthcare professionals. I only did a follow-up gentle messages, and it turned out to be effective. We did some contributions. The INTERYem LinkedIn network is growing. We have 250 plus followers so far, and there are people who are interested to become mentors and mentees are reaching out to us. These are the, I hope these are clear. These are 2 photos from 2 training sessions with other colleagues and the trainers. And I also contributed to our organizational framework that will be published as a supplement to an original article written by Dr. Becky Self, who is a RIMS consultant. And I shared it with the wider audience. I shared the summary that everybody contributed to, who were working in remote mentoring in different settings on my ResearchGate account. So what are our future plans? We aim to present the INTERYem RIMS pilot study in national and international conferences. We aim to publish the study in relevant peer-reviewed journals. We are also learning from the INTERYem phase 1, RIMS phase 1, and we're scaling up the project after the pilot study analysis. We will also be seeking new mentors and mentees who may benefit for the second phase RIMS, which is a wider project. Please do get in touch with us if you are interested at communications email. These are the references, and thank you very much.
Thank you very much, Sarah, for this thorough presentation about this ongoing project, which will be a milestone for more to come.
Yeah, inshallah.
Inshallah, yeah, exactly. Does anybody have any question about this particular project before we move into the closing remarks? So yeah, it's a few comments, and we have some people interested in becoming mentors, which is great.
Yeah, it is great and very encouraging.
Great. Does anybody wants to contribute by raising their hands? Yeah, we've got a few hands. So, Dr. Tong, if you want to come in, please. So, Dr. Tong, if you are.
Yes, I'm kind of curious about this. I saw this earlier, but you need a certain level of lab data for virology. So I'm wondering what kind of projects you actually have mentored or have had mentored before. Did you hear me? So I'm just wondering what kind of projects do you normally involve with mentors in this program?
Yeah, so Sarah will probably, yeah, you can take this one because you're very hands-on with these projects.
I'm sorry, but I really don't get the question. Could you please repeat it?
So the question is, what kind of projects are the mentees working on?
It depends on their expectations and what they wanted out of the remote mentoring project. It's a very generic project. So, for example, there was a mentee who wanted to learn more about clinical research. They were matched with a mentor who is in clinical research and whose qualities are close to each other. So that's one thing. So it's not something that is like one size fits all, if I can say that, but it is like a much more of a generic remote mentoring project. So they have their expectations and they were matched, and then they can work out what they want out of this project together with their mentor.
So it's not really.
Yes.
It's not a traditional one. It's kind of like a new way of approaching mentoring. And probably that was a challenge for me at the beginning, but later on it turned out to be, to be beneficial for those who were involved.
So just kind of to follow on from what Sarah mentioned, so the aim of this mentorship project was not the project themselves, but is rather the process and building the platform, which will then feed into mentoring specific projects, matching them with interested people in that specific field, which will be tailored to the need on the ground. But for the time being, we just kind of, going through the process, the contacts, building up the process itself. The current mentees and mentors are matched with aspirations of the mentees and their requirements. So we left it as that rather than deciding on the projects and then trying to find people who would be interested in those projects. I hope this answered the question. and we're really grateful if we have we will, I'm sure, have virology based projects in the future, and great to know that you'd be that support us. Thank you very much for your initiative. Dr. INTERYem has put his hand up. If you would like to come in as well, please.
Yeah, thank you, Dr. Wahib, and thank you, Dr. Sarah, for this nice presentation on mentor projects. I like the idea of mentor project. This is where we can do while we are away from Yemen. Mentoring is really easy, can be done. But I reflected in your presentation that, and I put in the chat a suggestion that we need mentorship to be multidisciplinary approach, because in healthcare we work in silos, right? We need to build the capacities in Yemen across all different health workforce. In other words, we need to come up, for example, an initiative from INTERYem saying, okay, we are adopting mentorship program or projects, but we need to be different from others. We need to create a team, for example, team of physicians, nurses, lab technician, public health administrator. See, this is a team that at the same time, they might work in a common project, common problem from different subject matter experts. And we align them with mentors who really interested to help them. And then we create a business model that's we can work as a team. Because this is what's missing in Yemen, actually. Each one works different from others. So we need to create a successful story that we can work as a team from mentorship point of view. If we succeed in this, we can work as a team in the reality. So I'm just proposing an idea as to what extent we can create a team-based mentorship program rather than an individual's mentorship. If it's really worthwhile to be discussed, we can discuss it further, and we take it further to other levels. Thank you.
Thank you for your question. So, in my opinion, I still don't have the answer to your question, how successful it is to build a team-based. Probably Dr. Wahib is much more equipped to answer this. But in this pilot study, what I really liked in the project is that when people get what they are expecting, or they are along the way and they are supported by a person who is open to their ideas, and regardless of the clinical specialty, we're talking here about a generic idea, like what you said, it's a multidisciplinary team. So it is something that needs to be normalized in medicine and in public health. So this is what I really liked about this pilot study. Dr. Wahib, if you want to add something.
Yes, thank you. So exactly, this is the first pilot study that we kind of allowed for a lot of flexibility, and we just do an individuals. This allows us to learn quickly, get the feedback, establish the platform, and then be able to scale it up. And we are very ambitious to get involved with projects that meet specific needs, and also team working as well. So thank you very much, Dr. We'll definitely take this on board. And that's why we present in this talk in such a conference at the end of the day, because a lot of people have gathered many ideas and many, and we've heard of many interventions and impactful topics. So when you hear about what we are doing, you then are able to be the other pair of eyes that can feed into what we are doing and give us suggestions. Really welcome that. So we are very close to ending this project, and then we will share our findings and what we're going to do for the future in our next event. And we have Afran Maflahi, she's also put in her hand. Yeah, please come in.
Are you asking me to come in, brother? Yes?
Yes, of course.
Okay. Shukran, Dr. Sarah. Fantastic presentation. Thank you so much. Mentorship isn't a new concept in nursing, and it's something that can be expanded into nursing, both nursing and midwifery, actually. Is there scope for that to kind of, we talked about it a little bit, is there scope for that to be, expanded to nursing and midwifery, and perhaps thinking about some global connections, because it's a concept which is very firmly embedded in the UK, for example, where there may be some additional support to kind of expand it into nursing and midwifery.
Yeah, thank you very much for your question, Afra. It was actually open for all healthcare professionals, but the people who were on board this time were the mentors were all doctors, physicians, and we had 3 nurses from Yemen who were mentees. So it was open for all healthcare professionals. So I guess if Dr. Wahib has to say something, please do. But I think it will be open for all healthcare professionals and not only physicians.
Exactly, 100% confirm that. So all our projects and all our events are mixed interdisciplinary focus. So yes. And then Dr. Khalid Sraimi.
Yeah, sorry for being talkative today about in this meeting, but we would like to share our thoughts. I would suggest, mentorship is really very instrumental things for Yemen, and but my suggestion is how we be strategic that we try to select people from different governorates, from different districts. We build the capacity on the ground because we don't want to end up realize later on it's come from one part of the country or only from Sana'a or from the area that really have something enough or something not enough, something there. I would suggest from interim perspective, if you can really come up with at least in the first round, 50% of the governorate or district has been covered, and then we take it further and further. And then those who are already mentees, maybe they become mentors later on. So this is what I'm thinking of how we can build the capacity from within, even during selection. And we will think together about incentives, and we're more than happy to contribute in this way, just to build the capacities in our countries. So either with our time or with our resources, we'll find a way. So, for example, if there is a person who need to be a mentees from X governorate, they don't have, for example, subscription for internet, we can support him or her with this kind of having a modem or internet access for 6 months. Personally, I can contribute to pay this for 6 months from one disadvantaged governorates. So at least we create a momentum that if you seek for knowledge, we are here to help. And we don't want to end up only focus on those who are already on some level. We need to go to the level that really can make a difference. This is suggestions if it could be considered. Thank you.
Thank you, Dr. Khalid, and your suggestions are very more welcomed. And we actually selected mentees from different parts of Yemen. It was open for everybody. And we have the mentees were from different parts of Yemen. This is a small pilot project, so we only needed at least 5 mentors, at least 5 mentees, and we had the time frame given by the funding organization, which is a very small grant. But thank you very much for your suggestions, and thank you very much for your cooperation. I'm sure that the INTERYem will be very happy to incorporate them into the wider project. Dr. Wahib, if you want to add something?
Yes, I thank you very much. For some reason, I just got muted and I couldn't unmute at all, but I'm glad I'm back. Yes, exactly. So it's all in the pipeline, and we kind of building on this experience, and this is what we're going to refine as we go along with the project. Well, I'd like to thank everyone for their contribution today. Everyone has been excellent. The interaction is really, really a testament to the passion of everyone involved and the dedication for helping people in Yemen. We've had international faculty who dedicated their time, especially on a weekend, to come and join us for a long event. Thank you very much. Special thanks to everyone. And we've had the guest speakers, and we also had the attendees. Everyone has been amazing. And also for INTERYem admin team in the background, and Bashar for organizing this and setting the logistics around it. We've had over 50 attendees for today's event, which is excellent. And we hope people who attended found it useful. Please remember to fill the feedback forms, which will be shared with you shortly about the event. We use this feedback to learn about how the event went and learn about the good things that we can continue to do and anything that we could do better for the future. Also, the feedback forms are linked to certificates. So once the feedback form is sent, you get automatically sent a certificate for attendance. Just to kind of wrap up and summarize, it was really, really holistic conference. We learned about the tragedy of conflict, politics, and chronic diseases, and the need for planning and cooperation. We learned about good practices in those environments, for example, the Health Remote Initiative against Corona. We learned about the epidemiology training projects happening in Yemen, how we can build on those further. And we also learned about the capacity building, which is what INTERYem is all about, and how we can get Yemen to be less resilient on the outside bodies. We learned about the importance for motivating staff to self-develop, motivating staff to remain caring and compassionate, motivating staff to feel empowered by giving them the training skills they need. We also want to empower people so they don't feel the need to leave Yemen, especially doctors and nurses and healthcare